We are live. Doctor, you may start. We are live. Doctor, we are live. You can start.
Good morning, friends. Myself, Dr. Surekha Mende, President of IMA KHAMGAON branch. I welcome you all in today's webinar KGCON-2022. Dream comes true. I am feeling proud to welcome you all, our honorable guests, honorable CME observers, honorable speakers, honorable chairpersons and co-chairpersons, and of course, all the delegates from all over the Maharashtra. No goal is too high if you climb with care and confidence. Today, I assure you a lecture series by all predominant practitioners, teachers to update your knowledge in all fields of medicine. And of course, with 4 credit points. Please share your views and let us make this mega event a great success. It was not possible without able guidance of our Dr. Suhas Pingre, IMA President, Maharashtra State, Honorable Secretary Dr. Pate, Maharashtra State, Dr. Prakash Marathe, Senior Vice President, Maharashtra State, IMA, Dr. Uday Revanwar, First Vice President, Maharashtra State, Dr. Tapre, Medical Superintendent, General Hospital, KHAMGAON. Without technical support, we cannot even think of carrying out this event. So I am very much thankful to Dr. Jignesh Taswala, Maharashtra Ophthalmic Society President, for his wholehearted support. And I also welcome our observers, Dr. Nilesh Tibdewal sir and Dr. Ajabrao Vasu. Without active participation from speakers, it was not just possible. I welcome our all the speakers, Dr. Soni, Dr. Thete, Dr. Kothalkar, Dr. Babaskar, Dr. Chinsole, Dr. Bhople, Dr. Narendra Bhagwat, Dr. Sumit Agrawal, Dr. Vivek Tadwalkar, Dr. Khatod, Dr. Tapadia, Dr. Marathe, Dr. Sor, Dr. Parag Tapre, Dr. Gaurav Ladda, Dr. Deepak Bhatt, Dr. Ashish Jhunjhunwala, and Dr. Haribhau Vadode, Dr. Amit Deshmukh, I also welcome today's chairpersons and co-chairpersons, Dr. Sandhya Nagargoje, Dr. Manjushri Tibdewal, Dr. R.K. Jadhav, Dr. Shirsagar, Dr. Haribhav Vadode, Dr. Amit Deshmukh, Dr. Parag Mahajan, Dr. Satish Gore, Dr. Anand Junjunwala, Dr. Manish Mankhede, Dr. Pankaj Mantri, Dr. Sheetal Chauhan, Dr. Tale, Dr. Pranali Deshmukh, Dr. Praveen Patil, Dr. Gaurav Goenka, Dr. Ashok Gaikwad, Dr. Nilesh Tibdewal, Dr. Nilesh Tapre, Dr. Ramesh Bhutada, Dr. Gulab Pawar, Dr. Samruddhi Mende, Dr. Ashok Bavaskar, Dr. Deepa Mantri, Dr. Sadananda Ingre, Dr. Nitin Nandurkar, Dr. Akhtar Hussain, Dr. Rahul Khandare, Dr. Gothi, Dr. Shankpal, Dr. Prachi Jadhav, Dr. Narendra Pawar. I welcome all of you on today's webinar, and with this welcome, I will hand over my speech to Dr. Anand Rathi, Organizing Secretary. Thank you.
Thank you, ma'am, for explaining our CME very briefly. Hello and warm welcome to all the delegates of KGCON 2022. I, Dr. Anand Rathi, Organizing Secretary of KGCON, welcome you all for the opening session of KGCON 2022. Hello, everyone. In today's first session, we are going to have 4 lectures. Note, Dr. Chandan Motwani sir's lecture is shuffled due to some family reasons, and Dr. Namrata Bhagwat ma'am will be giving her talk in this slot of timing 10:30 to 11:30 a.m. Kindly note. And to start with the lectures, I welcome our beloved Dr. Gopal Soni sir with the topic Peripheral Smear in General Practice. This lecture will be chaired by Dr. Manjushri Tibdewal ma'am. She is senior pathologist from KHAMGAON, and Dr. Sandhya Nagargoje ma'am. She is leading pathologist from Shegao. I request Dr. Sandhya Nagargoje ma'am to kindly introduce our speaker, Dr. Soni sir.
Thank you, sir. Good morning, everyone. I am Dr. Sandhya Nagargoje. Thank you so much for giving me opportunity to introduce and welcome a great speaker who is going to make us full of knowledge in next 1 hour about the very basic and inevitable investigation of peripheral blood smear in general practice, as sir himself is doing great job in it since many years of his private practice in KHAMGAON. Sir did his MBBS from PDMC Amravati and post-graduation MD Pathology from Tata Memorial Hospital, Mumbai, also completed DMB. After his post-graduation, sir worked as junior registrar at KEM Hospital, Mumbai and Tata Memorial Hospital, Mumbai. As senior registrar at Deen Dayal Hospital, Delhi, sir has passed PLAB and worked at University Hospital of Wales. Sir is gold medal winner in medicine, Dr. H.D. Tandon Award winner for best poster presentation at IAPM, and also Teachers Welfare Association Award winner in 1992. So ladies and gentlemen, please welcome the inspiration of all budding pathologists, Mr. Dr. Gopal Soni sir. Thank you, sir.
Recording से है क्या?
For the newly joined delegates, I welcome you all. And good morning everybody. Today's weekend, that is Saturday, Sunday, will be like great knowledge update for us. we are just going to start our first lecture. First talk by Dr. Gopal Soni sir. He is leading pathologist from KHAMGAON. And to chair this session, we have Dr. Manjushri Tibrewal ma'am and Dr. Sandhya Nagargoje ma'am.
Morning all. Thank you, Dr. Nagargoje ma'am, for your kind words. I am thankful to IMA KHAMGAON, Dr. Mrs. Mende ma'am, and the organizer, Dr. Anand and Dr. Aniket Mende, for giving me this opportunity to share my views. My topic is on peripheral smear in general practice.
Okay.
Slide में आ रहा है ना? Slide में आ रहा है। I have a topic that is peripheral smear in general practice. As you all know, peripheral smear is routinely asked investigation in the general practice. Mainly it is suggested from medical faculty and the pediatricians, and sometimes from the gynec side. We get request about peripheral smear examination. Though the test is very simple, but the outcomes are tremendous. Like it is mainly advised to evaluate the anemia. Then the second important particle, that is platelets, whether their number is high, thrombocytosis, or it is low, thrombocytopenia. The third component, WBC, their leukemias, then leukocytosis or leukopenia. Then we have hemoparasites like malaria and microfilaria. And in rare cases, we do see basophilic stippling, oil jolly bodies, that I will explain you in the next few slides. Peripheral smear, as you all know, we have two main, that is, one is thin smear and the thick smear. Thick smear now is rarely used because it is mainly for the blood parasites, but we have more sophisticated techniques like we have the malaria card, antigen cards, and antibody cards. And even for the microfilaria, we have the other sophisticated test. So thick blood film is now rarely used. We have mainly the thin blood film, and the basic steps we use to prepare the thin blood films are: first is the preparation then we fix the slide by the is the staining of the drop of blood over the slide. The ideal slide should cover the 2/3 of the slide, and it should have a head and a tail. With some minimal, can have a good quality slides, and the slide we have many more technical aspects, like the slide should be clean. It should not have oil smear or the dust, and the spreader that has its own quality. The various stains we use for peripheral smear staining are Leishman stain, Jimsa stain, Wright, Field, Jenners, and that is last one is Jasbir Singh Bhattacharya stain. But most commonly used is the Leishman stain. At some institute, people use Jimsa stain, but we use Jimsa stain for the FNAC and the cytology smears. Again, in the evaluation of the peripheral blood smear, initially I told you about we look at the RBCs, WBCs, and the platelets, and the fourth aspect is parasites. In RBC, we look at their size, shape, color, arrangement, and the inclusions. And in the WBC, mainly their numbers and the abnormal cells, abnormal WBCs. Now we first deal with the RBC, their morphology. This is a normal peripheral smear. It should look. If you prepare the slide correctly and stain it, then a normal peripheral smear look like this. The RBCs are evenly dispersed. You just see they are just touching each other. We have one lymphocyte here. I'm just and one segmented WBC polymorph is, and there are few platelets which you can see. These are the tiny platelets. These are the platelets. So ideal peripheral smear should look like this, and even a pathologist should look in this area. We should not count the WBC at a very crowded area, and even we should not look at the cells at the very periphery, because otherwise we will give a counting of the WBCs, miscounting in the sense we have more of a polymorphs at the tail end, and more of a lymphos and monos in the near the head end. So the first abnormality a pathologist look when he is dealing with the peripheral smear is hypochromia. That indicates the less staining or the paleness of the RBCs. There normally we have the normal central pallor that occupies the 1/3 of the RBC. So if it is more than 1/3 that paleness, then we label it as a hypochromia, and it indicates a decrease in hemoglobin content in the RBC, and that decrease in content could be due to, let me just remove this. Just scroll it down. Sorry for the interruption. Mainly this hypochromia is due to the decrease in mean corpuscular hemoglobin and the mean corpuscular hemoglobin concentration. And the first indication of iron deficiency anemia, we have hypochromia, and the second is thalassemia, either it is minor or major. It is very easy to pinpoint the hypochromia. You can see if you see the normal peripheral smear which I showed you. Okay, I think. Okay. This is a normal pallor you are seeing in the normal RBCs, and this is the increase in the pallor. So the abnormality is obvious on the peripheral smear. We can grade also. This is whether it is a mild hypochromia, moderate, or it is a severe hypochromia, depending on the pallor, central pallor. The second is hyperchromia, that is opposite. The central pallor is lost. Here you can see in a few of the RBCs like this, the central pallor is lost. Here it is there, the central pallor, but here it is lost. So hyperchromia, usually we don't come across hyperchromia in the peripheral smear, but sometimes it is an artifact that one should be aware of, especially the new pathologists. They should not they should not label directly as a hyperchromia, because mainly it is due to the hyperstaining of the slide. But you do get in the patients with hereditary spherocytosis, where the central pallor is lost, and sometimes in patients of megaloblastic anemia. So this is these two conditions, medical conditions, we should keep in mind. One is hereditary spherocytosis, and the second is megaloblastic anemia. This is a dimorphic where you have the picture of both microsites as well as macrocytes. Few RBCs are smaller in size. These are the micro as well as hypo. These are the microsites, and these are the macrocytes. This one is a macrocytes. So this is a dimorphic picture you get. It's a very common picture in the clinical practice, because many of our patients are deficient in both iron as well as B12 and folate. So especially patients who are coming from the gynec side, the ANC ladies who have the less hemoglobin, when we do their peripheral smear, we see such kind of picture. This is a dimorphic picture. It indicates iron as well as B12 folate deficiency. So in morphology, the first color we have discussed. The second one is the size. Normal size is 80 to 100 FL, femtoliter. Normal MCV, mean corpuscular volume. Normal size of the RBC is 7.3 micron. Any variation in the size, either if the size is less, then we call it as a micro, and if it is more, then it is a macrocytes. And if there is a variation in the size, we call it as an anisocytosis. This is a polychromatophilia. We have the different colored RBCs, and it usually these are the immature RBCs which we see in the peripheral smear in cases when there is an acute hemolysis, like in cases of G6PD deficiency patients, if there is a mass destruction of the RBCs, or if there is an acute blood loss during the accidents, or in cases of PPH, or if there is a roadside accident and patient is bleeding profusely, and if you see their peripheral smear, you see the bone marrow is acutely stimulated, and the immature RBCs, they come into the blood picture. So they are stained blue because they have the RNA content. That's why they stain blue. This is a polychromatophilia. These are the microcytes. You can see these small RBCs. Normally we compare the RBCs with the lymphocytes in the picture. Normally, normal RBC and the lymphocyte, they have the same measurement, 7.3 micron. So we compare them with the normal lymphocyte, not with the reactive lymphocyte, because the reactive lymphocytes is larger. So these are the microcytes, and again, it's a common picture in patients with iron deficiency anemia, but we do get in thalassemia, anemia of chronic disease, and sideroblastic anemia. So we always, in the report, a pathologist, when he report as hypochromic and microcytic, so that doesn't mean always it is an iron deficiency anemia. Clinicians, they put the patients on the iron tablets, and again after 1 month, if they repeat the hemoglobin, if the hemoglobin comes up, then the patient has iron deficiency anemia, and he got treatment. But if even after hematinics, if the patient is not responding, patient is with hypochromia and microcytosis, if he is not responding with the iron or iron supplements or with the other hematinics, then you should consider, am I dealing with other anemias like thalassemias or sideroblastic anemia? Because in that case, your treatment will harm the patient rather than any benefits. So you should consider hemoglobin electrophoresis and the bone marrow, because sideroblastic anemia will have the iron deposits in the bone marrow. So even in our reports, a pathologist will write down if iron deficiency anemia or a hypochromic microcytic anemia is not getting any benefit from the treatment, we should repeat repeat hemoglobin electrophoresis or a bone marrow examination. The other variation in size is macrocytes. Macrocytosis is common in our country because B12 deficiency. B12 deficiency is very common. After iron deficiency, the most common deficiency is the B12 deficiency. The size of the RBC is more than 100 femtoliter, and we get macrocytes as well as macroovalocytes. And the other thing which we look in the WBC is the hypersegmented WBCs. Here you can see the more than 5 lobes. Here there are 7 to 8 lobes. So if there is a hypersegmented neutrophils with macrocytes, macroovalocytes, reduced platelets, and the hemoglobin is less, we should consider I'm dealing with the B12 folate deficiency. Though macrocytosis is not a pathognomic or a feature of only B12 deficiency, we see in patients of liver disorders and in patients who are alcoholics. So we should keep these possibilities like myelodysplastic syndrome and these two conditions in patients of macrocytosis. After size, then we come to the shape. We come across various different kinds of shapes of the RBC. I will show you in the picture, like elliptocytosis, spherocytes, target cells, schistocytes, acanthocytes, keratinocytes, and everyone has their own importance because they guide you to look for other anomaly, other kinds of hemoglobin disorders, other kinds of anemias. This is a classical picture of elliptocytosis. All the RBCs are elliptical in shape. Normal RBC is, though it is a biconcave shape, but in the peripheral smear we see it is a round. Here they are elliptical in shape. We see in patients of hereditary elliptocytosis, but sometimes some elliptical shape of RBC we see in iron deficiency and sickle cell also. But in that case, their number won't be this much, and they will disappear in patients of iron deficiency or megaloblastic anemia. These elliptical shape will disappear. They will come to the round shape of the RBCs after the treatment. But in hereditary elliptocytosis, they will remain like that. Spherocytosis, hereditary spherocytosis, autosomal dominant conditions. The RBCs are spherical in shape. In this case, we have to rule out whether our slide is not hyperstained, and we have to ask the clinician whether there is any family history of anemia in their family. In autoimmune hemolytic anemia, AIHA, spherocytes are common. So we should keep that condition also in mind. Hereditary spherocytosis, autoimmune hemolytic anemia, they have the spear shape RBC. Target cells, though as such not of a clinical importance, but because we get target cells in variety of anemia, so they don't pinpoint to a single entity, because variety of anemia like thalassemias or simple iron deficiency anemia will have the target cells. Exact reason for the target cells is not known, but we do get commonly target cells in peripheral smear in varieties of anemia. Here there is a list like iron deficiency, hemoglobinopathies like hemoglobin H, sickle cell disease, and the post-splenectomy patient. Schistocytes, these are the fragmented RBCs, and in whatever conditions where the RBCs have a difficulty in passing through a passage, either patients who have the artificial heart walls or dyserythropoiesis, we have the fragmented RBCs. Here you can see these fragmented RBCs. These are the fragmented RBCs, and they also not specific for any specific anemia, but we get in thalassemias and megaloblastic anemia and congenital dyserythropoietic anemias. Acanthocytes. These red cells have small spicules or a thorn-like appearance at one end. Again, it is seen in patients of splenectomy and abnormal phospholipid metabolism. Echinocytes. These are like a crenated RBCs. Acanthocytes, they have the single pinpoint spicules on the RBC surface. Here there are multiple, but they are shorter than what you get in acanthocytes. These are multiple short regular projections on the RBC surface, and mainly you should rule out whether they are the artifacts, because many a times if a blood sample is kept overnight and in the morning when we prepare a peripheral smear. So in such case, it is best to call a patient, and again with the finger prick, we should prepare a fresh finger prick smear. And if you are not seeing the echinocytes in that, means that those were the artifacts. So keratocytes, they have the pairs of spicules, either one or two pairs. These are the helmet cells. I will just show you these are the helmet cells. These are the helmet cells. Here you can see. These are the white cells. They are because of the mechanical damage, or if there is a hinged body. So when the RBCs, they go through the splenic circulation, the pitting action of the spleen will create such kind of keratocytes. Leptocytes, again a type of hypochromic RBC, but the hypochromia is much more. The RBC is left with just a single ream of just a ream of hemoglobin. We see in severe, it is just like a kind of severe hypochromia we see in patients of severe iron deficiency anemia and thalassemia. These are the leptocytes. This one. These are the leptocytes. This one. These are the normal platelets, you can see. Stomatocytes, RBC, they have a mouth-like opening in the center. These are the stoma. These are the stoma. Again, it could be an artifact or in patients of MDS. Teardrop RBC, they have the shape like a teardrop. These are the classical teardrop cells. These are the, and they are also seen in a variety of anemias and the red cell disorders. They are not specific to a single entity. So we don't give much importance to the teardrop because they don't point to a single disease. You get in variety of conditions, but if they are there, we have to report because patient might have either of these conditions, myelofibrosis, thalassemia, or hemoglobin H disease. Now we come to the structure. What extra structures? Normally RBCs, even they don't have the nucleus also. But if there are other structures in the RBCs like basophilic stippling, you have the blue stippling in the RBCs or the Howell-Jolly bodies or Cabot rings, then we have to report. This one is the basophilic stippling. Just see these are the stippled RBCs. You see in there are two types, fine stippling and the coarse stippling. Fine stippling is seen in patients of the increased production of the red cells. These are the RNA bodies because there is and if the coarse stippling we see in patients of the anemia of B12 folate deficiency. There's a classical basophilic stippling. These are the Howell-Jolly bodies. They look like malaria, but with practice for a new one, they could be mistaken for a malarial ring because they look like the rings, and this is the dot. So sometimes untrained eyes will report it as a malaria, but these are the Howell-Jolly bodies. large round inclusions, they are the nuclear remnants classically seen in patients of megaloblastic anemia. But when we report, so we look for the other features of megaloblastic anemia like macrocytes, macrovillosites, reduced platelets. Then we have the hypersegmented neutrophils. And now we have the red cell parameters. We have the MCB more than 100. So when we have all these parameters, and then we can ask patients to get his B12 level done. Papillomer bodies, these are the single or multiple peripheral sites, angular basophilic erythrocytes. These are the papillomer bodies. One second. These are the papillomer bodies. These are the smaller than Poyle-Jolly bodies. Even these could be mistaken for the malaria. So they are seen in patients of sideroblastic erythropoiesis and hyposplenism. In his body, they are seen in patients of the G6PD deficiency, supravital stains. They are not seen in the normal Romanovsky stains. They are the precipitates of normal or unstable hemoglobin. G6PD deficiency. These are all in his body. You can see the dot. Normally, if someone is mistaking it as a malaria, but normally we don't get so many rings in almost all the RBCs have the Henne's bodies, and of course the history will help you out if there is a sudden loss of hemoglobin, sudden drop in hemoglobin, or if patient is not having fever and all. So clinically also it will help out. Cabot rings. In patients of pernicious B12 deficiency, we get this ring shape figure of 8 or loop shape inside the RBCs. This is a classical malarial stippling. Normally, the new pathologists probably they might not be aware, because now malaria is done. I don't know in the institutes now they do report malaria on the peripheral smear, but now we have the good antibody and the antigens card to detect the malaria. But when we were in college, we used to report malaria on the peripheral smear. This is a rouleau formation. That is the RBCs. They are like the stacks of coins, just like in the Poppins, and this is classically seen in patients of multiple myeloma or the paraproteinemia, whatever the monoclonal gammopathy. These are the sticky RBCs. You see rouleau formation. If there is a rouleau formation, a pathologist must report, and if the patient have the clinical history that matches with the paraproteinemia, we should ask for the serum electrophoresis or the protein electrophoresis for the M band. And if usually if a patient comes from the orthopedic side with a chronic backache, and if there is a rouleau formation, we must ask for whether there is any history of if the X-ray shows any lesions, bone lesions. Agglutination seen in autoimmune hemolytic anemias and macroglobulinemia. You can see such kind of, just see the RBCs, they are merged with each other. This is agglutination. It's just like a clumping of the RBCs. This is a normoblast. Normally, this is the RBC with the nucleus, and this normally we don't get nucleated RBC in the peripheral smear. But if we are getting this is called meta-rubricide. Normally we don't get, but if it is there, then we must look for the cause. Either if it is in the hemolytic anemias, whether it is a thalassemia, sickle cell anemia, In cases of acute blood loss, this normoblast will come in the peripheral smear. Or in cases of leukoerythroblastosis, we'll see nucleated RBC. This should not be confused with the lymphocyte. Normally, lymphocyte will not have this much of cytoplasm. Filaria, these are the parasites in the animals. This is just to show you in the veterinary practice also. They have the importance of peripheral smear. You can see they are just looking like a malarial parasites, filaria. Trypanosoma, fortunately, we don't have these two disorders, Trypanosoma brucei and Trypanosoma cruzi. Trypanosoma cruzi, Chagas disease, we don't have these disorders in Indian subcontinent. We have these in the African, these are the African sleeping sickness. But just to show you, these are also hemoparasites in the peripheral smears. You can see they look like this: Trypanosoma brucei and cruzi. Babesia. This is the Trypanosoma brucei. This is a classical Plasmodium falciparum, banana shaped. This is very easy to see because the shape, banana shape with some granules in the center. This is the Gametocytopla P falciparum, and these are the rings. This is the ring form, and this is the gamete form of the P falciparum. And this is the Leishmaniasis scalaza. We see it in the bone marrow. These are all the parasites. So this is also important. Patients with anemia, patients with fever, splenomegaly, not with the endemic malaria, the possibility of leishmania always we should keep in mind. And if the patient has come from that endemic region like Bihar, Orissa, so we should keep in mind leishmaniasis. This is again African trypanosomiasis, Trypanosoma gambiensis. Microfilaria. Again, this parasite, it's very difficult to see, especially we have to look from the evening 10 p.m. to 2 a.m. Blood. Usually these parasites come in the blood during this time. So you have to take the sample, and in that period. Recently, I had come across the patient, but I could not see the parasite. Dr. Surendra Jain sir has sent one patient with a elephantiasis leg, and he asked to look for the microfilaria. Though we collected the sample during the night hours, but we could not see. Then we sent the higher test for the filaria. But that patient also was not of filaria, that was something else. But filaria, we have to keep in mind always when the patient has come with a swollen leg like the elephantiasis, because filaria is endemic in our region. We have completed the RBC aspect, and the variety of disorder we could diagnose at looking at their size, shape, and the various inclusions in the RBCs. The second important organelle in the blood is the platelet. Normally their size is 1 to 3 micron. I will show you in the picture how the platelets look. You see, RBCs are the smallest. Platelets are the smallest. RBC is a 7.2 micron. These are the very smaller particles. WBC, they have the variety of the size. Monocytes are the biggest one. This is the monocyte. You see the kidney or the bean-shaped nucleus. Kidney or bean-shaped. This is a reactive lymphocyte. These are the platelets. You can see 1, 2, 3, 4. If you can see the 5 platelets, this is the oil emulsion field, 100 power field. If you can see the more than 5 platelets. You can see here 1, 2, then 3, 4, 5, 6 platelets. If you can see more than 5 platelets, then the patient's platelets count is normal. Initially, when we were in our PG days, the cell counter was not available. So we used to give the platelet count on the peripheral smear. One platelet count used to multiply by 30,000. So if you can see the platelets, more than 5 platelets in the oil emulsion field, this patient has a normal platelet count. Normally the count is 1.5 lakhs to 4.5 lakhs. Thrombocytosis, when their number is increased, when the number of platelets are increased, 7 lakhs, 8 lakhs, 10 lakhs. But most commonly, I have come across platelets around 6 lakhs or 7 lakhs, and I get a call from a clinician like his platelets are more. But most common cause for the high platelets in our region is the iron deficiency anemia. In iron deficiency anemia, we get high platelets because the erythropoietin has a stimulating factor on the platelets as well. So these are the variety of conditions like post-infection, inflammation, and juvenile rheumatoid arthritis, collagen vascular disorder, and essential thrombocythemia. Normally the platelets are these are the 1 to 3 micron size, but here you can see the mega platelets. They are seen in variety of conditions like May-Higlin anomaly, Bernard-Solder syndrome, Alport syndrome, and storage pool syndrome. The second disorder in the platelet is thrombocytopenia. Thrombocytopenia. The slide will be in the next. Thrombocytopenia we get commonly in our region, that is the malaria, and the second is dengue, and the third most common reason is the ITP. So in these 3 cases we get ITP is very classical. Female patients, young patients has come with a patch on the skin, and when the clinician asks for the CBC, the platelets are low. And when we do the bone marrow examination, we get megakaryocytes. The number is normal, and in the peripheral smear, platelets are low. The third common disorder that we see is the leukocyte related or the WBC related, white blood cell related. As you all know, we have the granulocytes and the granulocytes. In granulocytes, we have the polymorphs, eosinophils, and basophils. They have the granules, and the 2 cell lines which don't have the granules, they are the lymphos and monocytes. Here you can see all those. Just see, these are the granular ones. This is so polymorph. Normally they have the 3 to 4 segments. These 3 to 4 segments. This is the polymorph. This is the eosinophil. The granules are eosinophilic. Nucleus is bilobe or the spectacle shaped nucleus. Spectacle shaped nucleus and the eosinophilic granules. This is the eosinophils. This is the basophil. Basophilic granules. You can't see the nucleus because these granules obscure the nucleus. So these 3 are the granulocytes, and this is the lymphocyte. Just see, hardly any cytoplasm, and this is the monocyte. This is the monocyte. Yeah, just classical. I think this is difficult to identify, but this is the monocyte, the kidney-shaped nucleus, bean-shaped, and this is the size is the bigger size. These are the platelets you can see. And these are the RBCs with a normal 1/3 of the central pallor. So the whole peripheral smear you can see in this slide. RBCs, WBCs, platelet. This is again the slide is showing. These are this is the monocytes. They have the variety of variety of shape, the nucleus, either it is bean shaped or this is the reactive lymphocyte. Just see the amount of cytoplasm and the sizes also. This slide will just show you the precursor of all the cells, red cell, WBC, and the platelets. No, this is the myeloblast, but the earlier precursor is hemocytoblast. So the promyelocytes, myelocytes, and then they have the neutrophils, and the neutrophils, they come into the blood. This is in the bone marrow, and this is in the blood. And when they go into the tissue, when the monocytes they go into the tissue, that is a macrophage, and their size, promyelocytes, myelocytes, their size is bigger than the mature ones. WBCs, we have the variety of disorders. That there is a leukopenia, that there means according whether they have the neutrophils, eosinophils, basophils. Again, so if the neutrophils, they have the neutropenia, neutrophilia. Again, eosinophils, eosinopenia, eosinophilia, and the basophils. Again, basopenia, basophilia. First, we'll deal with the neutrophils. That is a normally their percentage is 40 to 75%. Their number is highest, and these are the granules which you can see. This is a normal WBC, normal granulocyte I'm showing to you, and these are the band forms in patients with the acute infection, septicemia. You see because there is a hyperproduction of neutrophils in the bone marrow, and we see these band forms. These either they are the U-shaped or the S-shaped, and there is a shift to left. Then you see this band form. Shift to left. Just see this is a shift to left. You see more of a band forms on this side, and this is as the neutrophils mature, we have the more and more segmentations. So increased band form, usually from the pediatric side, we get this request for the band forms, whether the baby has septicemia. Now we have more sophisticated parameters like CRP, but still band forms indicates the sepsis. And these are the toxic granules. So the band form and toxic granules, they go side by side, because in septicemia we have more of a toxic granulation and the band forms, especially in the bacterial infections, because obviously in viral infections and tubercular infection we have more of a lymphos and the monocytes. So it indicates a bacterial infection, and the clinician has to put the patient on antibiotic or he will ask for the blood culture. Hypogranular WBCs we see in patients with MDS. Hypogranular or the granular. These are the WBC, but there is hardly any granules. Just see, it is just a plain cytoplasm. You can see. Here the granules are much more bigger. Just seen in patients with Chidiac Higashi. Dhole bodies. This is a small, round, pale gray structure. This is Dhole bodies. Again, seen in patients with bacterial infection. Vacuoles in neutrophils. Many times this is just an artifact, but this could be an indicator of severe sepsis. Hypersegmented neutrophils, I think we have discussed when we were discussing the megaloblastic anemia. Pelger-Hewitt anomaly, this is a inherited condition, and the segmentation is not proper. Segmentation is not proper. They look like a band form. This is looking like a band form, the segmentation. Apoptosis. This is a cell suicide, and small number of dead or dying cells. Normally we see when we keep the blood overnight, and when next day when we do the peripheral smear, and we see such kind of pycnotic neutrophils, dog cells. This is just clinical pictures in cases of neutrophilia, neutropenia, sorry, patients with severe organocytosis. This is a picture of neutrophilia. You see the peripheral smear. It is full with numerous neutrophils, and many of them they are like a band forms, well, one or two segments. When this neutrophilia is very high, normally in neutrophilia we have the total count more than 11,000, like 18,000, 20,000. But if the 90% is neutrophils, but if it is around 30,000, 40,000, then it goes in favor of leukemoid reaction, that is shift to left. We have to differentiate this condition from the leukemia. Whether am I dealing with because if there are blasts, then the diagnosis is totally different. Leukemoid reaction, we have to see properly. We have to ask the clinical details, whether the patient has hepatosplenomegaly, whether patient has a bone pains, or patient, and because and in that case we have to ask for the bone marrow, because the diagnosis is totally different. We cannot just simple label as an neutrophilia, whether it is a leukemoid reaction or leukemia. See the neutrophilia, the number of neutrophils. Normally we don't see so many WBCs in the one oil emulsion field. See, all are neutrophils. Neutrophils with toxic granulations and band forms. We have discussed in cases of septicemia. Band forms with toxic granules. The neutrophils are the second important cell, that is lymphocyte. See this lymphocyte. This is a reactive lymphocytes. Normally, reactive lymphocytes has a cytoplasm. It is bigger, and we have to differentiate it from the blast. It is seen in patients of infectious mononucleosis. This is a leukemia reaction. But in leukemia reaction, the neutrophils are mature. We do get band forms also, but we will not see the blast. Sometimes we can see the blast, either single, but normally we don't get blast. Usually we don't see the blast, and mainly it is the band forms and the neutrophils. This is just to summarize how the acute leukemias and the chronic leukemias. In acute leukemias, we have more of a blast, and in chronic leukemia, we have the more of a matured cells. This is a chronic leukemia, and in myeloid series also, these are the chronic. When we have the more of a mature series cells, that is polymorphs, eosinophils, basophils, monocytes, that is chronic myeloid leukemia. And if you have more of a myeloblasts, promyelocytes, metamyelocytes, then it is acute myeloid leukemia. Depending on the number of blasts, we call either whether it is an acute leukemia or the chronic leukemias. This is totally different lecture on the leukemia. This is just to show you the slide. Yes, here it is very obvious. This is the normal peripheral smear. You can see the good normal looking lymphocytes with the periphery of the scanty cytoplasm. Here this is a neutrophil. Here we are seeing the platelets, normal looking RBC with central pallor that is not more than 1/3. And here you see these are all lymphoblasts. Just see the difference between their size. This is almost 3 times. Then you can see the nucleolus, and this is the open chromatin. They look like the angry looking cells. You see, and here this is all the myeloid cells, chronic myeloid, metamyelocytes, promyelocytes. So this is a chronic myeloid leukemia. This is acute myeloid leukemia. These are the myeloblasts. This is a lymphoblast. These are the acute lymphoblastic leukemia. Again, here the size of the cell is much bigger, open chromatin, nucleolus, you can see. This is an acute myeloid leukemia. Again, this is the last. And this is just to show you the patients of eosinophilia. If we report more than 7 to 8% of eosinophils in the peripheral smear, then the clinician must look for the cause for the eosinophil. That is variety. Mainly, it is an allergic reactions, but in patients of mainly in patients of if it is a worm infestation or whatever the variety of causes we have for the eosinophilia, bronchial asthma, or the allergic conditions, worm infestations, clinicians should look for it. Thank you very much. If there are any questions from the audience, I think whether the time permits, then we'll go for it.
Thank you, Gopal Soni sir. I call Dr. Manjushri Tibdewal ma'am for concluding remarks and any questions from audience.
Thank you, Dr. Gopal Soni, for such a wonderful presentation. It's a simple and basic investigation, but much needed in day-to-day life practice. There are few questions from the audience. What's the probability of finding malarial parasite in peripheral smear?
Peripheral smear, if it is if the patient has a fever and that time we take a finger prick smear, then there is a good chance, like there is a 70% chance we can see either a gamete form or the schizon form of the parasites. But today in clinical practice, what we are seeing is more of a rapid malarial card we are using. And they also have the excellent results. Malarial card, whether we have the antigen card also antibody card also. So, and they also differentiate between the patient has a Plasmodium falciparum infection or the Plasmodium vivax infection. So we now recommend more of a card test rather than on the peripheral smear. Because for the card test, we don't have to have the fever patient in the febrile conditions, because even if patient in the febrile condition and he has a malaria, that will detect. Peripheral smear, there are varieties of limitations. With the expert hand, it is a very good test, but for an experienced pathologist, or because we have to look really hard to look for the various forms of the parasites. Banana form is very easiest to find it out, the gamete form of the P. falciparum. But the ring forms, we really need a trained eye. But there is a good chance to see the parasite in the peripheral smear if the patient has a malaria.
Thank you, sir. Ma'am, we are running short of time. I request you to conclude the session, please.
Okay, thank you, sir. Thank you, Dr. Gopal Soni, sir.
Thank you, Soni sir, for your wonderful guidance, and chairpersons Dr. Manjushri Tibdewal ma'am and Dr. Sandhya Nagargoje ma'am for making it more educational. The second lecture of today's session is Tough Nuts to Crack, a Pain Physician's Perspective by Dr. Namrata Bhagwat ma'am. Chairpersons for the lecture are Dr. R.K. Jadhav sir, anesthetist and chest physician of KHAMGAON, and Dr. Narendra Pawar sir, leading orthopedician from KHAMGAON. I request Namrata Bhagwat ma'am to start her lecture, to start her talk.
Yes.
Hello.
Yes. Hello. Can you hear me?
Yes, ma'am.
Can you see my screen?
Yes. Now we started.
Good morning, ma'am. Dr. Narendra Singh Pawar will start with the introduction of yours.
Yes.
Just a minute, ma'am. Good morning. This is a short or brief introduction of Dr. Namrata Bhagwat madam. Madam did her MBBS from 2002 to 2008 from Government Medical College, Nagpur. Then Madam did MD Anesthesia from 2009 to 2012 from Tata Memorial Hospital, Mumbai. Then Madam is a gold medalist from HBNI. Then Madam worked as a senior anesthetic in pain department from 2012 to 2015 at UCMC and GTB Hospital, Delhi. Then Madam attended lots of short-term pain fellowships. Then Madam also did diploma in short nutrition, and also she is pursuing LLB from said Goenka College, Akola. Then Madam is currently working as a interventional pain physician at Vatsal Pain Clinic. She is a director of Vatsal Pain Clinic at Gorakshan Road, Akola. Then Madam also working as a consultant pain physician at Sant Tukaram Cancer Hospital, Akola. And she is working in nutrition and fitness, working as a nutrition and fitness consultant at Vatsal Pain Clinic since 2020. This is brief introduction. Now Madam can start with her lecture. Thank you, Madam.
Good morning. Is my screen visible?
Yes, ma'am.
Yes, ma'am.
Yes.
Yes,
So I'm starting with tough nuts to crack. Basically, tough nuts to crack is a saying where it becomes very difficult to crack a nut. You have to apply some extra efforts for that. So I just want to share a few of the tough pains in pain practice. Greetings from my hospital, Vatsal Hospital from Akola. How prevalent is chronic pain? So out of the 140 crore population of India, almost 25 crore, 19.3% of people are suffering from chronic pain. We have 2,000 neurospine surgeons, we have 2,200 pain physicians, we have 100 plus specialized pain clinics, and yet we have still yet to reach the nook and corner of the country, and still many of our Indians are in agony, and painkillers are out of reach for them. So ISSP is a body of on a national level of pain physicians, which is working towards this cause. It is bringing together scientists, healthcare physicians, healthcare workers, and policymakers so that all can stimulate and support the study of pain and translate that knowledge to give pain relief across India. With increased awareness of pain clinic among the population and all the referring colleague doctors, more and more difficult to deal pains are coming up, which tests a grit and patience. Now, majority of them respond to the conservative management like painkillers and physiotherapy, but then some of them give us a very, very tough time to treat them or to address them. So when a patient with a pain presents at first visit or is referred to us, then what do? We go through the same steps like we all do. We take a detailed history like onset, duration, progression, character, what aggravates it, what alleviates it, everything about the pain. Then we do a physical examination, system-wise, and general examination. Then we look at the clinical investigations, whether any blood reports are positive or pointing towards a specific diagnosis, or they are neutral. Most of the times they are neutral, and that's why it's difficult to find these pains. Clinical investigations, once they are seen, then we go to radiological investigations like MRI, CT scan, X-rays, the sonographies, or we go through the referral letters for what the referral has been given. And then any history of any procedures done, like inguinal hernia, operated for inguinal hernia, for cesarean section, or some back surgery done in the past. Then we initiate our treatment, which it depends on the likely pain generator. So it could be inflammatory, like inflammatory arthritis, rheumatoid arthritis, ankylosing spondylitis. Now in this era, post-COVID arthritis, it could be myofascial pains, fibromyalgia, neuropathic pains like neuralgias, disc pains, then myalgia paresthetica, phantom limb pains. It could be autonomic also, where the autonomic component is dominant, like in reflex sympathetic dystrophy or the CRPS, and in many cancer pains. Or it could be central, like some patients suffer from pain for 11, 12 years. So by that time, the pain becomes central. It also depends on whether it's an acute pain or a chronic pain requiring early immediate management or an OPD-based management. So modalities of treatment applied. Now, this is just a nut with a routine nut cracker, like we crack and the nut cracks. So it's the conservative method is lifestyle modifications. Painkillers, which include non-inflammatory, non-steroidal anti-inflammatory drugs like diclofenac, aceclofenac, centrally acting drugs like paracetamol, the muscle relaxants like thiococicoside, then IV drugs are given if it is acute and patient is in intense pain. Some are given transdermal drugs, like opioids are available in transdermal formulations. Then some are started on morphine, depending on what kind of pain and what is the prognosis of the disease. Then neuromodulators are also given, like gabapentin, pregabalin, duloxetine. Adjuvants are given, like dexamethasone, prednisolone, that steroids wherever needed, nerve supplements, vitamin D, calcium, and they are advised for physiotherapy. Mostly for most physical pains, physiotherapy is advised. Now these pains respond. Now there are some nasty pains which give us a tough time to diagnose. We have to counsel the patient. We have to tell them you can't really. Then they ask, what is the guarantee you will do it and we will get the relief? We have to go through all this mental stuff, and it gives us a big challenge to pursue that pain because it is chronic and it has already bogged down the patient. Patient is already distressed, troubled by going from doctor to doctor and then coming to us exhausted financially. All other resources are exhausted and he's just bored. So it becomes a big challenge for we pain physicians also to carry them through this phase. Now some of these nasty pains, these are disc bulge pains, so just a disc bulge, nothing much. Then internal disc disruptions which cannot be picked up on MRI or probably high intensity zones on MRI. Then facetal pains, sacroiliac joint pains, inflammatory arthritis pains, then failed back surgeries, coccygodynias, cancer pains which are not responding to high dose opioids, slipping rib syndrome which presents as an anterior abdominal pain. The patient undergoes a lot of sonography and still they are not able to find out the cause of pain. Anterior cutaneous nerve entrapment syndromes, herpetic neuralgias, post-herpetic neuralgias, whiplash injuries, chronic pancreatitis, continuously having pancreatic attacks, and yet the pain is not going with all the treatments. CRPS, proctalgia prugax, occipital neuralgias presenting in the form of headaches constantly taking medications for migraines and yet not getting relief, and even it gives a tough time to diagnose. Then various other facial pains. So then these kinds of pain require a little more efforts from our side, a lot of great determination, patience from our side, and intensified efforts. So then we go towards invasive procedures like targeted nerve injections, like which is the highly likely nerve which is causing this pain. Epidurals, joint injections. We deliver drugs like anesthetics, steroids, or we give PRP therapy. We do neurolysis, that is called chemical neurolysis with alcohol or phenol, or we do radio frequency ablations. It all depends on, first we have to identify the pain generator. And for patients on pains which have become central and nasty, not responding to any of these, then we have to go for higher procedures like implantable devices, spinal cord stimulators, intrathecal drug delivery system, epidural implants. So much so we have to refer to neurosurgeons so that deep brain stimulation can be done for them. It's a whole new branch, neuromodulation. So I came across this quote on the internet, and I so much related to this quote that even after having learned from some of the most brilliant and kindest doctors, I can undoubtedly say, hello. I can undoubtedly say that the greatest teachers I have had are my patients. May I again confirm, am I audible to everyone? Hello?
Yes, doctor, please carry on.
Yes, ma'am, you are audible.
Hello?
Yes, ma'am, you are audible.
Okay. So I would like to share some of the cases who taught me that I have so much to learn yet, and we did have a tough time. We could some of the pains we could address, we could decrease many of the pains, and some pains we are still fighting today. So this is the this is the investigation of a 54-year-old male who had a history of road traffic accident. While he was driving, he was hit by a truck from behind. So he got trauma by his own steering wheel on his chest. And then he had a these rib fractures. So acutely he was managed by surgeons and conservative. There was no surgical indication because he did not decompensate. There was no pneumothorax, and he was vitally stable. So he was given all the treatment 6 months back, and he was fine. He was discharged. All this was done at Nagpur, and he came to his hometown. Now, after 5 to 6 months, he was still having a pain in his chest with every breath he took. So because of that, he used to not take a deep breath. So many times we had to, admit him and give him oxygen because his saturation used to drop to 90. So this phase we carried on. Sometimes we gave him intercostal nerve blocks. We gave him conservative management. We took him for on oral analgesics for 2 to 3 months by titrating his serum creat, by looking at his liver function tests, and making sure that he does not suffer the side effects of painkillers. As and when acutely he used to get admitted. Now this patient was our next plan was epidural, putting in an epidural and maintaining it till his pain decreased. But fortunately, this patient responded to conservative management, like the intercostal block and the oral drugs, and we were now he's living a normal life. The other case was a 35-year young lady with pain in the operated side. She was operated a year back for a big bad rib tumor. Now she had a bronchopleural fistula in situ, so she could not sleep prone. And she used to get these acute attacks of intense pain, and she did not want to take morphine. She was also opioid intolerant. She had young children. So she used to keep coming for acute pain relief. So we used to give her trans epidural blocks, paravertebral blocks, and it was a big challenge for us to give it in odd positions. See, the CM is in very odd position. Ideally, this block is done in prone position under CM. But because of her fistula, we could not give, and somehow we managed with epidural, constant epidural with Baxter balloon pumps. Then we eventually, at the end of her life, we put her on morphine, and she passed away, but she passed away in a very less pain as compared to what she had come to us. This is a 20-year-old young boy with above knee amputation done for osteosarcoma of the tibia. And now he came with recurrence and severe pain, not tolerant to morphine. We gave him high doses, yet his pain was severe. So again, he had multiple admissions, used to come in pain. So initially we gave him femoral nerve block, PNL guided. Then again, he came with when the mass got fungated, that time we had to give him PNL, peripheral nerve locator guided femorosciatic alcohol neurolysis. That is, we tried to destroy his sciatic nerve. Again, he was pain-free for some days. Then again, he got a big recurrence, and we had to give him epidurals in standing positions because he could not sit. Eventually, even this patient succumbed because he had a massive bleed from the tumor and the femoral artery. But his pain, we were able to address his pain. This was a case of 32-year-old lady who came to me with a pain in her healed cesarean incision. She had cesarean section 1.5 years back, but the pain in her in the corner of her incision never went. So she had lightning neuralgic pain. She could not take her baby in the lap, and she could not feel, because if the baby kicked, she used to have a severe pain. She was going into depression, and out of desperation, a radiologist sent her to me, because she was landing up at the same radiologist for multiple USG abdomens, and the radiologist was not finding anything in the abdomen. So finally, when she came to me, we worked over the cause. Biggest thing was to counsel her that we can try, we have to take medications. Then we gave inguinal nerve block. We gave her repeated local infiltration at the point of pain where the either inguinal nerve was entrapped. Finally, now she is off medications and living a normal life, free from the pain. Now, this is a recent case, a distressed 60-year-old father of a budding doctor. The doctor is doing radiation oncology in Mumbai. His father suffered from COVID last year. Now they suffered from COVID, then the complications, ICU, then he got mucormycosis, then he was operated for mucormycosis. Then second, again, he got like residual mucor was there again. That was cleared through the nasal endoscopy. But after all this, when he came out of this, he went into a neuralgic kind of pain in the inner canthus of his eye and the supraorbital area. He had severe pains, and now he was again going into very depressed, like he has come out of the COVID and all the life-threatening complications, and yet he's not able to manage that pain. So he came to us. We gave him repeated supraorbital and supratrochlear nerve blocks. Our plan was supratrochlear and supraorbital radiofrequency ablation, but fortunately, even this patient is doing well on oral drugs now after the blocks, and we are in the process of tapering his drugs. This is a case of a young man who recently underwent in October a superficial parotidiectomy for pleomorphic adenoma. Everything went well, but he just had pain in his post-op incision, which was bothering him. The pain was lightning going behind his ears, not letting him do anything. The pain was so intense that he used to get nausea and admitted again and again to the hospital. So we were called, And after assessing, we realized it's the entrapment of the greater auricular nerve at the surgery, at the healing site. Probably that was transected while taking a flap. So then we gave a superficial cervical plexus block, USG guided. We put in local anesthetic and a steroid, that is dexamethasone. And we also, in the subsequent visit, we also infiltrated the incision, the healed incision. Now this patient is also fine on tapering on the drugs. This is again, this was referred by a neurosurgeon. The MRI looks really bad, but there was nothing to be done surgery-wise because the pain was very bad, but there were no motor complaints, no red flag signs. So then we went ahead with a cervical epidural in this pain, and this patient is also doing very fine. Trigeminal neuralgia. Now this is a very severe kind of pain which where people are on drugs for years together and yet it does not respond. It becomes very difficult to counsel them, bring them to the OT table, make them understand what we are going to do. It's a challenge, but when it works, it's a big relief to them. Now this lady, she came with trigeminal neuralgia. Look at the kind of pain. This was the just one of the episodes in front of me. She had 3 to 4 episodes continuously. She was so bothered that she could not comb her hair. She could do nothing. She never brushed from that side. She stopped eating. Similarly, the other patient, she also stopped eating. She had undergone mandibular neurolysis 10 years back in Mumbai, and again she had come. So both these were challenges for us. We did a radio frequency ablation of the. We went through this foramen oval, like which has been shown in the skull. And we did the radio frequency ablation of the mandibular nerve and the trigeminal ganglion, and the patients are pain-free now in the follow-up. This was again a pain patient. We had planned trigeminal for him, but it was an interventional challenge. We maintained him on high-dose opioids, repeated stellate ganglion blocks. Now his pain had come down, but he eventually succumbed to his disease. This is a patient of chronic pancreatitis. And he also was so distressed, took a lot of visits to counsel him to go ahead with the celiac plexus neurolysis. He is also doing fine. We ablated his celiac plexus transaortically. This is the celiac artery here, the circular, after putting the dye. Now he's doing fine. This was a patient, he was a known case of trigeminal neuralgia. Now he had a new kind of pain while swallowing. So he was distressed every single time, every single day. Whenever he used to swallow, he had pain in the ear. He was so committed to his pain relief diagnosis that whatever we told that let's do this, he was ready because he wanted to get rid of the pain. Ultimately, we could find the pain generator, which was the glossopharyngeal nerve. So we gave a diagnostic block at the glossopharyngeal nerve near the styloid process, and the diagnosis was confirmed. Which was a long styloid process, which was pressing against the glossopharyngeal nerve. And then we sent him to a surgeon who excised the styloid process, and now he's totally pain-free. Now, the toughest nuts also are the ones which arise due to faulty lifestyle. So what is happening? Newer and newer patients are coming, obese who are 125 kgs. They have pain in walking, unable to smoothly sit somewhere. They are unable to stand, and they have aches and pains in the body. Now, how many painkillers are we going to give these patients? Youngsters are coming with neck and back pain. What painkiller are we going to give? All investigations are going to come normal. Then people have faulty postures. Then like in pandemic, they have work from home, and so many people do up down from, like I have patients doing up down from Buldhana to Akola. So all these come with back pains. There is nothing intervention wise done to be done in them. So basically what happens is we have to prevent all these things. Now, rather than curing these, we have to prevent these kind of things. So health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity, according to WHO. So now lifestyle induced, whatever pains are there, they are not diseases. They are not infirmity. They are just absence of disease, yet the patient is not physically stable, and it affects their mental well-being too. Hence, we all have to commit to prevent the pain, educate people as much as possible, and also ourselves follow to prevent pain by following a healthy lifestyle. So we should consciously track our food, monitor our calories as per our goals, keep adequate protein intake, have a fiber-rich diet, exercise regularly, avoid junk food, quit smoking, limit alcohol, stay hydrated. Thank yourself for the efforts you're doing for yourself and others. Life is not to be taken very seriously. Sit in silence with yourself every day for at least 10 minutes. We all will be able to realize what our pain generators are. मुद्दा यह नहीं है कि दर्द कितना है, मसला यह है कि परवाह किसको है. Thank you for being such a wonderful audience.
Thank you, ma'am. Now I request Dr. Ravi Shankar Jadhav sir for concluding remarks and any question from audience.
Thank you, ma'am, for such a nice and elaborative lecture on a very highly subjective and underrated department in our medicine, that is pain. And thanks to all the anesthesiologists who are working for the pain as a pain reliever for the critical patients. So any questions from the audience?
I think there are no questions, sir.
As pain is the 5th vital sign as per American Pain Society, all the congratulations to both madam, as she is doing a fantastic job for the patients, for the needy patients, because these patients can't be seen and can't be understood by the relatives as well as the patients himself. So as pain is a highly subjective area, so all the congratulations to Namrata Bhagwat ma'am and all the best.
Thank you so much.
Yes, sir. Thank you, Namrata ma'am. That was really nice and informative presentation. I also thank our chairpersons, Dr. Ravi Shankar Jadhav sir and Dr. Narendra Pawar sir for being with us and for making the discussion more informative. Thank you. Now we will move for our next lecture. It is coming to third lecture of the day. Let's welcome our enthusiastic pediatrician, Dr. Guru Prasad Thete sir. He is going to enlighten us on how to handle pediatric asthma patients in general practice. This session will be chaired by Dr. Hari Vadode sir, leading senior pediatrician of KHAMGAON, and Dr. Amit Deshmukh sir, leading pediatrician of KHAMGAON. I request Dr. Amit Deshmukh sir to kindly give introduction of Guru Prasad Thete sir. Amit Deshmukh sir, are you there? Dr. Hari Vadode sir. Dr. Guru Prasad Thete sir, he is pediatrician and neonatologist of KHAMGAON. He has done his MBBS in 1995 from PDMC Amravati and DCH in 2005 from BPT Mumbai. He was ex-registrar KEM Hospital and Wadia Hospital Mumbai. He was medical officer of Government Hospital KHAMGAON. He is private practitioner in KHAMGAON since 15 years. He has his great work biodata, like he was secretary IMA KHAMGAON for year 2017-19. He was secretary IIP KHAMGAON from 2016-17. He was organizing secretary Annual CME KHAMGAON 2016, chairperson in state and national CMEs, and he has presented many seminars at conferences. He was guest speaker in many schools and social events to educate regarding health and development. He has conducted many free camps in rural areas too. So I request Dr. Guru Prasad Thete sir to continue with his talk.
Thank you, Dr. Anand, for a nice introduction of it.
Sir, I request to mute one of your device. I think it is making echo.
Okay. Hello.
Sir, it is making echo, sir.
Okay.
Sir, still it is making echo.
Now it's okay, sir.
Okay.
Yeah.
Hello.
Yeah. Now it is clear.
Thank you, Dr. Anand, for giving my introduction. And thank you, KHAMGAON, for giving me the opportunity for having a talk on the pediatric asthma. Hello. Hello.
Sir, you are audible. We can see
Okay.
your slides too.
Are you seeing my slides also?
Yes, sir.
Okay, fine. Thank you. I am presenting pediatric asthma. Asthma is a worldwide problem. There are more than 300 million people suffer from asthma worldwide. In India, there is a prevalence is 23% in India. The asthma heterogeneous disease characterized by chronic airway inflammation resulting in episodic airflow obstruction. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitations. You see this picture, the normal bronchial is normal vascularity, perfusion was good, and the lumen is normal. In the asthmatic bronchiole, you see there is a constriction and the swollen lumen. So it is characterized by the airway obstruction, that is bronchospasm, which is reversible, and there is a airway inflammation. There are some inducers like allergens that might be pollen grains, dust mites that stimulates, then chemical sensitizers, air pollutants, the viruses, most common RSV, rhinoviruses, that leads to the inflammation, which causes airway hyperresponsiveness. Triggers again.
So the audio is getting disturbed.
Which cause airflow limitation, bronchoconstriction, which leads to the symptoms of asthma, that is cough, wheeze. In the adult and adolescents, there are complaints of chest tightness and dyspnea. So there is a pathophysiology of asthma. It was mostly some so I has a very well slide modern view of asthma. The allergen which causes stimulate the mast cells, eosinophils, and the macrophage dendritic cell adhere to
Guru, I think he's lost the connection.
which leads to the bronch. Hello.
Yes.
Hello.
Go ahead. Yes, Guru, go ahead.
Okay, sir. Then there is a nerve activation which causes the stimulation of sensory nerve activation, which leads to the cough. Then inflammation
I think he has lost the connection.
Dust, house dust mites, smoking.
Dr. Prasad, your audio is disconnecting.
Hello.
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 Sir.
Just 1 second. Are you seeing my fact slides? No.
Sir, we are unable to see you just now.
Hello, Guru. I think Anand, he has lost the connection.
Yes,
Sir.
sir.
Sunil sir. Sunil sir,
Yes, ma'am. Yes, ma'am.
you are having the presentation.
No, ma'am.
Dr.
No.
Thete sir's presentation.
No, ma'am.
Hello. Are you seeing the slides?
No, Guru. We are unable to see the slides.
Dr. Prasad, you are on mobile data?
Maybe.
Sir, try to connecting on
Actually,
Wi-Fi.
he has some issue with his Wi-Fi, so he has connected with mobile. Hello, sir.
Hello.
Yes, Guru.
Sir, are you seeing me?
No.
Hello?
Not able to see.
My slides are not seen.
Now, yes. No. Just put on the slides.
Guru, we can see you, but your slides are not visible.
Just a second, sir.
Hello.
Are you seeing the slides?
Sir, दोन्ही on केलेले आहेत.
No.
That's a problem.
Yes. Go ahead, Guru.
Okay, sir. The triggers. Are you seeing the slides, sir?
Yes.
No.
Okay.
Yes.
Then strong odors. Sorry for the interruptions. Strong odors, pollution, anger. There are some emotional factors like anger, stress, and there are some pets, house pets. So there are some drugs like NSAIDs, aspirin, beta blockers, which can have the asthma triggers. The diagnosis of asthma is written like an iceberg. Only the 30% have persistent cough, wheezing, and dyspnea. There are atypical features like cough variant asthma, nocturnal asthma, activity-induced asthma, persistent cough after an URTI. Then there is recurrent pneumonia at different sites or the same site. Then we come for investigations. The routine blood counts doesn't help for our diagnosis of asthma, but the peripheral smear can show eosinophilia. The X-ray chest only to rule out tuberculosis, atelectasis, but in X-ray chest of asthma patient, there may be hyperinflation. Then sputum examination, it for eosinophils, and there are Cushman's spiral body, but it is rarely needed. The charcot-laden crystals are the crystalloids containing galactine-10, but it can occur in ascaris and other conditions also. And the Cushman spirals are from shade epithelium. So the gold standard for asthma diagnosis is a pulmonary function test, spirometry, and peak expiratory flow rate. Now we came for spirometry. It is useful in mostly 6 years and above children. It is an objective measure of airflow limitations. Low FEV1 and FVC ratio is less than 80%. FEV1, that is forced expiratory volume. It is the total amount of air exhaled in 1 second. And FVC, it is a forced vital capacity, the total amount of air exhaled during FVC test. These are the tests, safe tests, but they can cause sometimes temporary shortness of breath or lightheadedness. So there is a response of bronchodilator, that is to inhale beta agonist, and there is improvement in FEV1 more than 12% and more than 200 ml. Then there is an exercise challenge. It leads to worsening in FEV1 more than 15%. On the spirometer, we have to a daily peak flow or FEV1 monitoring. It varies from day to day and AM to PM variations. There is more than 20%. Now you see the chart diagram. That is FEV1. It is slanted and elevated with the time and volume. The lung function test, the PFR monitoring, it is simple and inexpensive home use tools to measure airflow and can be helpful in number of circumstances. The PEFR is the maximum flow rate generated during a forceful exhalation starting from full lung inflation. It reflects large airway flow, but it depends on voluntary effort of muscular strength of the patient. It is calculated height in centimeter minus 100 into 5 plus 100. There are some zones like green zone, yellow zone, red zone. In green zone, if 80 to 100% of the predicted number, it is normal. And yellow zone, 50 to 80% of predicted number, it is acute exacerbation. And the red zone of less than 50% of predicted value, it causes the severe attack. Then the differential diagnosis of wheezing. In early infancy, birth to 6 months, aspiration syndromes, gastroesophageal reflux. There may be some congenital problems like webs, bronchiolitis, rarely but foreign body inhalation. In infancy, early childhood, that is 6 months to 3 years, most common is bronchiolitis, and transient vision of childhood, foreign body inhalation, congenital heart disease, tuberculosis. Late childhood, more than 3 years, most common is asthma, then transient wheezing of childhood, congenital heart disease, again tuberculosis. There is functional, that functional means mostly stress. The child have wheezing episodes, which is functional, it is most, also we have to differentiate. Then classification of asthma severity. It is less than 4 years old children. The components of severity are there. And we have to classify in intermittent and persistent. Persistent again, mild, moderate, severe. According to symptoms, in intermittent, less than 2 days a week. In mild, more than 2 days per week, but not daily. In moderate, it is daily, and in severe, throughout the day. The night awakenings, there are nothing in intermittent, but there are 1 to 2 per month in mild, 3 to 4 per month in moderate, and more than 1 per week. Then SABA use is less than 2 days a week in intermittent. In mild, more than 2 days a week, but not daily. In moderate, it is daily, and in severe, several times per day. The interference with the normal activity. In intermittent, there is none affect the normal activities. In mild, there are some minor limitations are there. But in moderate, there are some limitations, and in severe, extremely limited normal activities. Asthma management. The asthma management is aimed at reducing airways inflammation by minimizing pro-inflammatory environment exposures, using daily controller anti-inflammatory medications, and controlling comorbid conditions that can worsen asthma. The management is also should be cost effective, and there should be goals, that is to achieve, maintain clinical control of symptoms, to perform normal activities, minimum days with less side effects, there should be no emergency visit, and there will be no normal lung functions. There should not be no exacerbations, and it can lead to improve the quality of life. Then there are some medications for asthma. It is mostly categorized according to some GINA, that controllers and relievers. I will tell later on what about GINA and their chart. So there are some relievers. I will mention these drugs as relievers and controls. Selective short acting.
Guru. Guru, voice is not audible.
Hello?
Your voice is
not audible.
Now it is clear. Initially it was
okay,
not.
okay.
Actually, I am mobile was away from me.
Okay.
Then controllers are there: inhaled steroids, beclomethasone, dipropionate, budesonide, cyclosinide, and there are some mast cell stabilizers: sodium chromoglucate, neutropenia, sodium. So the diagnostic flowchart for asthma in clinical practice. Patient with respiratory symptoms. Are the symptoms typical of asthma? That is, we have to look for the symptoms when the patient comes with respiratory symptoms. Then if it is yes, then we have to take the detailed history examination for asthma. History examination supports asthma diagnosis. That is, asthma diagnosis is mostly and examination. So we have to perform some spirometry, PFR with reversibility test. That results support asthma diagnosis, then treat for asthma. If the symptoms of respiratory system are not supportive of your diagnosis, then we have to do further history and test for alternative diagnosis. If the alternative diagnoses are confirmed, just I mentioned before the slides, then you have to treat that alternative diagnosis. Again, there is not alternative diagnosis. Then again, we have to give the total detailed history for asthma, examination, perform spirometry. If yes, treat for asthma. Then if it is the alternative diagnosis, then we have to think of again, repeat another occasions for the test and confirm asthma diagnosis. If it is not there, then we have to consider trial of treatment for most likely diagnosis and refer for further investigations. If it is yes, then treat for asthma. But in acute clinical urge or other diagnosis unlikely, then we have to empirically treatment with ICS, SOS SABA, revive the response, diagnostic testing within 1 to 3 months, then we can go ahead with treatment for asthma. GINA assessment of symptom control. GINA, it is the global initiative for asthma, which is formed in 1993 by WHO and NHBL. There are two components, symptom control and the risk factors for poor asthma. We have to reduce the risk factors. Then symptom control. In the past 4 weeks, has the patient had the daytime asthma symptoms more than twice a week? Any night waking due to asthma? Reliever needed for symptoms more than twice a week? Any activity limitation due to asthma? We have to mention that. And then well controlled, partly controlled, uncontrolled. In well controlled, none of these is present. In partly controlled, 1 of 2 these present, and uncontrolled 3 to 4 of these. Then risk factors for poor asthma outcomes. We have to reduce these risk factors that exacerbate patient's risk for exacerbations, fixed airflow limitation, medication side effects, and the risk can lead to the worsening, that is death of the asthma patients. There is an asthma action plan. The written asthma action plan should include the patient's usual asthma medications, when and how to increase medications and start oral corticosteroids, how to access medical care if symptoms fail to respond. This is an asthma action plan. It shows green, yellow, and red zones. In green, that is, there is no activity limitations, there is no problem, and their asthma is controlled. In yellow, we have to do for cautions, that is the proper checkup medications. If patients have some problems, then we have to look out for it. And red zone, it is an alert zone, that is danger zone. We should have close watch for the patient. It helps, medicine is not helping, breathing is hard and fast, nose opens wide. Then we have to look for its urgency. So it helps the patient and for us also. Then again, GINA assessment for symptom control, just I have mentioned. Then assessment of risk factors for poor asthma outcomes. There are potential modifiable risk factors for exacerbation. That is, our ICS is not prescribed properly, poor ICS adherence, incorrect inhaler technique, then high SABA use, low FE1, especially less than 60% predicted, higher bronchodilator reversibility, major psychological or socioeconomic problems, exposures to smoking, continued exposure to smoking, allergen exposure if sensitized. There are some comorbidities like obesity, chronic rhinosinusitis, or confirmed food allergy, sputum or blood eosinophilia, and pregnancy. The risk factors for medication side effects include, there are systemic, like frequent oral corticosteroids, long-term, high dose, and also taking P50 inhibitors. The local side effects are high dose or potent ICS, poor inhaler technique. Then the risk factors for developing fixed airflow limitations, mostly in preterm birth, low birth weight, greater infant weight gain, lack of ICS treatment, exposure to tobacco smoke, noxious chemicals or occupational exposures, low FE1, chronic mucus hypersecretion, and sputum or blood eosinophilia. These are having any of these risk factors increases the patient's risk of exacerbations even if they have few asthma symptoms. The control-based asthma management cycle. It has three components: assess, adjustment, treatment, and revive response. We have to assess the diagnosis. We have to assess the symptom control and risk factors, including lung function, the inhaler technique and adherence, and patient preference. Then we have to adjust the treatment, that is asthma medications, non-pharmacological strategies, treat modifiable risk factors and comorbidities, education and skills training. There is revive response. We have to revive the symptoms, exacerbations, side effects, patient satisfaction, and lung function. So we can categorize according to GINA. This GINA, it is categorized in newer modifications has came in 2021. Previously, up to 2020, there was different guidelines, and now we came with new guidelines in 2021. So they are categorized age-wise: less than 5 years, 6 to 11 years, 12 plus adult. There are some changes in most changes are occurs in 6 to 11 years. So we will discuss first 6 to 11 years. So the starting of treatment, 6 to years with diagnosis of asthma. We have to assess, that is confirmation of diagnosis, symptom control, and modifiable risk factors, including lung function. We have to deal with comorbidities, inhaler technique and adherence, child and parent preference and goals. Then we have to start treatment. In treatment, we have two categories: that's controller, that is preferred controller, then other controller options, and reliever. Controller means we have to maintenance the asthma symptoms, and reliever means we have to rescue the symptoms. So in preferred controller, as stepwise, when in step 1, that is the symptoms less than twice a month, we have to use step 1, that is low dose inhaled corticosteroids taken whenever SABA is taken. And the other controller options consider daily low dose inhaled corticosteroids. When the symptoms occur twice a month or more, but less than daily, we have to use step 2, that is daily low dose inhaled corticosteroids. And the other control option is daily leukotriene receptor antagonists, that is montelukast, or low dose ICS taken whenever SABA is taken. When there are symptoms most of the days or waking with asthma once a week or more, we go with step 3. In step 3, there are 3 modalities. First, low dose inhaled corticosteroids with LABA, or medium dose inhaled corticosteroids. Third, very low dose inhaled corticosteroids, formoterol, maintenance and reliever, that is MART. The other controller option in step 3 is low dose inhaled corticosteroids and montelukast. When the symptoms most of the days or waking with asthma once a week or more, and it includes the low lung function, we go with step 4. In step 4, we have to use medium dose inhaled corticosteroids, LABA, or low dose inhaled corticosteroids, formoterol, that is MART. And other controller options are add tiotropium and or add montelukast. In this step 4, GINA has mentioned tiotropium, that is, it is a long-acting muscarinic agent. And tiotropium is available as a inhaler in POPs. We can use it above 6 years. Previously, they are told above 12 years. Now they are told we can use it 6 years. So it is mentioning. This is a newer modality in step 4. Then there is a very low dose and low dose. We should look for the very low dose and low dose. In very low dose, it is budesonide formoterol, that is 100 micrograms and 6 microgram formoterol. And low dose budesonide and formoterol, it is 200 budesonide and 600 microgram formoterol meter dose. When the symptoms of the we have to go for the step 5. In step 5, if it is not controlled, step 4, then step 5, we have to refer for phenotypic assessment. Then higher dose of ICS, LABA or add-on therapy. Example is anti-IG, that is Omlizap. And other controller options are add-on anti-IL-5 and add-on low dose oral corticosteroids, but consider of side effects. So it is a simplified manner. I can explain in another slide, 6 to 11 hours. Again, in step 1, take ICS whenever SABA is taken. In step 2, when symptoms twice a month or more, you have to take daily low dose ICS. In step 3, symptoms most often days or waking at night or more than once a week, then low dose ICS, LABA, or medium dose ICS or very low dose, that is MART. In step 4, most symptoms most of days, waking at night more than once a week, and low lung function, then we have to use medium dose ICS, LABA, or low dose MART, or refer to expert advice. Then there are few changes of in children 5 years and younger. Again, we have to assess, that is exclude alternative diagnosis, symptom control, modifier, risk factors, comorbidities. Then we have to adjust, treat modifiable risk factors, comorbidities, and treatment, and review again symptoms, exacerbation, side effects. In this below 5 years, we have to controller and relievers. In mostly infrequent viral, wheezing, and no or few interval symptoms, we have to use step 1. And in step 1, there is no drug. Only we have to use sometimes reliever, that is short-acting beta agonist. When the symptom pattern not consistent with asthma, but wheezing episodes requiring SABA occur frequently, that is 3 times per year, give a diagnostic trial for 3 months. Then we have to use step 2. In step 2, preferred controller choices, daily low dose inhaled corticosteroids. Other controller option is daily leukotriene receptor antagonist, that is Montelukast, or intermittent short course of ICS at onset of respiratory illness. When there is a asthma diagnosis and asthma not well controlled on low dose inhaled corticosteroids, then we have to use step 3. In step 3, we have to double the low dose inhaled corticosteroids. And the other control option is low dose inhaled corticosteroids and Montelukast. When the asthma is not well controlled on double the dose of low inhaled corticosteroids, then we go ahead for step 4. In step 4, there is a continue controller and refer for specialist assessment. We can use other controller option like add-on Montelukast or increase ICS frequency or add intermittent ICS. Then another category of 12 years and adults. In this, Gina has mentioned 2 tracks. We can treat either track 1 or track 2. In track 1, we have to use controller and preferred reliever. In steps 1 and 2, when the symptoms has less than 4 to 5 days a week, we can use as needed as low dose inhaled corticosteroids formoterol. When the symptoms most often days or waking with asthma once a week or more, we can use step 3, that is low dose maintenance inhaled corticosteroids formoterol. When there are daily symptoms, waking or night, low lung function test, we can use step 4, that is medium dose maintenance ICS formoterol. And the reliever is needed at low dose ICS formoterol. And step 5, we can add LAMA, that is tiotropium, or refer for phenotypic assessment. You can use anti-IG, anti-IL-5, anti-ILR, and consider high dose ICS formoterol. Then Gina has mentioned again the second track, that is controller and alternative reliever again, the track 2. So in track 2, symptoms less than twice a month. In step 1, it is easy to take ICS whenever SABA is taken. And symptoms twice a month or more, but less than 4 to 5 days a week, we can use step 2, low dose maintenance ICS. In symptoms, most of the days or waking with asthma once a week or more, we have to go for step 3, that is low dose maintenance ICS LAMA. When the daily symptoms are waking with asthma once a week or more and low lung function, we can go for step 4, that is medium high dose maintenance ICS LAMA. In step 5, add on LAMA or refer for phenotypic assessment. Again, it is not that much confusing. It is simplified. Again, this track 1, track 2. It is easier to understand, but we can prefer track 1. In track 1, step 1, as needed, low dose inhaled corticosteroids formoterol. In step 2, as needed, low dose ICS formoterol. In step 1 and step 2, same. In step 3, low dose ICS formoterol maintenance and reliever, that is MARC. And step 4, medium dose ICS formoterol maintenance and MARC. In track 2, same. Step 1, take low dose ICS whenever SABA is taken. Step 2, low dose ICS as needed SABA. Step 3, low dose ICS LABA as needed SABA. And step 4, medium or high dose ICS LABA. This is some simplified steps. So the treatment may be stepped up or down, same reliever at each step, or switch between tracks according to the patient's need and preference. Then when to start ICS? For best outcomes, ICS containing controller treatment, it should be initiated as soon as possible after asthma diagnosis. Early initiation of low dose ICS in patients with asthma, it can help greater improvement in lung function than if symptoms have presented more than 2 years. Patients not on ICS with severe exacerbation have greater long-term decline in lung function than those who have already started ICS. Then dose of ICS, it's not a table of equivalence. The ideal dose which gives good control asthma symptoms. The low dose ICS most clinical benefit for most of the patients with asthma. And high dose ICS in combination or separately needed by very few patients. There is some chart of estimated clinical comparable doses of ICS. You can have in this chart, you can look at. Then step just I have mentioned, I will slide these steps. So the stepping down treatment with asthma is well controlled. Then consider stepping down treatment once good asthma control has been achieved and maintained for 3 months. To find the lowest treatment that controls both symptoms and exacerbations and minimize the side effects. We have to maintain for 3 months and then we have to decide. Then there are some non-pharmacological strategies and interventions. The smoking cessation advice, allergen advice, allergen avoidance, then avoid drugs probably triggering asthma. There are some common triggers for asthma symptoms, that is exercise, laughter. They should not be avoided. We can motivate the patients for yoga, pranayam. so that they can help their assessment. Then in immunizations, the children with asthma should receive all age-appropriate vaccines as any other child. But we can advise them influenza vaccines that as flu viruses can sometimes trigger asthma flare-ups. So we can advise them influenza. According to pneumococcal vaccine, there is no special recommendations for children with asthma. Then inhaled medication deliveries. We can use the deliveries for inhalation. 0 to 5 years is MDI with static treated spacer and mask. In below 5 years, we have to use the MDI with spacer and mask only. And above 5 years, you have the choice of MDI with spacer and mouthpiece. That is dry powder inhalation, DPI, and nebulizer is the second choice at any age. I can mention that there is an inhalation device because of drug deposition in airway. In MDI with spacer, it is mostly 10 to 20% is deposited in the air, and oropharyngeal it is less than 10%. Direct meter dose inhaler, 5 to 10% deposited in the airway, 40 to 60% in oropharyngeal deposition. Dry powder inhaler, it is 5 to 10% in airway and 40 to 70% oropharyngeal deposition. Nebulizer has few effect, that is 1 to 5% only in the airway and more than 50% oropharyngeal deposition. So mostly I mentioned that you should use MDI with spacer at whatever the age, below 5 or above 5. We can use MDI with spacer. In adult, we can also use MDI with spacer because it helps for the better outcome. Then I will go shortly for some acute severe asthma. A severe episode of asthma due to severe airflow obstruction which is refractory to the usual effective bronchodilator therapy. There are red flag signals, that is too breathless to talk, too breathless to feed, tachypnea, tachycardia, excessive diaphoresis. Then there are life-threatening features, cyanosis, feeble respiratory effort, fatigue or exhaustion, agitation, reduced level of consciousness. We have to investigate. There is hyperchromia, then hypoxia, metabolic acidosis, PEF less than 50%, FEV1 less than 30%, and chest radiograph may show pneumothorax, pneumomediastinum, and pulsus paradoxus more than 20 mm. The principle of management of acute severe asthma is the goal is to rapidly reverse the acute airflow obstruction with consequent relief of respiratory distress. Then assessment according to the acute severity of acute asthma, modified pulmonary index score less than 3 years. We have some points that is 0, 1, 2, 3 according to SpO2, accessory muscle use, IE ratio, V's, heart rate, respiratory rate. Then there is modified pulmonary index score. If it is less than 7, it is mild exacerbation. It is more 7 to 10, moderate exacerbation, and in severe more than 10. Then Baker asthma score. It has the score of 0, 1, 2, 3. It is depend on respiratory rate, wheezing, inspiration expiration ratio, accessory muscle use. It is again categorized. Less than 4 is mild, more than 4 is moderate asthmaticus, and score of 7 and above is severe and need of PICU admission. There is some algorithm of management of acute severe asthma. I will go fast. Child with acute asthma exacerbation, we have the clinical assessment. Then we have to do X-ray, ABG if needed, indicated. Then respiratory rate, wheezing, inspiration, I mentioned. The assessment of severity of status asthmaticus, admit when the Baker score is more than 7. We have to give supportive care, as you know, comfortable environment, IV access, maintain euvolumia, continuous cardiorespiratory monitoring, avoid sedation, monitor potassium, antibiotics if needed, if ventilation, arterial and venous access. Then we go for medications and ventilation. In medications, there is beta agonist, that is salbutamol nebulizer, MDI. Then we can use subcutaneous terbutaline, but terbutaline in India it is not available. So it is we have to look at. Then anticholinergic agents like apropium bromide we can use. Then corticosteroids of hydrocortisone 10 mg per kg IV stat, then 5 mg, or switch to oral prednisolone. Other medications are magnesium, theophylline, ketamine, epinephrine. Then indications for intubation. There are some absolute indications, that is cardiac arrest, comatose child, severe respiratory distress, silent chest exhaustion. And there are some relative, that is hypoxemia, hypercarbia, and metabolic acidosis. So in ventilation, non-invasive ventilation, invasive ventilation. Then non-invasive ventilation, it is positive pressure ventilation should be tried prior to conventional ventilations. We can use helix, that is helium oxygen therapy, may be responsible adjunct therapy. Then we have to go for treatment of comorbid conditions. In comorbid conditions, we have to treat allergic rhinitis, sinusitis. We can use intranasal steroid spray, budesonide, 100 microgram twice a day, or fluticasone, 50 mg once a day. And oral antihistamines we can use. Then we can treat gastroesophageal reflux. We can use anti-reflux treatment. Oral theophylline should be avoided. Then we have now COVID-19. So how could COVID-19 asthma? There are some myths that people with asthma at increased risk of COVID-19 or severe COVID-19. But the systemic reviews have not shown at increased risk of severe COVID-19 in people with well-controlled or mild to moderate asthma. Those with severe uncontrolled asthma increased risk of COVID death. So only in severe uncontrolled asthma. Have there been more asthma exacerbations during the pandemic? No. Many countries saw a reduction. Despite many countries saw a reduction in asthma exacerbations. During COVID-19, advise patients to continue taking their prescribed asthma medications, particularly ICS, inhaled corticosteroids. But nebulization, spirometry, we have to follow strict infection control practices so that we can avoid. And COVID vaccination in those with asthma allergies. Actually, those who's taking vaccine, those persons only for the component allergy, they have to think of taking vaccination. Otherwise, there is no contraindications. Thank you for listening for my presentation. I have made it in a simplified manner. Thank you for listening.
Thank you, sir. Now I request our chairpersons, Dr. Amit Deshmukh sir and Dr. Hari Vadode sir. Sir, Hari Vadode sir, kindly give the concluding remarks or any questions if you get from audience.
Yes. Thank you, Dr. Guru Prasad Pete, for giving such an excellent speech on pediatric asthma. Actually, it's very clumsy topic, but you have given in a simplified manner. Previously, we used to see a lot of patients with severe asthma. Nowadays, because of good controller and reliever, we are seeing very less patients. Thank you. Over to Anand.
Yes, sir.
One question for the audience for Dr. Guru Prasad. Hello.
Hello.
Yes, sir, you are audible.
Excellent topic.
How long ICS and SABA should be given in mild to moderate case of asthma?
Sir,
actually, from the audience.
Actually, sir, the GINA in 2021 has mentioned that we should use only ICS. SABA, SOS, it is discarded. That is only we have to use ICS. Only in reliever therapy you can use SAPA.
Okay. Thank you.
Thank
Anybody is
you.
having any questions?
Dr. Amit Deshmukh has joined. Do you
Hello.
want to share certain ideas, sir?
No, madam. Dr. Guru Prasad has given a very nice lecture and a very informative lecture. I don't have any questions from my side.
Yeah,
There is
definitely.
one question from the audience that what is the role of the adrenaline in asthma?
There is no role of adrenaline in asthma. Only an acute exacerbation we can use. But there is no, as such, Jina has not mentioned there is role of adrenaline in asthma.
Okay.
Ravi Shankar Zadav has raised his hand, I guess. Sir, do you have any question?
Sir, yes, I have one question. Excellent topic and discussion by Dr. Thete, sir. Congratulations. Sir, one question is that being pediatrician, it is very challenging to handle the asthma in pediatric age group. The chronic asthma in pediatric can land up the patient into chronic depression or anxiety. Then how to deal with the ADHD or autism disorders in asthmatic pediatric patients?
Actually, ADHD and in asthmatic, it is means quite difficult to treat at our level. I am not that much expert in that. We can refer him to the specialist in that field. So I cannot comment on this.
Thank you, sir. Such an informative lecture.
Thank you.
Please email the PPT to us.
Thank you, sir. Thank you, IMA, for giving me the platform. I am very much delighted and prepared these slides. Thank you, IMA.
Thank you, sir. Thank you, Thete, sir. We are enriched by vast experience and knowledge of yours. And thank you, chairpersons, Dr. Hari Vadode, sir, and Dr. Amit Deshmukh, sir, for joining us. Moving ahead, now there is last lecture of this session, that is pre-operative cardiac assessment, general and heart disease in pregnancy, to be presented by Dr. Amol Kotharkar, sir. And chairpersons for this session will be Dr. Parag Mahajan, sir, leading gynecologist from KHAMGAON, and Dr. Satish Gore, sir, leading physician from KHAMGAON. I request Dr. Satish Gore, sir, for a brief introduction of our speaker.
Hello, good morning, everyone. Welcome to today's special session. Myself, Dr. Satish Gore. I would like to introduce the presenter, Dr. Amol Kotharkar, sir. He is a very charming and eminent cardiologist from Buldana district. He did his MBBS from GMC Nagpur. He did his MD medicine from SSMC Rewa. He did his DNB cardiology, Sri Satya Sai Institute of Higher Medical Sciences, Bangalore. He has special interest in fellowship in interventional cardiology. In today's practice, pre-operative assessment of cardiac patient before non-cardiac surgery is common in clinical practice, and most non-cardiac surgical procedures are performed of the patients of advanced age who already having the ischemic heart disease. And in obstetric point of view, pre-existing cardiac diseases are major contributing for maternal mortality, and there is a higher prevalence of rheumatic heart disease in pregnancy. So Dr. Kotharkar, sir, will focus on this. So please welcome Dr. Kotharkar, sir, to present his topic.
Thank you, everyone. Today I will present two short lectures. Actually, they are pretty long slides, but I will try to cover them as early as possible. There will be heart disease in pregnancy and perioperative cardiovascular risk assessment in non-cardiac patients. So I will start with first with the heart disease in the pregnancy. 1 minute. I have to try it. Okay. I will share the screen. Okay. Okay. Now can I share my screen?
Yes, sir. Yes, sir. So you can,
sir, you can share.
Yeah. Okay. Thank you. Okay. So today's topic, first topic will be heart diseases with pregnancy. Pregnancy is a very physiologically is a very different transformation for a woman. It and the heart disease has a large burden in the on the patient in terms of economical cost on the economical cost, as well as maternal and fetal neonatal outcomes, as well as it has a large burden on the healthcare providers for managing such patients, because the mortality as well as outcomes of fetal and maternal outcomes are totally different from the general patients without heart diseases. So it becomes imperative to have a look at what exactly heart diseases do, and what are the variety of heart diseases which, and how much of the risk is to the mother and children during the pregnancy. So incidence of the heart disease is from 0.1 to 4% and average 1% during the pregnancy, and mortality to heart disease has decreased overall because of the better management, early diagnosis and treatment, and better healthcare facilities all over the world. But in developing countries, maternal mortality due to heart disease has increased. Pregnancy with heart disease has increased because of the better diagnosis and survival of the earlier diagnosis. Earlier, the patients with the heart disease used to remain undiagnosed, and there was before pregnancy itself they used to but now with the better survival, they are going into pregnancy and having pregnancy with heart disease. So this scenario has got complicated. So these are the variety of hemodynamic changes in normal pregnancy. Plasma volume increased by 40%, cardiac output by 43%, heart rate by 17%, mean arterial pressure 4%, stroke volume increased by 27%, systemic vascular resistance decreases, and pulmonary vascular resistance also decreases. So critical period of the pregnancies are changes start from 6 weeks, maximum changes around 30 weeks, intrapartum period just after delivery, and second week of the puerperium. These are the periods where the heart disease make greater impact. The symptoms of the pregnancy are like that of cardiac disease. So we may get confused that the patient may have some heart disease like breathlessness, weakness, edema of the feet, syncope. Patient may have tachycardia, physiological tachycardia, splitting of the first heart sound, murmurs. There may be some grade 2, grade 3 systolic murmurs, breast bruise, displacement of the cardiac apex. So these mimic the heart disease, and we have to differentiate the physiological changes in the body from the pathological changes. Symptoms of heart disease are like there is a progressive dyspnea, unusual in practice. If the patient is having unusual amount of dyspnea, nocturnal cough, syncope, chest pain, any hemoptysis, we have to be alert about the possibility of a cardiac illness. Clinical findings suggestive of cardiac disease are cyanosis, clubbing of fingers, persistent neck vein distension, systolic murmur more than grade 3, or presence of any diastolic murmur, cardiomegaly, persistent arrhythmia, persistent or fixed beating of second heart sound, and pulmonary hypertension. Investigations routinely we should the pregnant patients should go are ECG, echocardiography if there is suspected suspected cardiac illness, X-ray, chest, and cardiac catheterization. Cardiac catheterization is required very rarely. So symptoms can be classified as per the NYHA grade 1, 2, 3, 4. If there is minimal or no limitation, then it's a grade 1. If there is a mild limitation of the activity, we call it the grade 2. If there is a marked limitation of the physical activity and symptoms develop even with the minimal activity, then it's grade 3. And if the patient is having severe limitation or symptomatic at rest, then we call it grade 4 symptoms. These symptoms have a clinic prognostication, because prognosis of a patient in pregnancy and neonatal as well as maternal outcome depend upon the initial NYHA grade of the patient. So classification of heart disease according to etiology, there are congenital, non-cyanotic like ASD, VSD, pulmonary stenosis, coarctation of aorta, cyanotic like phallocetrology, Eisenmenger syndromes, and rheumatic heart disease, MS, MR, AS, AR, cardiomyopathies, pericardium cardiomyopathy, and other diseases, stress cardiomyopathies, ischemic heart diseases, and others like conduction defects, syphilitic, thyrotoxicosis, and hypertensive heart diseases. So classification, this is the old classification mentioned in the Williams textbook of obstetrics, where the heart diseases were categorized on the basis of low risk, medium risk, and high risk. Low risk is 1% risk, 0 to 1% of maternal mortality risk. So these are uncomplicated ASD, VSD, PDAs, stage 1-2 mitral stenosis, that is mild to moderate mitral stenosis, and corrected phallus tetralogy. Medium risk where the mortality is around 5 to 15%, that is moderate to severe mitral stenosis with atrial fibrillation, aortic stenosis, uncorrected phallus tetralogy. And very high risk where 25 to 50% mortality. These include severe PH, that is pulmonary hypertension, Eisenmenger syndrome, aortic coarctation with valvular involvement, and Marfan's with aortic wall involvement. These were the earlier classification as per the high risk. Now the WHO has come up with the maternal cardiovascular risk classification. These risk there are 4 categories of risk. That is risk 1 is no detectable increased risk of maternal and fetal mortality morbidity, and grade 2 is small increased risk in the maternal mortality and morbidity, and grade 3 is significantly increased risk, and grade 4 is extremely high risk. So they have categorized variety of heart disease according to these grades. So first is whose classification 1 is uncomplicated, small or mild risk is pulmonary stenosis, patent ductus arteriosus, and mitral wall prolapse. Or successfully repaired lesions such as ASD, VSD, PDA, anomalous pulmonary venous drainage. If they are repaired, there is no risk. Mild and atrial and ventricular ectopic beats isolated have also minimal risk. So these conditions actually we frequently encounter. A small ASD, small VSDs, no pH, and they come for the fitness. Then you can go ahead and give them fitness without much of the hurdles. If the ASDs have been repaired earlier, there are no there are no AF or anything. We can give them fitness without much issues. Like an atrial ectopics are also frequently asked for. If surgeon or anesthetist see some ectopics, they frequently send it to the physicians for fitness. I think we can safely, in the absence of other risk factors, atrial and ventricular ectopics can be safely given fitness. So conditions, because these have low risk. Then conditions with pregnancy, who 2 or 3. These include unoperated atrial septal defects, ventricular septal defects, repaired tetralogy of Fallot's, and most arrhythmias. Mild left ventricular impairment, like more than 45 to 50 more than 45% of EF, hypertrophic cardiomyopathy without much obstruction. Then native or tissue wall heart disease not considered 1 or 4, and Marfan syndrome without aortic dilatation, aorta less than 45 mm in aortic disease associated with bicuspid aortic wall, and repaired coarctation. These are the class 2 and class 3. So these also can be given fitness. Then who category 3, that is moderate to severe increase in the risk of maternal mortalities, mechanical valves, systemic right ventricle, then Fontan's circulation, cyanotic heart disease unrepaired, other complex congenital heart disease, and aortic dilatation more than 40 to 45 Marfan syndrome, and aortic dilatation more than 45 to 50 in aortic disease associated with bicuspid aortic wall. These are the high risk patients which will require, I think, referred to the higher center for cardiac management, for the obstetrical management as well. And who 3 categories, again same, mechanical valve system. The conditions which required who class 4 or pregnancy is contraindicated. These include pulmonary arterial hypertension, severe pulmonary arterial hypertension from any cause. If its RVSP is more than 70 or 75, we should tell the patient to avoid the pregnancy. Pregnancy has a very bad impact on the pH has a very bad impact on the pregnancy. It increased maternal mortality 25 to 50%. There is a risk of mortality, and it should not be. It's an absolute contraindication. Eisenmenger's or pulmonary arterial hypertension should be an absolute contraindication, because these patients do frequently come unrecognized ventricular septal defects, PDAs, and they come up with the echo report, and they ask us whether it should go pregnancy. We should firmly say no to these patients, that you should not undergo any pregnancy. These have frequently come to be, and when young patient, I mean like 20-30 years female, 21, 24, she came with I mean she was having a large VSG which was unrecognized in the earlier stage, and she underwent she recently got married, and they come to me. I said, you cannot undergo pregnancy because the pH is very high. And then she showed me the custody report. It was irreversible pH, so there was no point in operating for VSG as well, because the Eisenmenger is not going to regress to the normal levels. Then severe systemic ventricular dysfunction. LVF is less than 30% from any cause, like previous peripartum cardiomyopathy, previous history of heart failures. If the patient is having some other related cardiomyopathy and EF is less than 30%, it is an absolute contraindication for the pregnancy. Previous peripartum cardiomyopathy with residual impairment of left ventricle. If there is a peripartum cardiomyopathy in the previous pregnancy, and even if there is a minimal impairment of the LVEF, then such patients are also should not be advised to undergo pregnancy, because each pregnancy will impair her chances of survival as well as impair her LVEF further. Then severe mitral stenosis, which or severe symptomatic aortic stenosis, these are also contraindications for the pregnancy. Then again, Marfan syndrome with aorta dilated more than 45 or aortic dilatation more than 15 aortic diseases. These are also, like bicuspid aortic wall, these are also contraindications for pregnancy. And severe coarctation, unrepaired severe coarctation is a contraindication for pregnancy. So maternal predictors of neonatal events in women with heart disease are baseline class NYHA class more than 2 or presence of cyanosis, maternal left heart obstruction like mitral stenosis, aortic stenosis, coarctation, multiple gestation, smoking during pregnancy, use of oral contraceptive, oral anticoagulation during pregnancy, and mechanical heart wall prosthesis. These are the diseases and symptom clinical profiles which are associated with the bad fetal maternal fetal outcomes in the pregnancy. So again, same. If there is history of heart failure, ischemic attack, stroke, arrhythmias, baseline NYHA class 3-4, mitral wall area below 2 centimeters square, aortic area below 1.5. These are, and ejection fraction less than 40%. Same we have discussed just now. So additional risk factors which can complicate the course of a patient with heart disease in pregnancy is anemia, infection, hypertension, physical labor, weight gain, multiple pregnancy, caffeine, alcohol intake, pain, drugs like tocolytics. This can further increase the heart failure in a patient with the pregnancy. So worsening of the cardiac status will be there. Congestive cardiac failure may occur, bacterial endocarditis, pulmonary edema, pulmonary embolism. These are complications which can happen. So effects of heart disease in pregnancy, there is increased chances of abortion, preterm labor, IUGR, and there is a 5% chance that the patient with a congenital heart disease undergoing pregnancy will have a child with a heart disease at 5% chance of having a baby with a congenital heart disease. And there is also chances of intrauterine fetal demise. So management requires first is high index of suspicion, timely diagnosis, effective management. Obstetricians, cardiologists, anesthetists, neonatologists, CTVS surgeon, and nursing staff, all as a team you have to manage this patient, specifically the patients which grade 2 or grade 3 of the hook classes. No pregnancy unless must in, especially in high risk type of patient, should be avoided. Pregnancy should be avoided. Maternal mortality varies directly with the functional classification. NYHA functional class is the most important initial if the patient is having class 3, class 4 symptom, you should always tell the patient that should avoid the pregnancy. So NYHA class is a very important predictor of the outcomes. Then again, counseling, optimal medical management, counseling like maternal fetal risk, prognosis, social and cost consideration, because economical burden is very high for managing such patients. Even after that, this is not, it's not going to be easy. Pregnancy is not the only issue these patients are going to have. These are their own disease is going to linger on for lifelong. So we have to think about all those things and counsel them about the things. Hospital delivery is preferred in a tertiary care center. So medical termination of pregnancy should be advised in a patients with class 4 WHO criteria, WHO, that is pulmonary hypertension, Eisenmenger, coarctation of aorta, unrepaired, Marfan syndrome with dilated aorta. This patient should be advised termination, and it should be done in the first trimester itself, and suction evacuation is preferred. MTP also carries the risk for the life in these patients. So antenatal care, clear counseling of the risk and prognosis. On each visit, patient's physiology should be noted, like pulse rate, BP, symptoms, anemia. If anemia is there, anemia should be corrected, and treatment compliance. The fetal echo also should be done, because there is a chance of having a child with a cardiac illness, because 5% chance. Fetal monitoring also should be done. Rest, avoid undue excitement and strain. Diet, iron, vitamin, usual obstetric care. Dietary salt restriction should be there. Smoking and drugs and anything that increases the chance of failure, like infection, should be treated. Anemia should be treated. Avoid smoking, drugs. This should be carried out. Then patients, wherever there is a therapeutic prophylactic, like the patients should have a penicillin prophylaxis, like if the patient is known case of rheumatic heart disease, then heart failure treatments, therapeutics like diuretics, beta blockers, digitalis, and anticoagulant should be installed. Whenever there is a possibility, if a patient with severe MS comes and she wants to continue the pregnancy, she should be advised balloon mitral valvotomy before after the even during the pregnancy. We have done that in Satya Sai. We can get that done after the period of embryogenesis, after covering that uterus of the patient with the radiation gowns, and if that helps, and because you can get, even if you get a small dilatation of the mitral area, that will go a long way in survival of the patient as well as the fetal outcomes. So balloon mitral valvotomy, whenever possible, should be done, should be advised to the patient if it's feasible. Otherwise, there will be very high risk of the fetal and maternal outcomes. So indications for admission: NYHA class 1, 2. Before the if there is a functional class is 1 and 2, then you can expect a day 2 weeks before the expected date of delivery. NYHA class 2, 28 to 30 weeks. NYHA class 3, 4, irrespective of EDD, as soon as the patient comes, you should admit the patient. And NYHA class 3, class 4 should be monitored in hospital. And change from oral anticoagulant to heparin early should occur at 36 weeks of the pregnancy. Emergency admission, again, these are the deterioration of the patient, symptoms and signs of complication like fever, persistent cough, basal cramps, heart failure symptoms or infective endocarditis, new onset murmur, anything. If you feel abnormal, patient should be admitted to the hospital. Again, labor, these are usual labor management issues. Induction of labor is only for the obstetric indication. Oxytocin is preferred. Intracervical Foley's installation, especially in congenital heart disease. PGE2 gel may be employed. Management of the first step confined to the bed, intermittent oxygen, sedation, analgesia, cautious use of IV fluid. Anticoagulation should be stopped. Digitalize if the patient is in heart failure. Diuretic in pulmonary congestion, deriphylline in bronchospasm, prevention of infective endocarditis, and cardiac monitoring and pulse oximetry, evaluation by the anesthetist cardiologist. That should be in stage 1 level if possible. Then in infective endocarditis prophylaxis, not recommended for all patients, but very severe lesions, that is class 3, class 4 WHO IA. Management of second stage of labor, delivery in propped up position, avoid forceful bearing down, cut short the second stage of labor, episiotomy, vacuum, forceps, and not always must, and strict cardiovascular monitoring. Then oxytocin should be given. Third stage, again, I am not much about those labor issues, but thing is, there is a chances of failure in the this patient's peripartum as well as so you have to keep watch on the presence of heart failure or presence of the development of heart failure or deterioration in the signs and symptoms of the patient. Again, same. So LSCS is again mainly for the obstetrical indication. coarctation of aorta, and the patients with Marfan's with dilated aorta. If these patients come to us, then we can send them for LSCS. So reassessment every 6 weeks, and cardiological consultation is after the discharge is needed. So contraceptive advice at the time of discharge, barrier contraceptives are preferred. Progesterone can be a good option. IUCD is less preferred. Oral contraceptives are contraindicated. Sterilization, vasectomy is better. Tubal ligation, interval, or peripheral can be done. So this was all about the pregnancy and heart diseases. I will go. Should I go to the next preoperative assessment topic, or any questions about this?
Sir, we will take questions at the end only.
Okay,
you can go ahead, sir.
Okay. I'll go for the next. So, just 1 minute. So this is actually this is very detailed lecture about perioperative cardiovascular evaluation and management of the variety of drugs during the non-cardiac surgery. But I will just very briefly, and I will try to cover it briefly and focus on the points which matter to us most. Mostly that is acute coronary syndrome, angioplasty patients, and patients with risk factors but without angioplasty. So these are the 3 categories we will have to deal during the non-cardiac surgery workup. So and variety of diseases like first valvular heart diseases, then what to do with the valvular heart disease assessment. It is recommended that patients with valvular heart disease, moderate or greater degree of valvular stenosis or regurgitation undergo preoperative echo should be done. If there is no echo done within the last 1 year, or a significant change in the clinical status of the patient. So if a patient is having moderate or severe stenosis or regurgitation of any wall, and there is no echo done within last 1 year, and there is significant change in the symptoms of the patient, then echo should be repeated. Then again, aortic, there is an increased risk of non-cardiac surgery in patient with aortic stenosis, but elevated, and they can undergo non-cardiac surgery with elevated risk if there is if there is asymptomatic severe AS. Again, mitral stenosis, elevated risk of non-cardiac surgery using appropriate intraoperative and postoperative hemodynamic monitoring may be reasonable in asymptomatic patient with severe MS. Severe MS and severe AS patient, there is a even if they are asymptomatic, there is a elevated risk of non-cardiac surgery. Elevated risk of again, this was class 2B and this is class 2A for the aortic stenosis, whereas for mitral aortic regurgitation there is also elevated risk of cardiac outcome in cardiac outcomes in patients with non-cardiac surgery if there is a severe MR or severe AR. Again, okay, now pulmonary vascular disease. If there is a chronic pulmonary patient is on chronic pulmonary vascular disease patient, specifically those who are having RVSP more than 70, RV dilated or dysfunction of the RV, or increased pulmonary vascular resistance, or class 3, class 4 symptoms. These patients, pulmonary vascular disease, have a elevated risk of elevated risk of mortality and morbidity after the non-cardiac surgery. So these patients, if undergoing any vasoprotective therapies like 5-phosphodiesterase inhibitor or other anti-pulmonary hypertensive therapies, then they should be continued during the non-cardiac surgery. Then calculation of the risk in the perioperative risk in the cardiac morbidity. So there are variety of scores available for calculation of the risk, like RCRI, which can measure the event rate in a non-cardiac surgery patient. So we can Duke's activity score index is also there. So can you these are the activities, variety of activities if a patient can undergo then I think the risk of cardiac surgery is reduced. If can you take care of eating, dressing, bathing, using, then weight is 2.75. Walk indoors such as around your house 1.75. So as the activity increases, his risk of surgery reduces. So this course help us to gauge the activity level of a patient. So now we'll come back to the cardiac assessment in a patient with suspected coronary artery disease or established coronary artery disease. If the patient is scheduled for this flowchart will help us. If the patient is scheduled for surgery with known risk factor for coronary artery disease like diabetes, hypertension, previous CAD, family history, dyslipidemia, or smoking, then if the surgery is emergency, then without much hesitation we can go directly to the proceed to the surgery. If there is no emergency, then we have to check whether the patient is having ACS or not. If there is yes, then evaluate and treat according to first treat the ACS, because the risk of ACS is more to the life than the surgery, any other surgery. So if there is no ACS, then again go to the next slide. If there is no ACS, then estimate perioperative based on the combined clinical surgical risk. That this course will calculate on the basis of RCRI. If there is a low risk, no further testing is required, can proceed to the surgery. If elevated risk, more than 1% risk is there, then we can subject the patient for the treadmill stress testing. If he can tolerate more than 4 minutes, it is excellent. And more than 10 minutes, no further testing, we can proceed to the surgery. If 4 to 10 minutes, no further testing again, and you can proceed to surgery. If less than 4, if he cannot exercise more than 4 minutes, then we can subject him to the pharmacological testing like dobutamine stress echo. If it is normal, proceed to the surgery. If it is abnormal, then only coronary angiography and address the lesion, and then we can proceed for surgery. So role of ECG in a perioperative assessment. Preoperative 12-lead ECG, reasonable patient with known coronary artery disease, significant arrhythmia, peripheral arterial disease, cerebrovascular disease, or significant structural heart disease, except for those undergoing low risk. Low risk surgeries like cataract surgery and all those normally do not require cardiac assessment. But most of the actually we are working in a very peripheral area and nobody wants to take the risk. So even the cardiac patients come for, a cataract patient come for the fitness, and it is reasonable. Reasonable working, no backup settings. It's reasonable to get everything done. Nobody wants any surprises on table. Routine preoperative 12-lead is not useful in asymptomatic patient undergoing low risk surgeries. LV function. It is reasonable to assess the LV function by echo if undergoing. It is reasonable to for patients with heart failure, worsening of dyspnea, and other changes in clinical status. Reassessment of LV function in clinically stable patient with previous documented LV dysfunction may be considered if he has no assessment within a year. Routine preoperative evaluation of echo is not recommended. So exercise stress testing for functional capacity. If the patient, again we have saw that in the flow chart, if patient can tolerate more than 10 minutes of exercise on TMT, then it is further testing is not required. And elevated, if again 4 to 10 minutes, also we can take a risk and a patient can undergo the surgery. For patients with elevated risk, that is who cannot tolerate more 4 minutes of exercise on the treadmill stress testing, it may be reasonable to perform exercise testing or cardiac imaging like dobutamine stress echo, and then manage such patients with further. Cardiopulmonary exercise testing may be considered in patient undergoing elevated risk of procedures in whom functional capacity is unknown. So non-invasive pharmacological testing like dobutamine stress echo should be done in patients with less than 4 minutes and 4 minutes on TMT. Routine preoperative coronary angiography is not recommended. It should be I mean, it should have a very strong clinical judgment, clinical suspicion that the patient is having or the patient is having ACS. Then only you should send the patient for coronary angiography. Routine coronary angiography is not indicated before any preoperative checkup. So again, perioperative therapies. Coronary revascularization before the cardiac surgery is recommended in circumstances where revascularization is indicated according to guidelines. That is ACS, and if the patient on dobutamine stress echo is required, that is a patient who cannot tolerate 4 minutes of exercise and TMT, very high risk of bad outcomes on the during the surgery. Such patient should be coronary revascularization should be considered. And again, timing of elective surgery after in the patient is previous PCI. In the elective non-cardiac surgery should be delayed 14 days after only balloon angioplasty and no stent implanted, and 30 days after the BMS implantation. And elective surgery should be deferred beyond 365 days after the DES implantation. In patients in whom non-cardiac surgery is required, a consensus decision among the treating clinician as to relative risk of surgery and discontinuation or continuation of the antiplatelet can be useful. Elective non-cardiac surgery after DES implantation may be considered after 180 days if the risk of further delay of the surgery is greater than the risk of ischemia. Elective non-cardiac surgery should not be performed within 30 days of BMS implantation or within 12 months of DES implantation, in whom DAPT will need to be discontinued perioperatively. Elective non-cardiac surgery should not be performed within 14 days of balloon angioplasty in patient in whom aspirin will need to be discontinued perioperatively. So beta blockers, perioperative beta blockers should be continued in patient undergoing surgery who have been on beta blockers chronically. It is reasonable for management of beta blockers after surgery to be guided by clinical circumstances independent of whether the agent was started. In patients with intermediate or high risk myocardial ischemia, pre-operative risk stratification test, it may be reasonable to begin perioperative beta blockers. Again, the patients with risk factors like diabetes, heart failure, CAD, renal insufficiency, it may be reasonable to begin beta blockers before the surgery. In patients with compelling long-term indications for beta blockers, initiation of beta blocker in the perioperative setting is an approach to reduce the perioperative risk is uncertain benefit. Beta blocker therapy should not be started on the day of surgery. That is very important. That is a harm. If he is already on the beta blocker, continue beta blockers throughout the surgery. If there is a compelling indication, start the beta blockers before the surgery, but not on the day of surgery. Perioperative statin, again, statin should be continued in patients currently taking statin and scheduled for non-cardiac surgery. Perioperative initiation of statin is reasonable if there is a patient is undergoing vascular surgery. Perioperative initiation of statin may be considered in patients with clinical indication according to guideline-directed medical therapy who are undergoing elevated risk procedures. Again, ACE inhibitor and ARB also should be continued if they are already on the ACE inhibitor or ARBs for hypertension or other cardiovascular indications. Antiplatelets, again, in patients undergoing urgent non-cardiac surgery during the first 4 to 6 weeks after BMS or DES implantation, DAPT should be continued unless the risk of bleeding outweighed the benefit of in the prevention of stent thrombosis. In patients who have received coronary stents and must undergo surgical procedure that mandate discontinuation of the P2Y12 inhibitors, it is recommended that aspirin be continued if possible, and the P2Y12 inhibitor receptor be restarted as soon as after the surgery. Management of perioperative antiplatelet therapy should be determined by the consensus. In patients undergoing non-emergency cardiac surgery, it may be reasonable to continue aspirin when risk of potential increased cardiac event outweigh the risk of increased bleeding. Initiation or continuous aspirin is not beneficial in patients undergoing elective non-cardiac, non-carotid surgery who have not had previous coronary stenting. So aspirin can be discontinued in patients who didn't have any stents. So stent ACS and stents are the indications, very strong indications to continue DAPT for 1 year. If most of the stents these days are DES. So practically BMS and balloon angioplasty are out of question. So 365 days are the after the stent implantation, you have to continue the DAPT. After 1 year, you can continue aspirin throughout the surgery, can continue P2Y12 during the surgery if the patient has received stent or patient had ACS. And in a patient who does not have ACS or no stent implantation, you can stop both DAPTs. DAPTs mean aspirin. You can stop. Most of the time we give aspirin only in such patients like diabetic, hypertensive, and all those. We can stop aspirin during the surgery. So again, this same flow chart. Patient with coronary stent, stent implantation less than 4 to 6 weeks. Elective surgery. Yes, delay the surgery up to 30 days after BMS and 365 days after the death. No elective surgery, continue DAPT unless risk of bleeding is greater than the risk of stent thrombosis. Again, if the stent implantation is less than 4, no. If the days is more than 30 days, but less than 365 days, risk of surgical delay is greater than the risk of death thrombosis. These are two flow charts, two arms. Then again, proceed to surgery after 180 days. Delay surgery until after optimal. Yeah. After 180 days, if it is delay in the surgery is not harmful, then we can delay. And if there is again this if already more than 365, does surgery demand discontinuation of P2Y12? Just now we discussed that after 1 year, continue DAPT regime if there is bleeding risk is low, and continue aspirin if there is bleeding risk is high, and start P2Y12 immediately after the surgery. Again, there's ICD and all that. Pacemakers, just not much. Anesthetic consideration. Either use of volatile anesthetic agents or total intravenous anesthesia is reasonable for patient undergoing non-cardiac surgery. The choice is determined by the factor other than the prevention of myocardial ischemia. Neuraxial anesthesia for post-operative pain relief can be effective in patient undergoing abdominal aortic surgery or to decrease the incidence of perioperative MI. Perioperative epidural anesthesia may be considered to decrease the incidence of preoperative cardiac events in patients with hip fracture. Prophylactic intravenous NTG is not effective in reducing myocardial ischemia in patient undergoing non-cardiac surgery. It is, earlier they used to do this. Now nobody does that. Again, they are tertiary care center things like transesophageal echocardiography and all that. So these are not much here. Again, euthermia, normothermia should be maintained during the surgery. Again, hemodynamic assist devices. These are tertiary pulmonary artery catheters for the management of hemodynamic during the non-cardiac surgery. Normally, we don't do that. Very few centers do it. Even in Satya Sai, we used to see that only in the post bypass cases. So these were the two topics. Any questions regarding them?
Thank you, sir. Thank you, Dr. Sir. You covered everything which we want during the giving fitness and giving continuity and discontinuing the antiplatelet drugs during pregnancy and during non-cardiac surgeries. Very excellent presentation, sir. Very excellent.
Thank you, sir. Thank you.
Thank you, Dr. Sir, for your amazing concept.
Sir, mute ho.
Just a minute.
Thank you, Dr. Kothadkar sir, for your amazing concepts. Now we will have lunch break and we'll be back in half an hour. Post-lunch session will be with Dr. Aniket Mende. We will be back by 2 p.m. Thank you, all delegates, all speakers, and all chairpersons. It was really educational session for us. We will meet by 2 p.m. Thank you.
Thank you.
Thank you, Kothadkar sir.
Thank you, sir. Thank you for giving me opportunity to speak.
Thank you, Parag Mahajan sir. Thank you.
Kothadkar sir, please share your slides to me.
Yes, sir. Yes, sir. I will share. Definitely, sir.
Okay, sir. Thank you, sir.
Thank you, sir. Thank you. हा काय झालं दिलं
अब ये भी देखिए ना, ये किया तो हाँ, गुड मॉर्निंग सोनी सर।
मॉर्निंग। क्या होते हैं सर जी?
क्या चल रहा है? आपका एक लेक्चर
मेरा हो गया ना बाबा सुबह ही।
अच्छा भी, अच्छा आनंद राठी का है क्या?
नहीं नहीं, आनंद रठी का कहाँ से? वो तो
सर
ये
गुड
है।
आफ्टरनून, लंच ब्रेक चालू है सर।
अच्छा लंच ब्रेक है?
हाँ, 2 बजे चालू हो जाएगा सर अभी।
और लंच आया नहीं मेरे पास, भेजो रहा लंच।
वो घर का लंच है सर।
घर का लंच है सर।
क्या हो रहे?
घर का लंच है, घर का लंच ब्रेक है।
अब तो घर
लंच
का
प्रोवाइड करना था यार
भेजो,
आनंद।
घर का भी
हाँ
चलता है।
लंच
अब
प्रोवाइड करना था
किसके
तुम
घर का है
लोगों
कि
को।
किसके घर का है?
बिल्कुल सर। सीएमई की अपनी पार्टी रखेंगे ना अपन,
हाँ,
ये
सेक्रेटरी
लंच
पार्टी। हाँ।
आपने एक प्लेट सजा के रख दे, ये बना ये लंच है बना।
Sir, we are live.
ऑनलाइन
Sir,
ऑनलाइन
just,
लंच।
sir, we are live.
इसमें तो वैरायटी ऑफ डिशेस रख सकता है यार, तेरे को क्या एफर्ट्स
Hello,
लेने।
Dr. Gopal, Dr. Anand, Dr. Ashish. We are live. It is getting broadcasted. Just for your information.
ओके ओके ओके,
सॉरी।
Thank you.
इट इज गेटिंग ब्रॉडकास्ट।
Hello, am I audible? John sir, namaskar.
Good morning. Good
Good
morning,
afternoon.
madam.
झालं जेवण झालं की नाही? Good
चला
afternoon.
वानखेडे आलेत का वानखेडे
आहे
ऍज
ना,
युजल
Online
दिसला
ऍज
दिसला.
युजल
आहे हो मॅडम. तो कुठे जाणार नाही आम्ही असल्यावर.
नाही तो दिसत नाही ना सर.
बघा
अरे बाबा आम्ही
नाही
असल्यावर
लॉग
मी
आउट
आणि-
झाला तो. लॉग
नाही,
आउट
नाही,
झाला.
अच्छा
होता
येईल
पण
येईल.
लॉग आउट झाला.
येईल.
चालू करू. Hello friends, I myself Dr. Atul Rajput, Treasurer, IMA KHAMGAON, welcomes you all. Let's start the session with our hunger for knowledge. To open this session, I welcome Dr. Sean Chinchole sir. His topic is approach to red eye in general practice. This session will be chaired by Dr. Anand Junjunwala sir and Dr. Mende madam. Introduction by Dr. Mende madam.
मॅडम अनम्यूट करा. मॅडम अनम्यूट करा. मेंढे मॅडम.
Now start, madam.
Dr. Sean Chinsole has passed MBBS in 1995 from Nagpur University. He has done his post-graduation in JJ Medical College, Davangere, Karnataka. He has done fellowship in phacosurgery at Lions Nap Eye Hospital, Mirrors. He has done fellowship in medical retina, especially in diabetic retinopathy at Arvind Eye Hospital, Madurai. He is holding the post of director at Vasanta Prabha Arogya Seva Pratishthan, Buldhana. He is also director of Vasanta Prabha School of Nursing. He is past IMA secretary from Buldhana IMA branch. He is a member of Buldhana Ophthalmic Surgeon Society, organizing secretary. He is also secretary of Vidarbha Ophthalmic Society. He had joined in government hospital as a district ophthalmic surgeon in 2000, and he was there till 2006. He performed more than 50,000 of cataract surgeries. He practiced as an ophthalmic surgeon at Chinsole Eye Hospital and Laser Center, Buldhana. He has been awarded with Best Performing Surgeon. He is also awarded with Dr. Ishwar Chandra Award in Vidarbha Ophthalmic Society. He has awarded National Blindness Control Program by Government of Maharashtra. He is doing charitable work as a free cataract surgeries in tribal area, free eye camp in rural areas, Lake Vatsva Abhiyan, Save the Girl Child, free diabetic retinopathy screening program, and glaucoma awareness program. Herewith, I am presenting Dr. Sean Chinsole with us as a speaker.
Hello. Hello. Am I audible? Hello.
Yes.
Yes.
Yes, loud and clear.
I think I can't share this. Yeah, it is there. Okay. Can you see my screen now?
Yes, sir.
Yes.
Now?
Yeah,
yes,
we can see.
Yes. Good afternoon, everyone. Thank you, KHAMGAON branch, IMA branch, for inviting me as a speaker. And thank you, madam, respected ma'am, Mende madam, my dear friend, my brother, Anand Junjunwala, and all respected dignitaries. So the topic is for everyone, and topic is very interesting for each and every field, because everyone has to face this problem in their routine work. To start with, how to approach for red eye in general practice. Give me 1 minute, please. Yeah. The common causes for red eye is injury, pink eye, blepharitis, uveitis, allergies, corneal ulcers, dry eye, cold, eyelids. Hello.
I'm sorry,
yes.
we cannot see the slides moving. We can see only the first slide right now.
Okay. Okay.
No.
Just give me 1 minute.
No problem.
Now?
Yeah, we can see the first slide. Yeah. Now it's moving.
Okay. Is it okay now, Anand?
Yeah. Yes.
Okay.
Yeah, sure.
Yes.
Go ahead.
The common causes for red eye is injury, pink eye, blepharitis, uveitis, allergies, corneal ulcers, dry eyes, cold, eyelids dry, acute glaucoma, scleritis, and subconjunctival hemorrhage, and other use of contact lenses, which can lead to overuse or misuse of the contact lenses. Patient with red eye in OPD, how to go for it? Just see how the patient presents with you, whether it is a mild or pricking pain, because this is more important. Because see, if the patient is presenting in a different way, you can judge whether it is acute, chronic, or whether we can do it in an emergency way, or we can refer to doctor or ophthalmologist. So if it is a mild pain, then there must be some small foreign body. Herpes simplex keratitis, which is very common and it is a chronic one also, because so many times patient present with this type of redness and ulcers with you, and even in the general practitioner we have to treat in accordingly. There is also a mild pricking pain in bacterial conjunctivitis, dry eyes, episcleritis, and contact lens wear, where the discomfort will be there with the contact lens, or there must be some foreign body sensation, or must be some dust particle in the contact lens, and patient present with redness and mild pain. But if the pain is mild, you can treat it accordingly. But if the moderate to severe, if the patient is coming with a high grade of severity, if patient is saying, no, I'm having severe pain, I can't tolerate that pain. So in OPD also, you can just manage like what to do next. So if the patient is having uveitis or scleritis, he will get a severe pain. Then angle closure glaucoma, which is more important, because sometimes these changes had been missed in a general practice or in a routine OPD patient. Penetrating trauma is there, where the patient will get a severe pain. Then chemical injuries are there. These are very common nowadays because lots of industrial areas are there, lots of home traumas are there. So these are all chemical injuries which comes in with the severe pain. You have to judge it accordingly and you have to treat accordingly. If photokeratitis, this is also a very common cause nowadays going on. Then welding work trauma, this is the most important. Nowadays, welding work, those who are the patients, they directly come to general practitioners or to the common OPD where they can find, okay, now I'm having this normal problem. But if it is a severity is there, you have to treat accordingly. Then herpes zoster keratitis, because herpes zoster simplex patient won't present with a severe infection. But if it is a herpes zoster keratitis, there will be associated pain and headache also, and that pain will be towards the unilateral side. Like if it is on the right side, the pain will be only on the right side. It will not be on the left side. So these are the common things which we can consider, and we can go ahead with the same thing. Just give me 2 minutes, 2 seconds. Okay. Now, another point to note is itching or discomfort. Now, if the severity is not there, but if patient is coming with the discomfort, definitely nowadays very common, that is aankh आई हुई है. Viral conjunctivitis is very common nowadays. Then allergic conjunctivitis, which present with बहुत खुजली आ रही. The patient will say, I'm getting scratching, irritation, and I'm not comfortable with everything. Even though he is not presenting with more redness, but he will more present with conjunctivitis. So sensitivity to any drugs also is there. Cannuculitis and blepharitis. Blepharitis is also very common nowadays. Now the fourth point is whether the pain, if there is no pain, but there is only redness. This is very important because patient will not present with any discomfort or any pain. He don't find any problem with his red eyes, but those who are just in front of him or any side by anyone is there, he will just say, "Bhai, tumhari aankhein bahut laal hui hai. Why your eyes are so red? Just go and check with your doctor." So these are the common things to be considered. If there is no pain, no discomfort, but redness is there, definitely that will be a subconjunctival hemorrhage, which is very common nowadays. Pingula and pterygium. Pterygium will be there. We can just see the redness, but the patient will say, "I don't have any problem, but only redness is there," and that will persist, and duration is also there. You can ask the duration, whether it will be in the morning or in the afternoon or it will be in the evening time. Now, this is for the babies. Like why babies present with redness or pink eyes, babies, because there is sometimes we are overusing of antibodies also. Antibiotics are started. If the baby is having home treatment or home delivery is there, or delivery by not with a good gynecologist or any good institute, the bacterial infection will be there, and that leads to redness, pus drainage, and eyelid. These are the common causes. Even gynecologist will observe, even a pediatrician will observe, and even a normal general practitioner will also observe. So these are the things to be considered. Then bacterial infections, like why this pink eye will be there in kids, like early eye discharge will be there. Along with that, ear infection will also be there, and lid swelling is there. I have to differentiate with this with bacterial, then viral infection and allergies also. If only with the allergy is there, sometimes with the powder or any solution or any lotion, then there will be only tearing will be there, sneezing, scratching will be there, and involvement of both eyes will be there. These are the most important. And if there is a foreign body, then it will be a uniocular. Only one eye will be involved, not the other one. Blockage of tear duct. This is the common problem for so many kids. Like whenever they are coming to pediatrician, gynecologist, they will just say कि पानी बहुत आता है, the watering is there. So that watering will be just because of, not only because of all these consequences, maybe he is having congenital dacrocystitis or there is any other problem also. Yes, this is more important. When the patient come to your OPD, do we really need to ask? Yes, I will say yes, yes, and yes. You should ask, always ask leading questions to your patients, because sometimes if you will not ask the leading questions, you will be in trouble of prescribing the drops, because patient will not say that what has happened. He will directly come, no, I am having just redness, just go and check. But you should ask him a leading questions, because when you will ask him the leading questions, then only you will expect what you want. Otherwise, he will just say, "No, doctor sahab, now you give some drops, I will go." But before giving or prescribing any drops, because so many times some drops are really helpful and some drops are really hazardous for eye. So I will ask each and every general practitioner or practitioner to ask such type of leading questions, which are definitely help you for further treatment. So first you ask the history of trauma. Even though he will say, no, nothing, since morning I am not doing anything. But you are just ask him that since morning what you have done. Like, have you done any work, or have you done any gardening? Have you done any field work? Have you been to farm? Have you been to any factory? Have you been to any allergy? Have you been to with any chemical solution? These are the things to ask, because so many times when we ask the patient will say, no, nothing has happened. Just since morning I got up and I got this redness. I don't know why. And even I don't have any problem. He was not having any problem because his vision is absolutely normal. He was not having any irritation, or he was not having, only he was having some itching, or he was having some foreign body sensation. So he will just say, just morning se redness hui hai, but after that I'm comfortable. But just to I'm getting scared of that redness. I just want to show to physician. So ask for any history of trauma, any history of illness. This is more important, because some allergic and related to reaction to skin lesions are directly proportionate to redness of your eyes. So this redness can lead to irritation, and that leads to further again some complication that will definitely hamper his visual disturbances. And to treat the patient at the beginning and to send to the ophthalmologist, it's totally a scenario to have such type of cases and to treat in a long way. Self-meditation and self-treatment. Yes, that is very, very, very important, because before coming to physician or general practitioner, patient will definitely had some homemade treatment or self-made treatment. He goes to a chemist, he goes to a drug where he will get normal drops, and those drops, I don't know why those drops are towards normal side. Most drops are to be prescribed by a chemist is a steroid drops, and that will definitely hamper his vision, and the further complication will be there. This is happening with us. So ask him that whether you are treated for yourself with any drops or anything. Then you should ask for any home remedies. This is very common in our side, because we are all working in a rural area where we can see all the patients are having their own home remedies, milk, ghee, then turti se pani, then lot of normal herbs they are putting. They are doing, so many babas are treating them like anything, and they are taking and they are following them. So we should take care of that, like whether patients are taking any home remedies or not. Because if patients are taking any home remedies, You should ask him that what home remedies you are taking. These are the leading questions, because even though if you are asking them, they will just say, no, काहीच नाही टाकलं, सकाळपासून फक्त डोळ्यात कचरा गेलं आम्ही गेलं. Ask his relatives, ask his wife is there, ask the husband, because if mother is there, ask the daughter, because they must be having some home remedies which will hamper your treatment. Because even if something went wrong, they will just bring and ask your doctor, sir, you have given this drop and nothing, no, kuch bhi farak nahi hai, and some problem is there. And when they will go to ophthalmologist, he will say, no, this drop is of no use. They will not say that they had some home remedies at home. This thing happened with us, because when at a tertiary level the patient comes to us, we have to ask them for the leading question. Then we will come to know, since 4 days, 5 days, she or he is putting some milk, ghee, bakricha doodh, then turticha pani. So many things are there which are going on, and definitely that will definitely hamper your prescription power. Because I am asking you that the patient will not say, वो डॉक्टर ने वो ड्रॉप दिया था, उसके बाद में हमको और प्रॉब्लम आना चालू है. So this is the problem. Your drop doesn't make any sense, but he will feel or she will feel that I am having this problem just because of this eye drop. So this is what we should ask, that is there a home treatment you have done, home remedy treatment you have done, and not only home remedies. We should ask that if you have put anything, just show me or just bring it. So many things are there, quack practices are there. In my observation, our side, still people are going for foreign body renewal to a dai or a lady. She will remove your foreign body or his eyelid foreign body, showing the big stone or some calcium powder like that. And it's very difficult to say that still we are in 21st century and we have so many quacks in our side. So, and that leads to corneal damage, end ophthalmitis, pus, everything. And at the last, the eye goes totally completely went wrong and we have to remove the eyeball. So this is my experience. So we should ask them, is there any home remedy, any tongue removal foreign body, जिभेने काही काढलंय का, तंबाखूची पोटली डोळ्यात फेकलेली आहे का, त्याच्यानंतर तंबाखूची पिचकारी डोळ्यात मारलेली आहे का, ह्या सगळ्या गोष्टी आपल्याला विचारणं आवश्यक आहेच. Now to go ahead with it, you don't have to need so many equipments like we people have as ophthalmologists. No need. If a good light or if a good torch light, I will ask you, not a good torch light like LED torch light, because if in a LED torch light, it should be a normal torch light which can be help for the examination. So how to go ahead? If there is a simple allergy, if patient comes with the allergy should be treated and should be examined and ask him that whether he is having itching, blurring sensation, increasing tearing, watering is there, or any allergic symptoms that are also accompanied by allergy symptoms such as sneezing and itching and running nose. This is very common in allergic conditions. Some common allergic triggers includes that is pollen grains, dust bites and molds, and dander is there, irritants like cigarette smoke or air pollution, that is there in allergy. So this is a simple, you can see in this patient, this is a simple allergy. Patient had a history of itching and you can see there is a congestion and it's a very simple congestion and you can see watery eye. The congestion is there and with that watering is also there. So if the watering is there, so definitely you should ask him, आपको किसी चीज की एलर्जी है क्या? आपको खुजली आती है क्या? Are you getting scratchy eyes? Because if some dust particles, बहुत सारे लेडी को ऐसा होता है कि घर में अगर कचरा भी झटकना है, इधर उधर से कुछ साफ सफाई भी की है, तो you can find there is some allergic conditions and she will get sneezing also. छींके भी आती है, खुजली भी आती है, हाथ पैर को भी खुजली आती है. This can be related with cosmetic also. So many cosmetic, after using cosmetic also, they feel the same problem. So you should ask for allergies, and such allergies can be treated in a normal way. no need to give higher steroid drops, or you can just give anti-allergic drops, anti-allergic tablets, or any simple painkiller which can be useful. Even simple eye drop along with steroids. Now depends on steroids is you don't have to prescribe prednisolone and all. It's just simply you can prescribe antibiotic with dexamethasone, and this allergy can be resolved within an hour or within a day. And definitely patient will need oral anti-inflammatory and anti-allergic tablets also. That depends on your own choice, and the patient will be more happy for that. Yes, this is more important for me and for you also, because now you can see that there is a picture of one towards the left side and one is towards the right side. This is we always find such a patients on Friday evening, Saturday evening, and Sunday morning. Now you will say why this is. बहुत सारे लोग Saturday को our side we can call it as a ruit's झाड़, ruit's food. And this is very common in general practice. So many patients come, doctors. I was in the normal. I was completely doing my work and all. Suddenly, I started getting irritation, and but the irritation is not that much, but blurring of vision is there. I can't see now. This is a very common because see why I'm asking you, ask the leading question. This is what he will not say anything. He will say नहीं अभी तो मैं मॉर्निंग में घर पे ही था, घर पे, लेकिन तू क्या कर रहा था मॉर्निंग, कल शाम को तूने क्या किया, कल अगर फ्राइडे है तो तूने फ्राइडे इवनिंग को क्या किया, सैटरडे है तो सैटरडे मॉर्निंग में तूने क्या किया. You should ask him, because patient will not say that what he did. Patient will say nothing. I am totally absolutely normal. I was not having any problem. I was doing my own work. मॉर्निंग में उठा, नहाया धोया, और उसको पूछो भाई तू कहाँ गया था. Then धीरे से he will say, हाँ yes डॉक्टर साहब मैं मंदिर गया था. Definitely you will say, मंदिर में तूने क्या किया. So he will say मैंने रुई का पत्ता था, रुई के पत्ते को हाथ से वो ये किया, फिर मेरा वो हर सैटरडे मैं जाता हूँ, मुझे तो कुछ नहीं होता. Definitely there is a history कि आपने कहीं तो भी हाथ लगाया हुआ था, और वही हाथ उसने आंख में लगाया, आंख के बाद में उसने इचिंग किया, इचिंग होने के बाद में that causes a this toxicity. So this is a calotropis toxicity that induce corneal edema, and definitely that edema will be very horrible. Patient will be scared because जो उसको 10 मिनट पहले दिख रहा था, 1 घंटे के बाद में उसको कुछ भी नहीं दिख रहा है और पूरा ब्लर हो रहा है, और पेशेंट दौड़ते भागते पहले ऑफ्थल्मोलॉजिस्ट के पास में नहीं जाएगा. जो भी डॉक्टर उसको पास में मिलेगा, जो भी रिलेटिव पास में मिलेगा, उसको पास में जाएगा, वो उसको दिखाएगा कि भाई बहुत सारे लोगों को ये पता नहीं. ही विल नॉट से कि वी डोंट नो वेयर टू गो टू ऑफ्थल्मोलॉजिस्ट डायरेक्टली, सो ही विल गो टू अ प्रैक्टिशनर और जनरल प्रैक्टिशनर, एंड ही विल से okay something went wrong. Some general practitioner give him avilvamazone, some dexamethasone drops, which is very common nowadays, bitalol or whatever it may be. So this is all what. But after giving some steroid, sorry. After giving some steroid drop, definitely that edema will reduce. You can see the patient with A and B, and same patients with C and D, the steroid, after giving steroid drops and some lubricating, definitely that patient got relief. So this is what the leading question has to be asked. Now we come to the conjunctivitis part. This is a very common disease nowadays. Aankhein aana. This is related with each and every. The patient, there will be some small membrane which will get inflamed. Inflammation of conjunctiva causes white when your eyes appears pink, red in color. So with that, there will be some signs and symptoms. There are itching, blurring sensation will be there, feeling like something is in your eyes. So patient will say, Dr. Saab, since morning I am getting scratching, itching, and some feeling is there of blurring is there, or some blurring is there. Definitely each and every patient will not present with a blurring of vision. Nice diminution of vision will not be there, but there will be some itching part, that khujli aana, foreign body. Patient will say some रेत गई हुई है, सब पंथर गया हुआ है, कंकर गया हुआ है, and definitely he will start scratching in front of you only, and that will give you the clue that this is a very common, and sometimes it present in a late phase with both eyes or he will present with a single eye. So should take care of that, ki discharge or mucus or pus is there or not, because there may be some small discharge, mucopurulent discharge is there, even pus point picture discharge is also there, leading to crusting of your eyelids and eyelashes. आपल्या मराठी भाषेत म्हणतात की डोळे हागले, means that will be there. Patient will say हागरे येत आहे डोळ्याला, हागरे येत आहे डोळ्याला. And this is a point whether you should know that since how long it is there. And one more thing you should ask, is there any history of same episode in home? Because his friend, his relative, his brother, sister, wife, husband, each and everyone may be having same episode, and that will be there. That is, you will having conjunctivitis. The conjunctivitis have a variety causes, including viral, that is there. And nowadays, conjunctivitis is presented with a COVID-19 patient also. And this is a fact. The first COVID patient has been diagnosed. It has not been diagnosed as COVID-19, but something is there with the viral infection by an ophthalmologist. So bacterial infection that can be caused by a specific Staphylococcus aureus, Staphylococcus pneumonia, then allergies to things like pollen, moths, pets, dander, environmental irritants like smoke and chemical fumes. Such type of conjunctivitis is very contagious. This you should take in mind. So after examination of your own or that patient, you should be careful for your own hands also, because you should wash your hands, then start next patient. Otherwise, that will be contagious for your patients also, side by patients also, or attendants also, and each and everyone. So how to treat with the conjunctivitis? Conjunctivitis is very simply to treat, but depends. Like only with the low dose of steroid, that fluorometholone is more helpful. Antibiotics, because I will not go much more detail in that, because we have to diagnose and treat in a simple way. Sometimes some people are using rotipronolone, but the mucopurulent discharge, if you will say that it is a yellowish discharge, and you won't find that there is something related with more towards what I can say towards the side with discharge. But if fever is also there, so you should give oral antibiotics, oral painkiller or anti-inflammatory along with the anti-allergic or antihistaminic treatment. Drops, I should ask you to put anti-allergic drops with a low olopatadine, or some things are newer drugs are also coming in market. So these are the things with low dose steroid, or in case if you find patient is not getting relief with that, then you should go with higher range of, that is a steroid with dexamethasone combination, steroid with hydrocortisone combination, like that. When presents with a type of conjunctivitis, this you should know in your OPD. Healthy eyes, if the bacterial conjunctivitis is there, that redness of eye is presenting with the edema of conjunctiva, and pus will be there, like you can see here. Then if it is a viral conjunctivitis, lacrimation will be there, but there will not be a mucopurulent discharge. So this should be in consideration, that how the redness is presenting, or how the conjunctivitis is present. The redness of eye with allergy, there will be edema, lacrimation, and itching, but there will be a slight discharge, but which will not be a mucopurulent discharge. So these are the pictures which we have to be considered. Why I'm more focus on this is, I have seen my patient, so many VIP patients had called me, doctor, I'm having redness. I just asked him last first episode, and this is this we have discussed with our friend Dr. Anand Junjunwala, then Dr. Manish Wankhede, madam, that we are the first who treated. We started, not treated, we have first diagnosis. One doctor, he's a physician, he just sent me a picture of his own eyes. Ki, Dada Mala, I'm having this problem. I first asked him, you have congestion, you have itching. You don't have itching, you have congestion. And definitely that congestion is of nowadays if the COVID-19 is going on, and you just go and get your test done. To be frankly speaking, when I ask him, he will just, no, doctor, Dada, I'm taking care of everything, sir. Why to worry about that? I said, see, this is my personal experience that whatever patients I have seen, within 1 to 2 days, they are developed with the COVID. So I asked that patient, go, doctor, just do it for myself. He said, okay, sir, I will do it. He did his rapid test, he come positive. After 24 hours, he called me, sir, thank God you said me, because as you said, I just isolated myself, and he isolated from the home and he got positive. And this is a condition where each and everyone has to see. So many doctors don't take care of that ophthalmology. Patient present with you with hemorrhagic conjunctivitis, not even the hemorrhage, only red patches. And first presentation is there, slight fever is there. If fever is there, he is definitely having, and nowadays the scenario is that whatever fever or whatever conjunctivitis and whatever is there, you should see to it that patient or treat him as he is a COVID, or take care of yourself. It is not necessary that you should take care of the patient only. You should take care of yourself also, because these patients are complaint only with redness, slight fever is there, and they don't think that they are having conjunctivitis, COVID. So we should ask him, whatever it may be, I am going to prescribe this drop, but today or tomorrow or day after tomorrow, watch for your fever, watch for any other symptoms or COVID, and get your test done. What is venereal keratoconjunctivitis? This is for my pediatrician friends. This is more important, because keratoconjunctivitis, it's like to treat since childhood to adult. So many doctors get fed up to treat this, and so many pediatricians also get fed up to treat this. As these patients come with us, doctors are, after every 3 months we are developing this. So first they will go to pediatrician treat with him with normal steroid, or he will treat him or that kid with low dose steroid, because he has to prescribe drop also. Otherwise patient will see, आँख में भी तो कुछ दीजिए drop डालने के लिए. So this is what patient will think, कि there should be some relief, and relief will be there when you are giving him a good steroid. A steroid drop will give him a very good relief within 5 to 10 minutes. And what he will think, a general practitioner had given steroid drop, and that is very good for my patient, and and the ophthalmologist is just simply giving, no, isko time lagega, thoda sa, he will prescribe some lubricating drops, and that lubricating drops will help that patient. But the steroid drop will definitely hamper that patient in a long way, because since childhood we ask the patient that you need this treatment in a longer way. I always used to prescribe on that prescription pad, वे या आजाराला वेळ लागेल, वय वाढेल तसा आजार कमी होईल, विविध प्रकारच्या औषध उपचारानेच हा औषध उपचार दिल्याने हा आजार ठीक होईल, वय वाढेल तसं तुम्हाला आजार कमी होता येईल, तुमच्या प्रतिकार शक्ती वाढवावी लागेल, because so many things are related with the immunity also. Venereal keratoconjunctivitis is a treatment that lasts long because patient will have some immunity problem also. He will have some fever in between. He will be developing some. Patients are already in a low immune system. So we prescribe with low steroid or no steroid. I will again tell you, with steroid or no steroid, because if you will prescribe steroid, what patient will go do? He will not come to you. He will go directly to the chemist and he will take steroid drop. And that steroid drop will definitely help him. He will say, okay, ये drop 12, 13, 20 रुपए, 25 रुपए का लेने के बाद he will, माझे डोळे चांगले होतात, मला कशाला डोळ्याच्या डॉक्टरांकडे जायचं काम आहे किंवा मला फिजिशियनकडे काय. पण I will request to the pediatrician, if you will find such patient, ask him that don't buy any local drops, because local drops will definitely cause him a long way hampering of his visual disturbance by having glaucoma and development of cataract also. So this is a point to be considered, that whenever you are going to treat such type of patients, that patient has to be considered whether to give him steroid or not. What we are giving such patients, we are giving the trichomonas ointment. This is a new ointment. Even the skin doctors must be knowing, dermatologists must be knowing. This is our low strain and higher strain, which are the long-term anti-inflammatory action is there, and which will definitely help such type of patient, along with lubricating drop, anti-allergic drop, and low-dose steroid. This is our regime. But what we ask, that this regime has to be there only for 2 months. After that, you have to come to doctor, and then we will think that whether to continue or not. This is more important. Now we are shifting towards the keratitis. Keratitis is one is infectious and other one is non-infectious. The following conditions may lead to a non-infectious condition, like wearing contact lenses, irritation, complete. If there is irritation of eyes, like if patients is having foreign body sensation, development of keratitis will be there, because rough surface of cornea will happen, and that rough surface of cornea will lead to keratitis. Eye injury leading to scratches or a blow of eye. Wearing your contact lenses too long, wearing extended wear of contact lenses. Then some foreign body sensation, swimming pool irritation is there. If some chemical injuries are there, that leads to. This again more important is weakened immune system is also there. Then exposed to intense sunlight, photokeratitis, and dry eye syndrome. Dry eye syndrome I will cover in next slide. So these are the non-infectious, where you just have to treat him by giving some lubricating drops, some anti-allergic drops, and oral anti-inflammatory or antihistaminics. And how to go ahead with the infectious. This is what we have said. The infectious keratitis is where the cornea is involved with bacterial infection, like Pseudomonas, Aeromonas, Staphylococcus. Both these bacterial infections are usually seen with improper contact lens use also. Even the improper eye hygiene. This is also more important, because some patients don't take care of their hygiene in proper way. Then fungal infection. This fungal keratitis is, there must be some trauma, vegetative infection. Is there any farming infection? मिट्टी गई है क्या, खेत में कुछ गया है क्या, कुछ डाला है क्या, कुछ और कुछ normal infection trauma रहता है, then they used to go for this दूध, ghee, then some homemade remedy that leads to fungal keratitis. That is, then this keratitis leads to fungal ulcer, and that again gets hazardous for that. Then is there any parasites? Particularly dangerous form of infectious keratitis called Acanthocytes, usually acquired while wearing the contact lenses. Then viral conjunctivitis is also very common. Herpes simplex infection is there, and with the herpes simplex, ask him any history of fever, sneezing, or anything, because this is related with the conjunctivitis and leads to keratitis. Blepharitis is also very common. Blepharitis, you can see each and every patient may come with itching, because if the patient is having dandruff, you should see for blepharitis in the patient eye also. It's a simple thing. You can just see with this patient. This is a very common. The one eye is very severe and one eye is a little bit mild. But severe eye, all eyelashes has gone, and you can see the white crusting on the lid margins. This clustering of lid margins and redness is there, and with the severity, there is no eyelashes also. These eyelashes, there is no eyelashes, and that leads to a severe condition that may lead to foreign body sensation. Corneal itching is there, and that corneal itching may cause afterwards the blurring of vision. Then that blurring of vision leads to it comes with us in a long time period. So many hazards are there that leads to loss of eyelashes. With the eyelashes, foreign body sensation is there, and corneal trauma will be there. And this trauma leads to bacterial infection, and again the corneal ulcers and keratitis will start. So what to do with the blepharitis? If blepharitis is there, please ask like whether he or she is having dandruff, and ask the family also, because if dandruff spreads with the family has to take care of their dandruff, not only the patient but the relative. Agar maa hai to beta, baap, सबका माँ बाप, because they use their comb, जो कंघी रहती है वो common रहती है, and that dandruff start from one patient to another and whole family will involve. And this blepharitis is commonly seen in females and with the kids because they don't take care of that much and continuous itching is there. So the simple treatment start with the prevention, then care, and then treatment. The care is only how to take care of dandruff. And another thing is the prevention is better not to get other one infected. And if the डोक्यात कोंडा असेल तर पहिले कोंड्याची treatment, and then you start with simple ointment. That steroid ointment is there, dexamethasone combination with antibiotic. You just ask to rub take on your finger and ask to rub on your eyelid, eyelashes margin, so that you will feel much more better. And most probably the ointment should be with the hydrocortisone, because if the hydrocortisone is there, the inflammatory stages and the mammalian glands will not get swollen. And patient has to ask for hot fermentation, because each and every time the hot fermentation will reduce the inflammation, and definitely that blepharitis will be in a longer way, it will reduce the symptoms and signs also. So these are the some stages. If the patient asymptomatic, mild to moderate, and if the severe patient is there, what are the symptoms? Blinking, watering, itching, loss of eyelashes, blurring, itching, greasy appearance. If the cleaning daily with clean clothes, medication from inflammation and infection, as I said, dexamethasone ointment has to be there. Treating an underlying condition. What are the underlying condition that I told you before? If patients come to the dermatologist presenting with other lesions also, like I'm having conda and all, just see for blepharitis also. If the dandruff is there, definitely he is having blepharitis. And if blepharitis is there, definitely he will be having dandruff also. So these are the things to be considered. All things has to be there. It is not presenting with the ophthalmologist also. It will be presenting by yourself also. That okay, you can judge like if this patient is having dandruff, definitely some problem will be there with the eyelashes or something like that, and you just watch with your normal torchlight examination also. Patient education is more important. Warm compression was okay, and lead scrubs. Lead scrubs are towards the different side, because if that blepharitis is very chronic, because so many blepharitis are not treated in a single episode. So you have to take care of that patient. You have to tell the patient that he or she may need the treatment for longer time, maybe 6 months, 7 months, or 1 year. Usually we prescribe in this way, and after that topical antibiotics, steroid drops, ointment are there, and lubricating drops to treat for the same patient. Yeah, this is more important and very interesting topic for each and every, for you, me, and for everyone. Now we all are shifted towards computer, and now when we all are shifted to computer, this is actually a topic to be noted, that dry eye is very common in children also. Before that, the dry eyes were very common in women, in those who are using computer work, those who are using PC work, IT companies, bankers, and this thing. But nowadays, computer vision. Computer vision syndrome is very common nowadays in our field, because now all are online. Sorry, somebody's mic is there. Hello. Somebody's mic is there. I can't hear. Hello.
Yeah, they muted. No problem.
Okay, thank you. Yeah. Now the computer vision syndrome is very common, because patient used to come, doctor, if he's a pediatrician or physician, pediatrician will, the patient will ask, doctor sir, बहुत सर दर्द हो रहा है इसका, तो directly pediatrician will say, okay, सर दर्द हो रहा है क्या, you just, ये तो मैं treatment दे रहा हूँ, then you just go and show it to ophthalmologist also. If you will go to ophthalmologist, definitely he will look for that, whether what patient is doing. So leading questions are more important again, whether the computer, whether patient is using the computer more than 2 hours, definitely he is having computer vision syndrome, that is dry eyes, and that dry eyes leads to irritation, redness, fatigue, diminution of vision, blurring of vision. Patient will complain, doctor साहब computer में से आंखें बाहर निकलने के बाद 5 मिनट तो मुझे बाहर से कुछ भी नहीं दिखता है. That is just because of the glare. So these are the symptoms and signs to be considered in mind. And if we are taking care of this sign, definitely, and treatments are very simple. If no medication, just ask him, go and wash your eyes after 2 hours. Go and clean your eyes after 2 hours. Definitely, there are some points to be considered. That is, that point is to be considered like 20, 20, and 20 seconds. This is just in brief. I will tell you what for you and me also, because we all are on computer nowadays. 20 seconds, just close your eyes. 20 seconds, next 20 seconds, you just put your lubricating drop to whatever you have prescribed or whatever you are available with your near chemist or with you. 20 seconds, again you close your eyes. Again you start closing your eyes after 20 seconds. So only then after 20 seconds, do 20 times blinking and start your work. Only 1 minute exercise will help to prevent your fatigue, dry eyes syndrome, and that dry eyes will definitely going to hamper your day-to-day life. So these are the common things to be considered. If the patient is with redness, dry eyes, ask him whether he is using computer, what type of how many hours he is sitting, or if nowadays with your children, those who are using online classes, we should ask them to go ahead with this type of symptoms and signs which you should be considered in your OPD. I will just tell you in brief what is uveitis. It's inflammation of sclera, including iris, sclera, and uvea. So I am not going in much more detail because sometimes this uveitis is very critical to treat for ophthalmologist also. So what is in brief, like there will be a severe pain, floaters will be there, sensitive to the light, and related with that is autoimmune diseases are there, that is lupus, rheumatoid arthritis, and ulcerative colitis. So I will request to all each and every physician, if patient is having rheumatoid arthritis, you should ask patient, if you have rheumatoid arthritis, you should go and check your eyes also. What we do, we used to check the eyes, not only what is his vision, but how is his iris condition, because we used to take whole examination and ask him to put some drops, which we will examine after 20 minutes, so that whether the pupil is wholeheartedly dilated or not, or whether the pupil is constricted. If the pupil is constricted, definitely that is a long-term iridocyclitis or uveitis there, and along with that, we have to treat accordingly. Here, I should request our surgeons and physicians, and even the urologist, those who are using, those who are treating the prostate patient, means those who are having treated with the prostate, like enlarged prostate and all. Some drugs are there which you are prescribing. We are asking you, we are requesting you, before prescribing that drugs, we should ask patient to go to an ophthalmologist, because some drugs are there which will directly permanently constrict your pupil, and that pupil constriction will not hamper anything with the patient, but whenever patient will develop cataract or any other problem, that pupil will not get dilated because of the occlusion of the pupil and muscles. That drugs will help hamper on that pupil size, and that will be difficult for us to operate on a small pupil cataract surgery, what we can say. So these are the things to be considered. And as I told you, so many things are there. What if the physician suspect that he or she is having some uveitis, definitely he should refer the patient towards the ophthalmologist. These are the scleritis. These are the patients with the scleritis. These are OPD patients, usually come with severity and nodular scleritis. Actually, nodular scleritis and complete scleritis, these are the different topics to be considered. But as a physician, or as a general practitioner, I request each and everyone, if you are prescribing normal steroid also, this redness will go. Definitely patient will say, okay, I'm having very nice, doctor ne 2-4 goliyan di, and I can feel very nice, and nothing is there. I can again tell you one thing. Even we are the physician, we are the doctors, we have done so many treatments since long we are doing anything. But these patients, why I'm again asking you about the leading question to the patient, ask patient कि भाई तू कभी बाजार वाले डॉक्टर के पास में जाके आया हुआ है क्या? क्योंकि ये लोग जो these people will go to some quack doctor and they will have good type of steroid powder form. पूरी देता है, कुछ टैबलेट देता है, कुछ देता है, and patient will feel अरे वाह इनका तो होने के बाद में, because so many patients are associated with rheumatoid arthritis, and these rheumatoid arthritis will cure by some higher dose of steroid, and that steroid will definitely hamper their everything, but they will feel much more better with the आठोड़ी बाजार का डॉक्टर जो रहता है उसके पास में से. So we have to take care of this thing also. Yeah, this is a condition which is, we can call it as subconjunctival hemorrhage. Subconjunctival hemorrhage is a very commonly found for the general practitioner. So many doctors get scared, like all of a sudden patient was normal and he find that collection of blood is there between the conjunctival layers. So first you should ask patient not to worry, but take care of normal thing, that some trauma is there, whether he did some scratching, vomiting is there, and eye injury is there. So many things are not asked by physician, because patient will say सब कुछ अच्छा था डॉक्टर, अभी 10-15 मिनट के पहले वो भी मुझे नहीं प्रॉब्लम हुआ, आगे वाले ने देखा, आगे वाले मैंने मतलब कोई भी जो भी उसके साथ में रहे, those who are side by to him, he will say अरे all of a sudden your eyes are getting red, and those eyes getting red are very dangerous to look. The dangerous look is there. So we should ask for the same patient. So many times you just prescribe, general practitioner give some drop and ask him to go to doctor, that's all. But nobody will check his blood pressure. This is a fact. When patient comes to us, we just ask him, okay, because everything is normal, vision is normal, everything is normal. He is not giving any history of trauma. Patient will say absolutely normal, मैं absolute normal था. We just ask him, okay, just 1 minute, मुझे blood pressure लेने दो. And all of a sudden, that patient blood pressure will be 210, 100, then 180 by 110, then 150 by 90. So these are the things to be considered. If patient comes directly first time to you with the subconjunctival hemorrhage, just take 2 things in mind: hypertension, trauma, and itching. That's all. Nothing more than that. Because if the hypertension is there, first patient, one patient had come to me and he will say, no, doctor sir, I am absolutely fine. Why you are asking me to check the blood pressure? I asked, no, zara zopa baba ekda bagun gyu. And all of a sudden his vision is, his blood pressure is 210. So these are the things to be considered in mind. This is a simple thing and simple to treat. Only thing is that the ask patient ki this blood clot will go and resolve after 15 to 20 days. So don't worry and don't come to me. So because if you will not say like this, that patient will come, definitely go to other 3 doctors and he will say, doctor ne dila drop, but nothing has happened. Now I had come to you. Then again he will say same patient to the 3rd doctor, and the same doctor will treat in same way, but he will think, okay, after 20 days, that 3rd doctor is treated and that only helped me to resolve my blood clot. So this is how we should take care of that. So normal drops, low dose steroid or no steroid, only vitamin C tablet. Some vitamin C tablet will help to reduce, and some anti-inflammatory if you need it, or if patient is having some signs and symptoms regarding to that. This is again one more redness is there in such patients. That is a lead style, but we can call it as a manjari honi, doyala manjari honi. A style is a blockage of the mammalian gland in eye that causes inflammation. It can affect the outsider and inside, either upper or lower lid. It can be repeated. So many patient comes to it. काय डॉक्टर 3 दिवसापूर्वी झालं होतं, परत दुसऱ्या डोळ्याला झालं, आता खालच्या पापणीला झालं, त्याच्या बाजूने झालं. Yes, this is going to happen because you are treating as a normal infection and it's okay for that period. But this patient will be having some other problem regarding what we can consider. Ask him to refer to ophthalmologist to get his checked vision. Vision should be checked because he will be or she will be having visual disturbances, visual field different. This thing is there, and another thing is that continuation of mammalian gland infection, chalazion or lead style. You should ask patient to check his hemogram. So many patients will be having diabetic or some other illness because sometimes diabetes can be neglected. That will be present only with mammalian gland infection, that is chalazion or repeated style infection, or refractive error is there, what I said, as an ophthalmologist. So we should check thoroughly with systematically with the hemogram report also. Again, this topic is for us, but yes, I should ask you that if patient comes with red eye and the patient, we have to be considered, there has to be 3 points. Ask the patient to me kya problem ho raha hai. If patient says कि after getting this redness, I am getting diminution of vision, और जब मैं ट्यूबलाइट के पास में देखता हूँ, so he is having color halos, मतलब ट्यूबलाइट के बाजू में पूरा कलरफुल उसको एक रिंग दिखती है, वो रिंग अगर दिख रही है, उसके बाद में एसोसिएटेड विद हेडेक अगर है, अगर पेशेंट इज हैविंग हेडेक, so definitely अगर वोमिटिंग भी साथ में हो रहा है, so this is acute stage. Don't treat for anything, just we are there to take care. We are there as an ophthalmologist because so many patients will get an acute attack, and with this acute attack, definitely within a hours or within a day, that patient may get permanent damage to optic nerve, and that optic nerve leads to permanent diminution of vision loss. So we have to take care of that. If patient, 3 days before, I got a call from a physician. He admitted a patient in a IPD, saying, shown just one patient is there. He is complaining of severe headache and vomiting. This is a fact. This is the 3rd day before 3 days back. This is a fact. And patient is complaining of vomiting, headache. But all of a sudden, he is telling me, doctor, 2-3 days since I'm having this headache and nausea, and he's hypertensive also. So his thinking is absolutely normal because he thought he's some problem is there. Then after next day, he called me. Now patient is settled, but vomiting is still there and headache is there, but blood pressure is normal. So now headache is there, vomiting is there, and patient is complaining that I'm having diminution of vision, and that patient is complaining since 3 to 4 days. So if since 3 to 4 days patient is having same problem, but diminution of vision is there, I ask him, sir, better you ask that patient to come to my OPD, because if I will come to there, I will just with the torchlight, I can't see anything. So after seeing that patient had come to me, immediately I started IV mannitol, and within an hour, patient got relief. So this is the things to be considered. If patient is having diminution of vision, nausea, vomiting, color halos, ring, definitely you should ask your ophthalmologist.
Last 4 minutes we have.
Yeah, yes. So non-corneal ulcers, these are also very tricky to treat. If the first blue slide, it is a herpes zoster herpes simplex patient. These are the chronic patient also and acute patient also. So sometimes only redness doesn't count that only he's having conjunctivitis. So that will definitely go for your ulcers also. So if the viral conjunctivitis is there, you should ask, is there any before episode? Is there any previous episode of same thing is there? And if previous episode of same thing is there, better if you want, give some oral antibiotic, oral anti-inflammatory, anti-allergic, but ask him to go to ophthalmologist, because you can see on torchlight some white spots or some white images. So that if it is there, better not to prescribe any drops, because simply antibiotic doesn't make any help. On if you will prescribe steroid, that will definitely develop an ulcer, and that ulcer will definitely leads to consequences that will permanently damage to the vision. So these are the point to be considered. Next point is second is our fungal infection. Fungal infections are, as I asked, leading question has to be asked. Fungal infection may present with some homemade ready-made treatment or some local drops which has been purchased by a patient directly from chemist. With steroid drops, that will be definitely there. Corneal thinning will there, and that corneal thinning will be going to hamper. And so better give some oral treatment, but don't prescribe anything, because if you will prescribe anything, if the patient not responding, if he will go to ophthalmologist, he will not say anything about his homemade remedy. He will say, मुझे physician ने drop दिया था और उसके कारण ये सब कुछ हो गया. And next is ask for the any injuries. Yeah, Bell's palsy. This is also very, very important. Bell's palsy or exposure keratitis may lead to a patient with a lag ophthalmos, lead to exposure keratitis. That keratitis leads to permanent corneal ulcer or white cornea, and that has to take care. If Bell's palsy is in a longer duration, we have to do tarsorrhaphy also as an ophthalmologist. Otherwise, that exposure keratitis may lead to permanent corneal opacity. This is a small maggots which I removed 3 days back. This is a patient complaining that I was in मैं बाजार गया था, मैंने कुछ fruits खरीदे, and you can see there are small maggots. Within 2 hours, he developed these maggots, and patient come to me, and I asked him. I just did this. You can see with the forceps. I can show it to you on cornea that there is a small maggot, white maggot. See, you can see the movement. See these movements. The patient, the maggots is going upwards. Yeah. And now I am remove that. What I did, I simply did with the KGCON that anti-inflammatory drops and anti-anesthetic. You can watch with the upper and lower palpebral. Just give him a wash. It is not necessary we are asking you to remove the maggots, but do some betadine wash. If you have betadine at your place, just go for that, and you can treat these maggots also. So patient leading question has to be asked. Patient will not give, but proper cleaning, proper wash definitely help to remove that maggots. Eye injuries, this is very common in each and every field, orthopedic, physician, surgeons, and everyone. This treatment depend on, like, yes, only I'm requesting to the physician if only eye injury is there. But if there is a cellulitis, please, my request, first don't take only headache CT scan. Sorry, I'm so sorry to say. Don't take only the brain CT scan. Just if the leads are not opening, if you can sign the pupil is not seeing, if eyeball is not seeing, only red eye is there, black eye is there, please take the orbital CT scan also. Because orbital CT scan help so many patients to recover their ophthalmic injuries, which, yes, just 1 minute. Yeah. Okay. Things are there to take care, and that will definitely. Sorry, my watch was little bit towards minus side, so I'm just going to complete that. So CTs, I will ask each and everyone go for CT scan and take the orbital scan, because optic nerve compression, if it is there, that will give permanent damage to the visual loss, and it is not going to recover. If within 24 hours we can do compression and all, we can go ahead for the recovery of the visual loss. These are the foreign bodies which usually you can find in these things. Chemical injuries, I will not go in much more detail. Only treatment at the basic level for chemical injuries, if it is ask the patient what is the history, alkaline or normal saline wash, just give at your OPD procedure at your basic level. If lime injury, remove some foreign body particles if it are there, white crystals are there. And if it is going to more, then definitely go and refer to patient to ophthalmologist. Just wash with more than 1 liter if it is there. Definitely, because if it is going to be there and if patient doesn't come to ophthalmology, you can see there are corneas burn, conjunctival burn, and all gone. So we have to harshly give the treatment which are definitely mild to moderate corneal burn to be treated at normal level, as I told you. The contact lens where we will skip. Yes. Only for the pediatrician, I'm asking you. So many things are there. The antibiotics are to be over prescribed. Why? School policies that require treatment, the lack of patients education, and so many patient thinks कि जितना antibiotic ज़्यादा डालोगे उतनी आंखें fresh रहती है. It is not like that. Only request is that long-term use of steroid drops to be avoided, because it may lead to constant irritation, corneal thinning, repeated infections, glaucoma, conjunctival cyst, and cataract. Thank you very much. Thank you very much. I am a KHAMGAON, and thanks a lot. Thank you.
Very nice.
Thank you.
Sir. Questions, if any concluding remarks by Dr. Anand Junjunwala, sir.
Yeah, thank you, Atul. Thank you, Sean. It was a really great deliberation on red eye. Very informative, very descriptive, simple, and easy to understand. Thank you so much. And I think we are already overshot at the time. So over to Atul back. Thank you so much. There are no questions.
Coming to the next topic, importance of blood pressure assessment and follow-up in general practice by Dr. Ashok Bhaskar, sir. This session will be chaired by Dr. Sheetal Chavan and Dr. Pankaj Mantri, sir. Introduction of speaker by Sheetal Chavan.
Good afternoon to everyone. Am I audible, sir?
Yeah, you are audible.
Good afternoon to everyone. I am Dr. Sheetal Chavan, MD Medicine, practicing at KHAMGAON at Chavan Hospital. Thank you for giving me a great opportunity to introduce a great personality, a well-known physician in our KHAMGAON, Dr. Ashok Bhaskar, sir. He is born on 1st October. He had done MA, then he finished MBBS from GMC Nagpur in 1989 when I was born, and he had completed his MD medicine in from IGMC Nagpur in 1993, and he has also done LLB from Amravati University in 2008. Now he is practicing at KHAMGAON Hospital, Aksha Hospital, KHAMGAON since 1995. He is also managing director of Silver City Multispeciality Hospital and Trauma Care Center. Then he was a CME organizing secretary in 2004-2005. He was IMA president in 2010-2011. The founder secretary of Buldhana District API. He has attended numerous national, international, and state level conferences. He had chairperson RSSDI in 2014 and 2017. Now he is a member of Association of Physicians in India, Cardiological Society in India, Research Society for Study Diabetes in India, and he has presented papers in JAPI, Vidarbha Cardiology Society. He is actively involved in social work and public beneficiary activities through Lions Club. He is occupied the post of Lions District Governor in 2009-2010. Presently, he is in charge of diabetic awareness in action portfolio for Maharashtra, except Mumbai, and he has traveled more than 45 countries in all parts of globe and attended international conferences and workshops. We are lucky to have such knowledgeable seniors. Thank you. Hello. Hello.
Hello. Good afternoon, everybody.
Good
Am I
afternoon, sir.
audible?
Yes, sir. Good afternoon.
Yeah. Sir, myself, Dr. Pankaj Mantri, I'm a physician at KHAMGAON. Let me first wish all of you a very happy New Year 2022. And I hope that this year we'll see the end of this monster virus, COVID-19. Friends, in our daily practice, whatever branch of medicine we are practicing in, we come across patients of hypertension. And this is very commonly seen in all the young, olds, males, females, as well as educated, non-educated people. At the same time, we know that it may be primary hypertension or it may be secondary hypertension. And all this has so many complicated and intermingled pathways. And there are so many groups of antihypertensive drugs available in the market. And at the same time, so many clinical conditions coexisting with the hypertension itself. So it is an art of diagnosing and treating hypertensive patients. Dr. Ashok Bavaskar, sir, a well-known physician from KHAMGAON and a hard-working physician at the same time, he is with us to solve this difficulty. Sir, please start your lecture. Thank you.
Thank you, Pankaj. And thank you, Sheetal, for a nice introduction. Friends, good afternoon. Let me first congratulate the team of IMA KHAMGAON for wonderfully organizing this virtual CME. I think this is a great milestone in the history of IMA KHAMGAON to have a virtual CME with registrations of more than 1200 delegates. And friends, we are saying right from the morning that all the deliberations and all the presentations are going on in time. Friends, I'll be shortly speaking on workup of a newly diagnosed hypertensive patient with a special reference to the importance of blood pressure assessment and follow-up. As rightly said by Pankaj, right now, we are facing the medicine people, they are facing almost every third patient is a hypertensive patient in our day-to-day practice. If we see the burden globally, it is the leading modifiable cause of ischemic heart disease and premature deaths, whereas large burden of hypertension is seen in low and middle income countries like India, South Asia and African countries. As of now, around 45.4% of all the age group adults, almost around 1.6 billion population of the world is suffering from hypertension. If we consider a male and female distribution, almost 51% male and 39.7% female, they are suffering from hypertension. We see the incidence of hypertension is increasing with the age. Lower the age, that is 18 to 39 years of age, we see around 22.4% of the incidence of hypertension. In the age group of around 40 to 59 years, we see an incidence of around 54.5% diabetic patients, hypertensive patients, and more than 60 years, almost 74% patients are hypertensive. If we consider the burden in India, large absolute burden of hypertension is seen in India being a low and middle income country. The total prevalence is almost 29.8% with the urban distribution of 33.8% and a rural distribution of around 27.6%. If we exclude the white coat hypertension, we'll see what is white coat hypertension. If we exclude the white coat hypertension from this epidemiological studies, the remaining 23% of the urban and 17.5% of the rural population are suffering from hypertension in India. If you go by stages, the stage 1, almost 70%, that is 45 million patients are stage 1 patients. And if we go by stage 2, almost 24% of the patients, that is 20 million patients are from stage 2. Everybody knows the JNC 7 guidelines has categorized the hypertension in 4 important categories. One is the normal, that is less than 120 systolic and less than 80 diastolic. Pre-hypertensives, those having a systolic blood pressure of around 120 up to 139 and a diastolic blood pressure of around 80 up to 89. The stage 1 hypertension, we see the patient having a systolic blood pressure of around 140 to 159 and a diastolic blood pressure in between 90 to 99 are categorized in stage 1, whereas the systolic blood pressure of more than 160 and a diastolic blood pressure of more than 100 have been categorized as stage 2 hypertensions. Friends, we see there are a number of factors which are as a risk for the developing in the hypertension.
we'll see the modifiable and non-modifiable factors. The non-modifiable factors is our age, because we cannot change our age. As far as just we have seen, the incidence of hypertension increases as the age increases. We have seen the sex predominance also. Males are slightly more predominantly seen with hypertension than female. Race, the South Asian people and the American subcontinent people, they are more prone for hypertension as compared to other African countries. Then those patients who have got a family history of hypertension are also more prone for hypertension. The fifth one is hyperlipidemia. If you have got a incidence of hyperlipidemia in the family, then those patients, they tend to have hypertension in their age group, in the elder age group. For modifiable risk factors, the importance are obesity, that is particularly the abdominal or central obesity, unhealthy dietary habits, those people who are eating junk food or unhealthy foods, then those people who have got a high sodium intake, they are also prone for developing the hypertension. Sedentary lifestyle, no activities, they are sitting throughout the day in their office, in the chairs, all these people, they tend to have hypertension in their elder age group. High alcohol consumption is also one of the important factors which can increase the risk of developing hypertension in your future life. Tobacco and stress, they are also very important factors which are responsible for developing the hypertension. One more thing which is not mentioned here is modifiable risk factor is the low potassium intake. Those people who have got low potassium intake, they are also at high risk of developing the hypertension. Just now we have seen the two different categories. One is the modifiable and the other is the non-modifiable. Because the non-modifiable factor is not in our hands, we cannot change it. Whereas the modifiable factors, definitely we can change. And all these things, obesity, unhealthy dietary habits, high sodium content, sedentary lifestyle, high alcohol consumption, tobacco and stress, it is up to our hands that we can change these habits and we can reduce our risk of developing hypertension in our future life. Friends, how to assess the blood pressure? Blood pressure of all adults should be measured by a trained healthcare professional at all appropriate visits. For example, when a new patient comes to your hospital for a checkup, at any given point of time, whenever any new patient comes to you, first of all, for any other reason, whether he has come for some infection, whether he has come for some any other aspect, you have to check the blood pressure. You should make a habit to measure the blood pressure of each and every patient. Then periodic health examination. There are a few people, particularly all the people who are working in the factories or in some companies or in offices, they have got yearly health checkup, the executive health checkup or a simple health checkup or comprehensive health checkup. These people come for health checkup every year. And when they come for a health checkup, we should, without fail, we should check their blood pressure periodically. We should not take it as granted that last year his blood pressure was normal, so this year there is no need of taking the blood pressure. Then urgent office visits for any neurological or cardiovascular related issues. If some patient is coming for CV or some patient is coming for some other cardiac problem or some convulsions like episode, then we should not take it like this. This is not related to hypertension, so why we should check it? Each and every patient, even though it is a neurological, cardiovascular, renal, or gastro, or any stream patient, we should check the blood pressure on his every visit. And medication renewal. Many of the patients, they come for just for the renewal of the medicines. Every 2 months, every 3 months, they are coming to our OPDs for changing the medicines or getting checked. So at each periodic visit, we should check check the blood pressure so that we can notice whether there is any change in your blood pressure in the last from the last year's reading. Blood pressure of all the adults with high normal blood pressure, that is with a systolic blood pressure of 130 to 139 and a diastolic blood pressure of around 80 to 89, all these patients should be regularly checked whether they go in for hypertension in their near future life. There are some special consideration for screening. Frequency and timing may vary based on increasing age. If the age is increasing, suppose you have got a patient of around 22 years of age, 25 years of age, you can ask him to check his blood pressure maybe every 6 months or like that. But if a patient of around 45 to 50 years, or say more than 60 years of the patient is coming to your OPD for some other periodical examination, then we should frequently check his blood pressure. Then the patient with comorbidities, if the patient has got comorbidity or any of the risk factors, either the modifiable or the non-modifiable risk factors, then we should check his blood pressure on a regular basis. Reduce frequency for consistently normal recent BP. If we come across that some patient has got a normal BP at all the times when we check it, then we can reduce the frequency from say every 2 months or every 3 months to maybe from 3 months to 6 months or 6 months to 1 year, like that. Then higher the frequency for higher the frequency for high normal BP patients. All those patients who have got a diastolic blood pressure, or all the patients who are white coat hypertension. White coat hypertension patients are the patients whose home blood pressure is normal, but when they come to the consultation chamber, there the blood pressure increases. So all these patients, they are the high risk patient, or we can call it as pre-hypertensive patients, which can have their blood pressure higher blood pressure in their future visits. So we need to check the blood pressure frequently. Higher frequency for adults in high risk ethnic groups, like in South Indian or South Asian population. South Asian population, they tend to have higher blood pressure. So when they come to your OPD, we should frequently check their blood pressure. Now we'll see how to check the blood pressure, because that is also equally important, how to check the blood pressure, because many of the time when we see the patient that are coming to our OPD, we just casually check the blood pressure, but that is not the case. We should check the blood pressure in a very systematic way. There should not be any acute anxiety, stress, or pain suffering for the patient. The patient should not have consumed the caffeine or smoking, or he should not have intake of nicotine in the preceding 30 minutes, because all these things, they tend to increase the blood pressure. Then there should not be any use of the substance containing adrenergic stimulant, because many of the patients, they come with the decongestant medicines for some ENT problem, or they come for some, they use ophthalmic drops, and then they come to our hospital for checkup, and we see that their blood pressure is on the higher side of the blood pressure is more. So just confirm whether the patient is already on any decongestant medicine or any ophthalmic drops that he is continuing. Then the patient should have his normal bladder and bowel movements. He should have a very comfortable bladder and bowel. There should not be any tight clothing on arms and forearms, because when we check the blood pressure in our arms, there should not be any very tight clothing. Then a room where you check the blood pressure should be a very quiet and comfortable room with a cozy environment with the normal temperature. It should not be very chilled, it should not be very hot, or it should not have a very warm weather, so that it can again change the stressful condition of the patient, and it will again result into higher readings. Then ask the patient to rest in your OPD for at least 5 minutes. Many of the patients, they are in so much hurry that they come to your OPD, they come to the counter and they say, if doctor is available, sir, I want to check my blood pressure. But when these patients come inside the chamber and when we check their blood pressure, we see frequently that their blood pressure is more. So whenever the patient comes to your OPD, ask that patient to sit in the OPD for a few minutes or for a few time, and after that time, then ask him to come inside and then check the blood pressure, so that you can get a proper reading. Then patient should stay silent prior and during the checking, because many of the patients, they are very stressful patients. They always they come to the OPD and they are in so much hurry that मेरा नंबर अभी तक क्यों नहीं लगा, मेरा नंबर तो जल्दी लगना चाहिए था, मैंने तो फोन करके सर को बोला था. So all these patients, like type A personalities, we would say that when they come to our OPD and when they talk like this and you check the blood pressure, then always the blood pressure is on the higher side. So ask the patient to stay calm and silent while checking his blood pressure. What is the standardized technique to measure the blood pressure? How should be the posture of the patient? The patient should be calmly seated with his arm, with his or her back well supported and arm supported at the level of the heart. Everybody must be knowing that our teachers in the medical colleges have taught us that patient, whenever you check the blood pressure, the BP apparatus should be at the level of the heart, because this was a very famous dialogue of almost every medical clinic. Whenever we first time entered the clinics in our second year, that the medical officer and our seniors, they always tend to tell us that whenever you check the blood pressure, the BP apparatus should be at the level of your heart. So always see that whenever you check the blood pressure of the patient, where is your blood pressure meter. Then ask his arm to be properly supported. It should not be hanging one. because again, if the hand is hanging, it will again have some tremors and may result into a improper blood pressure checking. His or her feet should be touched to the floor and legs should not be crossed. This is a very proper position that is seen in the photograph which is in the slide, that the legs are touched to the floor. There is no crossing of the legs. The hand is at the apparatus is at the heart level. The hand is firmly rested and the patient is sitting calmly with a back rest. So this is the proper position in which you should measure the blood pressure. What is the recommended device for appropriate size of the cuff? Because again, it also results into improper measurement of the blood pressure. See, if the arm circumference is in between 18 to 26 centimeter, then a size of the cuff should be around 9 to 18. That is called as the child cuff. If your arm circumference is between 26 to 33, then you should use a standard adult model, that is 12 by 23 or 12 by 35. If your arm circumference is between 33 to 41, then you should use a BP cuff of around 50 to 33, that is a large size. And if your arm circumference is more than 41, then you should use a cuff of extra large size, that is 18 by 36 size. But if you are using a electronic model, then whatever cuff is supplied with the model, you should use that one. Then for initial readings, take the blood pressure in both the arms. So how should you measure the blood pressure? For initial readings, take the blood pressure in both the arms and subsequently measure it in the arm with highest. Suppose we check the blood pressure in right arm as 140 by 80 and in left arm it is 150 by 90, so that you have noted that there is a difference of around 10 mm of Hg in the left hand. So you should measure the blood pressure in left hand for another 1 or 2 times, and you should confirm that whether the blood pressure which was noted earlier is right or wrong. And whenever you see that the blood pressure in the left hand arm is more, then you should measure the blood pressure in that arm on 2 frequent occasions, and then you should come to the conclusion that patient has got a high blood pressure. Again, you should not you should not mention that the patient, once it is the blood pressure is on the higher side, that you should not label the patient as a hypertensive patient unless and until you measure the blood pressure on some other occasion. So at least on 2 occasions, you should confirm that the blood pressure of that person is on the higher side. Record the blood pressure to the closest of 2 mm of mercury of the manometer. When we see that the sounds are coming in the apparatus, then nearest to 2 mm of the highest reading, you should consider as a systolic blood pressure, and nearest to the disappearance of the sound, you should consider as a diastolic blood pressure. And record the patient position, in which position you have recorded the blood pressure, whether that 140 by 80 is in a supine position, or it is in the sitting position, or whether it is in the standing position. Then what are in which patients do you recommend to have a standing blood pressure? Which patient need to check the standing blood pressure? You measure the patients with the age group of 65 and above. All the patients of 65 and above, there are the chances that they may get a postural hypotension, or there may be any autonomic dysfunction resulting into change in the supine and standing blood pressure. Then all the patients with diabetes with a age group of more than 45 to 50 years, this patient, if they have got the diabetes more than 10 years of duration, then you should suspect maybe some autonomic dysfunction. And in those patients, you can detect the blood pressure, you can check the blood pressure in standing as well as in a lying down position. Then if there are any symptoms of postural hypotension, if there is a giddiness, there is symptom that the patient is feeling very tired, where the patient is feeling that he has got some dizzy feeling, or some other feeling that he is not proper in the standing position, then in such conditions you should measure the blood pressure in supine as well as in the standard position. Check that the patient BP 1 to 5 minutes after the patient is in a standing position. It is not like that the patient, you are just ask the patient to stand up and you are checking the blood pressure and you are coming to the conclusion that the blood pressure is normal. So ask the patient to be in a standing position for almost around 5 minutes, and then you check the blood pressure, and if you can check the blood pressure immediately if the patient has got a complaint suggestive of hypertension like dizzy feeling. Then what precautions you should take at the initial visit? An average of the 3 readings taken at intervals of around 2 to 3 minutes should be recorded. Then for confirmation of the diagnosis of hypertension, record at least 3 sets of reading on different occasions. That just now I have told you that we should not label the patient as a hypertensive patient. If we measure the blood pressure once and it is on the higher side, at least you should have 3 sets of reading on different occasions. Then measure the blood pressure in both the arms at the first visit and use the higher of the 2 readings. Suppose you see that the patient has got a higher reading in the left hand, then from the next visit also, you should check the blood pressure in the left hand only. What is the concept of masked hypertension? That is the blood pressure which is not detected, but the patient has got a tendency to develop the blood pressure. If you measure the blood pressure on in home ambulatory blood pressure monitoring, and the second one is check the blood pressure in the office, that is to visit to your consulting. If the blood pressure of the patient is less than 135 at home and less than 140 in the consulting chamber, you should consider all this normal as a true normotensives. These are not the hypertensive patient. If the patient has got a blood pressure more than 135 at home and less than 140 in a consultation, then all these patients should be labeled as masked hypertension. That is, they have got a tendency to blood pressure on their ambulatory blood pressure monitoring. Whereas if the patient's blood pressure is more than 140 in the office but less than 135 at home, these are called as the white coat hypertension. White coat hypertension means the patients are very normal at their home, and when they come to the consulting chamber, they tend to have increase in the hypertension. So all these patients are called as white coat hypertension. And the true hypertensive patient are the patient whose blood pressure is more than 135 at home, and at the same time they have got more blood pressure more than 140 in the consulting chamber. Then we should assess the overall cardiovascular risk. For that, you have to search the organ or get damage. What are the different target organs which are damaged by hypertension? These are mainly brain, then heart, kidneys, and peripheral arteries. In the brain, cerebrovascular disease in the form of transient ischemic attacks, ischemic or hemorrhagic strokes, or vascular dementia because of the old age. Then hypertensive retinopathy. Many of the patients, they tend to have retinopathy changes, background retinopathy, or there are different, this is a different topic to be discussed, that hypertensive retinopathy. Then left ventricular dysfunction. When the patient has got a long-standing hypertension, there you may come across that their ventricular function has been reduced, or there is a left ventricular hypertrophy, which is resulting into some ECG changes. Then if the patient has got a long-standing hypertension, there is a tendency that patient may have got a coronary artery disease in the form of either myocardial infarction, angina, or patient may go in for a congestive heart failure. As far as kidney is concerned, hypertension can lead to a hypertensive nephropathy resulting into albuminuria and a CRM. Patients who have got peripheral vascular disease, they tend to have intermittent claudications and absent peripheral pulsation because of the peripheral vascular disease. How to assess the cardiovascular risk? Search for the exogenous potentially modifiable factors that can induce or aggravate the hypertension. Which are those factors, friends? The medicines, NSAIDs, including coxib derivatives, they tend to have tendency to increase the blood pressure. Corticosteroids and anabolic steroids, they also tend to have a tendency to increase the blood pressure. Oral contraceptives and sex hormones result into increase in the hypertension. Vasoconstricting and sympathomimetic decongestant, that is just now I said the nasal or ophthalmic drops. Then calcineurin inhibitors, that's cycloserine and tacrolimus. These are the drugs which can again result into increase in the blood pressure. Erythropoietin and all its analogs. Then antidepressant drugs like MAO inhibitors, they have got a tendency to increase the blood pressure. Which are the other things which have got tendency to increase the blood pressure? These are the licorice roots, stimulants including cocaine, high salt and excessive alcohol. These are the other things which can result into tendency to increase the blood pressure. over 90% of the hypertensives have their other cardiovascular risk. You have to assess and manage hypertension patients in terms of whether they have got a dyslipidemia, whether they have got a dysglycemia, that is blood sugar, either impaired or a frank diabetes. They should not, either you have to assess in them for abdominal obesity or unhealthy eating or physical inactivity, so that you can advise them accordingly which are the things they need to modify in their day-to-day life, like a lifestyle modification, so that the lifestyle modification can result into decrease in the blood pressure, and they should delay their medicines for hypertension. Then just now I have seen the cardiovascular risk factors. Presence of the risk, they increase with the age. They are more in the male gender. Smoking also increases the risk of complications with hypertension. All the patients who have got a family history of cardiovascular disease, they also again have got a tendency to have complications due to hypertension. All the dyslipidemic patients, sedentary lifestyle, unhealthy habits, all these patients, they have got tendency to have a cardiovascular risk of targeting the heart. Then, what are the preliminary investigations to be done with the patient with hypertension? All the hypertensive patients, they need to be investigated for target organ damage. And what are those investigations? Those are the routine urine analysis. You should check the routine urine analysis and see whether that albumin is present or whether sugar is present in their urine. Then blood biochemistry in the form of sodium, potassium, creatinine, liver function test, kidney function test, hemoglobin level. Then their fasting blood glucose, whether the fasting blood glucose is more, or if fasting is more, then you can go for post meal blood sugar also. Then considering the lipidemic state, whether there is an increase in the total cholesterol or low density lipoprotein, or how is the layer of high density lipoprotein, and particularly in the population of South Asian countries or Indian population, they tend to have high triglyceride levels. So you should screen the patients for all these abnormalities. As far as heart is concerned, then you should examine the ECG of the patient for if the patient has got one or more risk factor, then at least twice in a year, that is every 6 months, you should check the cardiac risk. Then currently there is insufficient evidence to recommend a routine testing of microalbuminuria in people with hypertension who do not have diabetes, because all the patients who have got diabetes and blood pressure together, they tend to have a tendency to develop albuminuria in their future life. Then other routine laboratory tests, they are during the maintenance phase of the hypertension, they are the electrolyte level, creatinine level, blood glucose, fasting lipid level. These are to be checked on routine visits on every 3 to 6 month basis. Whether additional investigations which are more important are the lipid profile, uric acid, and echocardiogram. If you see that a hypertensive patient has got some changes in the ECG, or he has got a symptom suggest to have some cardiac problem like breathlessness or dyspnea in sitting position, then you should advise echocardiogram of the patient, so that you have to know what different what complications he has developed in the heart. Diabetes develops in 1 to 3% patients of blood pressure, which is supposed to be a drug-related hypertension. When the patient, they are using diuretics and beta blockers for their hypertension control, they tend to have diabetes in their future life. Assess the diabetes patient for more frequently. If the patient has got a diabetes, or if the patient is on beta blockers or diuretics, then you should check the sugar level more frequently, that is every 3 months or 6 months. Then these are the optional laboratory tests, and these are the tests for the kidney disease, that is urinary albumin excretion ratio and proteinuria, to assess whether he has got a frank proteinuria or the patient has gone in for a kidney failure. Friends, why the treatment of blood pressure is important? With every reduction of 2 millimeter of Hg of blood pressure, there is almost 7 to 10% reduction in the risk of ischemic heart disease and other vascular diseases in the future life. In one meta-analysis, in 61 prospective studies, it was seen that with 2 millimeter decrease in the blood pressure, there is 7% reduction in the incidence of ischemic heart disease in the future life, and there is 10% reduction in the stroke mortality in those patients who have got a long-standing hypertension. Then, what is the recommended target BP for the hypertension patients? If the patient has got no risk factors, there is no modifiable or non-modifiable risk factors, then you can ask the patient to have his blood pressure on the higher side, that is 140/90 is an acceptable level. But if the patient has got a complication in the form of cardiovascular complications, neurological complications, or the patient has got a diabetes, hyperlipidemia, or any retinopathy like symptoms, then all these patients are a high risk patient, and these patients tend to have, they are to be said that their blood pressure should be always less than 140/80 in all the things. Patient should return for follow-up and adjustment of the medication until the BP goal is reached. Many times what happens, if the patient comes to your clinic and you see that you say that the patient has got a blood pressure of 140/80, that is patient is controlled, then the patient gets lost to the follow-up, and after 3 months, 6 months, 8 months, the patient comes with the accelerated hypertension. So this should not happen with the patient. You should ask the patient to have a regular checkup. More frequent visits for stage 2 hypertension patients, and with the comorbid patient, they should have the tendency to check their blood pressure very frequently. Serum potassium and creatine monitored 1 to 2 times every year, because these are the two important electrolytes which can result into cardiac complications as well as some other complications related to hypertension. After BP at a goal is stable, then ask the patient to check the blood pressure every 3 to 6 months interval. And all the comorbid patients like heart failure, diseases like diabetes, then they need to check their labs very frequently. So this is how we have gone through what is the importance of the blood pressure, what is the modifiable and non-modifiable risk factors for hypertension, what is the present prevalence of hypertension in world as well as in India, how we should properly check the blood pressure, what is the proper technique of checking the blood pressure, what is the proper assess, how to assess the blood pressure properly, and what are the important investigations and monitoring and the follow-up of the hypertensive patient. So in our day-to-day practice, if we follow all these things, so I'm sure that all your hypertensive patients will be very properly controlled, and they won't land up in any complications. I am really thankful to our IMA KHAMGAON for giving me an opportunity to talk on this important topic of hypertension, which has been faced by many physicians as well as many general practitioners in their day-to-day life. And my congratulations are to the IMA President, IMA Secretary, and IMA Treasurer, along with Organizing Secretary Dr. Anand and Joint Organizing Secretary Dr. Aniket, for their wonderful arrangements of this virtual platform. Because many times, friends, when we log into the virtual conferences, either the state conference, even the national conference, lot of things are faced in their virtual thing. So even though it was a very first attempt of IMA KHAMGAON, I would say IMA KHAMGAON has stood up to the occasion, and they are 100% properly managed the show. Congratulations, everybody, and congratulations to all the IMA members KHAMGAON for their wonderful involvement. Thank you, friends.
Sir, thank you very much. Sir, thank you very much.
Presentation. Questions, if any, and concluding remark by Dr. Pankaj Mantri, sir.
Sir, it was a very good narration, very explanatory narration it was. Sir, some questions are there.
Yes.
What about the salt sensitivity?
Yes. Salt sensitivity means many of the patients we see that even though they have been labeled as hypertension, they don't cut up their sodium intake. The normal recommended sodium intake should be 3.5 grams per day for a normal person. But many of the hypertensive patients, they don't stick to this standard protocol. They go for their extra salt in their diet. Secondly, if the patient is a patient who needs a slightly higher sodium, then you can use a Lona salt. The Lona salt is a salt which has got good salty taste but low sodium intake. And at the same time, we should see whether the patient is utilizing the things which are high in sodium, like high in salt. That is, many of the patients, they have got a tendency to have some extra things in their diet, like vapors or pickles or papad, like these things. So these are the things which are high in salt. So we should restrict the salt intake in these patients.
Sir, what are the roles of pranayam, yogas, and gyms in
Yes,
managing hypertension?
this is a very important question, and a question which is more near to my heart, because you know that I do practice yoga and I do practice all these things. Friends, these are the ancillary things which are considered very important. because the treatment for hypertension, the first thing for the treatment for hypertension is the lifestyle modification. And just now I have said the modifiable risk factors, and these modifiable risk factors they consider they are mentioned are anxiety, stress, alcohol, tobacco, smoking. So all these things. So what is more important is you change your first the dietary habits, you quit your bad habits, then you stick to your good lifestyle. Good life. What is the good lifestyle? It is not like that good lifestyle you should wake up at 4 o'clock and you start like this thing. You should have a good lifestyle means सुबह जल्दी उठना, उठने के बाद में प्रॉपर्ली आपका जो रूटीन वॉक वगैरह वो वॉक करना. And those people who are interested in doing yoga, they should have a separate yoga protocol, tailor-made yoga protocol for them from a yoga teacher. It is not like that the yoga रामदेव बाबा ने क्या वहाँ पे टीवी पे बोल रहे हैं और वो सब का सब अपन कर रहे हैं. It is not recommended. All the patients of hypertensive, unless and until you assess what are the complications they have got, whether they have got any cardiac complications, neurological complications, kidney complications, you should not blindly advise them to do all the yogas. Because even yoga also, few yogas are not recommended for cardiac patients, few of the yogas are not recommended for the brain patients, and few of the yogas are not recommended for the patients who have got some gastric problems. So there is a clear-cut guidelines in yoga also, which yoga you should do for a particular thing. As far as pranayam is concerned, those pranayam can be done by any person. Anybody can do the pranayam. Even meditation has got a very good role and very positive role in decreasing your systolic blood pressure, because meditation and pranayam, they tend to reduce your stress. They tend to reduce your stress as well as they tend to reduce your peripheral resistance, because you get relaxed and the peripheral vasculature get relaxed. Even just now, Pankaj, I came to an article that if you shower in hot water, for 10 to 15 minutes, then it results into decreasing in the blood pressure.
Wow, very good.
Even if you don't take some medicines and you got a stage 1 hypertension, but you continue to shower daily in a hot water, this medium hot water for 15 minutes, then the tendency of getting your blood pressure reduced has been seen in one or two studies, which just I came across a few days back in this thing. So these are the ancillary treatment which are recommended for hypertension, and I think these are in reach of everybody.
Yes, sir. Yes, sir. Sir, there is one more point that we all know that in the early morning hours there is surge of hormones in the body.
Yes,
and that leads to rise in the blood pressure as well as heart rate.
Yes.
So there is now recommendation at many places that the antihypertensive medication should be prescribed more in the evening hours rather than in the morning hours. So what do you suggest, sir? See,
yeah, there are lot many things which are changed in hypertension. You might be knowing that when we were students in the college, our teacher used to tell that minus your age from your height, minus your age, your age plus 100, your age plus 100, you consider as a normal. If you have got a 60 years of age, so 100 plus 60 is 160. But I think these are not the things, because those are the old concepts. Those are the old concepts that you should have blood pressure as your age increases, you should have a higher blood pressure. Now it is recommended that anything which is less than 140 by 80 or 140 by 89 for without complication patient are to be considered as normal. So it is not like that कि तुम कितना भी तुम्हारा blood pressure age बढ़ गया तो ज़्यादा रहने दो. It is not that. Secondly, our teachers used to tell us that you should take your pill early in the morning in our college days. But this concept is again changed. Nowadays, the recommendation is that you should take your BP pill in the evening, so that pill works for almost around 16 to 18 hours, and you should have a normal blood pressure in your early morning hours. Right. Even as everybody knows, there is also a categorization of the blood pressure pills, beta blockers to anxiety patients. Then you should use a different pill for a different category of patient. If we follow all these things, then definitely we get an added benefit of this hypertension control.
Sir, what about the use of oral contraceptive pills in young females? How do you recommend that?
Oral contraceptive pills in young females, if they are using, they have got a tendency to have increased viscosity of the blood. And increased viscosity of the blood also results into increase in the blood pressure. Recently, again, in last month only, I have seen a young girl has been given oral contraceptives for some other reason. and she developed venous sinus thrombosis.
Acha, okay.
Just because of the increase in the viscosity. With
Right.
all the results normal. So if you are using a oral contraceptive medicines in young age, you should. I think this is my view that you should again recommend a antiplatelet agent along with that, so that the patient should not go in for this type of complications.
Right, sir.
Yeah.
So thank you. These were my questions. But from the audience side,
any questions from the chat box? Chat box. Role of caffeine. There is one question from Prakash Chimani. Prakash Chimani, sir. Very good question. Role of caffeine. Caffeine increases the systolic blood pressure in a patient of if you are a normotensive and if you are regularly using caffeine, then there is a tendency that with a regular use of caffeine, there is a increase in the blood pressure. The patient may go in for hypertension, maybe stage 1 hypertension if the patient is using caffeine regularly. What is your view, Pankaj, regarding caffeine?
No, sir. Use of caffeine should help it.
It increases the tendency of hypertension.
Yes, sir. Definitely. Yes. It increases that. Yeah.
Chalo, thank you so much once again, and thank you,
Sir,
Pankaj,
thank
for
you
changing
for
the session in a
good
nice way, and
narration.
thank you, Sheetal, for a nice introduction. Thank you.
Thank you, sir. Thank you.
Thank you, Bhaskar sir, for your beautiful presentation. Coming up next is Dr. Sanjay Bhopade sir with his topic on FNAC, a diagnostic tool for tumors. I welcome Dr. Brahmanand Tale and Dr. Pranali Deshmukh madam to chair this session. Introduction of speaker by Dr. Pranali Deshmukh. Deshmukh madam.
Hello. Good afternoon, everyone. Good afternoon, everyone. First of all, I'm thankful to management team for giving me opportunity to introduce Dr. Bhopade sir, our senior pathologist. He had completed graduation and post-graduation in pathology from Government Medical College, Nagpur. Now working in KHAMGAON as a pathologist since 25 years. He had presented papers in cytology in state and national pathology conference. Sir loves classical music, appeared for Visharad examination conducted by Gandharva Mahavidyalaya. He is also spiritual follower of Swami Vivekananda. Sir invites sir to give us lecture regarding the fine needle aspiration cytology, a diagnostic tool for tumors.
Dr. Brahmanand Tale sir is adding on introduction to Dr. Bhopade sir.
I want to add certain few things about Dr. Bhopade sir. Bhopade sir was a past president of IMA KHAMGAON. He was IMA past president of KHAMGAON also. And he is also a member of BAPM since many years. He is also a good sportsman.
Thank you, Brahma. Thank you. Hello.
You are audible, sir.
Am I audible? Yes.
Yeah. You can start the lecture.
Okay. Good afternoon, everybody.
Good afternoon, sir.
Firstly, I would like to congratulate our IMA President, Dr. Mende Madam, Secretary Dr. Ajankar, Atul Rajput, Organizing Secretary Dr. Anand Rathi, and Mende, and the team of KGCON-2022 for organizing such a wonderful webinar. Congratulations. Today, I am going to present topic on fine needle aspiration cytology, a diagnostic, very useful and reliable diagnostic tool in the diagnosis of tumors. Firstly, I will discuss basic introductory things about FNAC. Then I will discuss various types of cytology and their procedure. And afterwards, I will discuss advantages and some limitations of it. And lastly, I will show some FNAC smears of some tumors which we are routinely performing in our laboratory. Cytology or cytopathology is a branch of pathology that deals with study of cells and cell morphology. In cytology, we study individual cells only or cell clusters. Complete tissue architecture and relation of cells with blood vessels or surrounding tissue is not available. George Nicholas Papanicolaou is the father of cytology, who founded and developed cytology in 1928. Later on, Leyden and Menetrier used needles to obtain cells and tissue fragments from the tumor. It is really difficult to make diagnosis from few cells obtained from the tumors. Though it is very difficult, cytopathologists examine few cells from the tumor, and this examination of cells gives idea about the nature of the tumor, like whether it is inflammatory or benign or malignant. In Marathi, we say शीतावरून भाताची परीक्षा. म्हणजे जसं आपण भात शिजला की नाही की भाताची शीते दाबून बघतो, तसंच आपण ट्यूमर मधून काही सेल्स काढतो आणि मग सांगू शकतो whether tumor is benign or malignant or whether it is inflammatory. Depending upon the method of obtaining cells, cytopathology is of 4 types. First is exfoliative cytology, then intervention cytology or fine needle aspiration cytology, then imprint cytology and sediment cytology. Now, first the exfoliative cytology. In this study of cells, the cells are set down in the body cavity or body fluid. It is a spontaneous process, and spontaneous exfoliation of cells occur into the pleural cavity and pleural fluid and pleural cavity. In our routine practice, we examine pleural or peritoneal fluid for the diagnosis of malignancy or tuberculosis. The second type of this is mechanical exfoliation. Here the cells are mechanically removed from the surface of mucosa. Cells are scraped from the mucosal surface. Here we are using the external force like a spatula or brush to scrape the cells from the surface. We routinely do cervical scraping for pap smear by using air spatula. We obtain bronchial epithelial cells by bronchial brushings. For oral cavity, for oral cancers, we scrape the cells from the buccal mucosa. In spontaneous exfoliation, the cells are spontaneously coming into the fluid, and in mechanical, we remove the cells by scraping. Now coming to the imprint cytology. Here it's a rapid method of diagnosis, and in this method, tissue biopsy is touched firmly or it is slightly gently rubbed on the glass slide to make imprint of the cells on the slide. And here the cell imprints are made on the glass slides. That's why it is called the imprint cytology. The most common tissue on which imprint cytology is done are the lymph node biopsies. For example, a surgeon while doing gastric dissection for suspected malignancy, and if he observes some enlarged lymph nodes, suspecting that there is metastasis in the lymph node, he cuts the lymph node into 2 halves and touches the open area on the glass slide, making the imprints of the cells on the slides. So this is the imprint cytology, so that we can get the results within say minutes during operation. This has markedly reduced the use of frozen section nowadays. The second is the sediment cytology. Here, small fragments of cells, small fragments of tissue or the aspirated material is put directly in the fixative like methanol or formaldehyde and then centrifuged. Then we get the sediment of button of cells at the bottom of the test tube, and then this button of cells is then processed as histopathology sample. Now coming to our topic, that is fine needle aspiration cytology. In FNAC, the cells are obtained with the help of a fine needle and a syringe. By applying a negative pressure, the cells are obtained and the smears are prepared. Now, coming to the requirements of fine needle aspiration cytology. Here we require 10 ml syringe and a needle of size say 20 or 22 gauge needle. Aspiration, that is a special type of instrument, that is aspiration gun is required. This pharyngeal syringe holder. Then the glass sides are required. A coupling jar filled with a fixative. The fixative we use generally is ethanol 95% or methanol, and in a staining material. This is aspiration gun, specially used for FNAC. It has a pistol-like grip holder, because while doing FNAC, our one hand should be free to palpate and fix the lump. And that's why we, with the other hand, we can pull this plunger of the syringe, and other hand remains free to palpate the lump. That's why this device is specially made for this fine needle aspiration. The fine needle aspiration biopsy may be done with or without aspiration. Fine needle biopsy with aspiration, generally we do routinely. Here, we do fine needle aspiration biopsy with the help of this syringe and needle. Here, the needle is positioned in the target tissue, and then we pull the plunger and apply negative pressure. And with this negative pressure, the cells, they come in the bore of the needle or the hub of the needle, and then we move back and forth this needle inside the target tissue, and then the negative pressure is released while the needle is still inside the tumor. And then we withdraw the needle, and the material that is aspirated inside the needle is then blown on the microscopic slide, and the smears are made. Now, this is the fine needle aspiration biopsy, fine needle biopsy without aspiration. Now, here we do not use syringe, only the needle is used. The needle is inside the target tissue, and the needle is moved back and forth and in different directions in the varying the angle, so that due to this trauma inside the tissue, the cells, they come inside the bore of the needle or hub of the needle, and then the needle is withdrawn, and aspirate or the tissue material inside the bore of the needle is then blown on the microscopic slide. This particular type of method is used particularly in vascular lumps or in thyroid nodules, because thyroid nodules are very vascular, and if you apply the negative pressure by aspiration, we get a lot of blood inside the syringe, and very few diagnostic cellularity is obtained. That's why this fine needle biopsy without aspiration is recommended for the vascular lumps or the thyroid nodules. Now, coming to the next important step in the cytology, that is the fixation and then staining. Now, fixation is required to preserve the cytomorphology of the cells. Fixation preserves the size, shape, and the cellular proteins. Depending upon the stains that we use, fixation is of two types. First is the air drying fixation, and second is the wet fixation. Now, in air drying fixation, the aspirated material are spread on the slides, and the slides are just kept in the air for drying. And then it is followed by this type of stains. The Romanowski stain, that includes May Grunwald Jimsa, Leishman stain, Wrights and Jenner stain, Gill and Nielsen stain for the acid-fast bacilli. And wet fixation, the smears are prepared by the aspiration, and the aspirated material is spread on the slide, and immediately the slides are immersed in the fixative. The fixative that we use here is the ethanol or methanol. In wet fixation, drying is not allowed, and in dry fixation, there should not be any wet cells. So this precaution has to be taken during this fixation. And for wet fixation, for hematoxylin and eosin stain and for papinicola stain, we generally fix the slide with the help of ethanol or methanol. Now coming to the staining, 3 major stains are used in cytology. The first is the Pap stain or Papinicola stain, hematoxylin and eosin stain, second, and the Romanowski group of stains. Now coming to Pap stain, here we use methanol as a fixative, and routinely we do this staining for cervical scrape cytology or Pap smear we call it, and the smears that we prepare from the buccal mucosa. In this staining, the nuclear features are better seen or better appreciated. Nuclear morphology and nuclear features are better seen with the Pap staining. Another advantage of this Pap staining is that we can differentiate easily between the keratinized and non-keratinized squamous epithelial cells. Now coming to the hematoxylin and eosin stain, again the fixation is alcohol fixation, and here the cytohistopath correlation is better appreciated because normally all histopathological work is done in the hematoxylin and eosin stain. So if we do hematoxylin and eosin staining in the cytology also, then it becomes easy for us to correlate the cytological features with that of the histopathological features. Now coming to Romanowski group of stains, here the staining is different. That is the air drying fixation is applied here. In Romanowski stains, the most commonly used is the May-Grunwald Jimsa in cytology. The cytoplasmic features are better studied with this stain. The cytoplasmic granules, the cytoplasmic vacuoles, they are better appreciated with this group of stains. And another important feature is that the lymphoid tissue or hematological cells, they are better studied with the Romanowski group of stains. This is the Pap stain smear. We can see here the squamous cells, and we can differentiate the keratinase from the non-keratinase squamous cells. Here, the pink color is the keratinizing squamous cells, and blue or green color cells are the non-keratinized squamous epithelial cells. The nuclei are pycnotic or very pinpoint nuclei, and they are blue or black in color. So this Papinicola stain is a polychromatic stain, and the multiple dyes are used here for differential staining. So the nuclei are blue-black, and cytoplasm is blue with the non-keratinizing cells, and pink or orange with the keratinizing cells. This is a normal hematoxylin eosin stain slide. Here we see the nuclei which are blue or violet in color, and the cytoplasm is pink colored, and all other material, extracellular material, is pink in color. This is the MGG stain slide. This is the Romanowski stain, and the staining here is again air dried smears are used. The cytoplasmic granules or vacuoles are better studied with this stain, and the nuclei are here. We can see they are blue or violet colored nuclei. The cytoplasm is pink or rose colored, and bacteria, if they are there, they are blue in color. This is routinely used stain in nowadays for the routine cytology. This is a normal cervical scrape smear. Here we can see the superficial squamous cells. The cells are very large with pycnotic nuclei. Pycnotic means pinpoint nuclei, and we can see the keratinized squamous cells here. This is pink color, and the bluish or greenish colored cells are the keratinized type of cells. Then these are intermediate squamous cells. The nuclei are slightly larger with non-keratinized type of cytoplasm. The parabasal cells, the nuclei are still larger, and the basal cells, parabasal cells, basal cells. The basal cells may be combined with the some endocervical columnar epithelial cells. So this is the complete normal cervical scrape smear. To the advantages of fine needle aspiration cytology, we find that FNAC is extremely useful in diagnosis of superficial palpable lumps like lymph nodes, cervical lymph nodes, axillary lymph nodes and inguinal lymph nodes. FNAC is extremely useful for at least giving some idea about the nature of the lesion. Then the breast lumps, we can say whether the lumps are benign or malignant, breast lumps. Then thyroid nodules, various types of thyroiditis, it is inflammatory and neoplastic conditions that can be diagnosed. Salivary glands, then any superficial soft tissue swelling or bone tumors that can be diagnosed. Then for deep abdominal or retroperitoneal tumors, we can use USG or CT guided FNAC, and we can take material from deep abdominal or retroperitoneal tumors also. Another important advantage of FNAC is that it is easy to perform, and it can be performed in the OPD. So it is the OPD based procedure. It is almost painless. The procedure is almost painless. Just the pain of prick of a needle, that is okay, and that doesn't require any anesthesia. It gives very rapid diagnosis, so we can get result as early as on the same day. We can get the result. The continuing the advantages, we can see that the procedure is almost complication free. So there are almost no complications. Only rarely minimal hemorrhage can occur or vasovagal attack may occur, but these are very rare. The procedure can be repeated many times. The diagnostic accuracy is 95 to 98%, and this diagnostic accuracy that depends upon the availability of cellularity and the expertise, expertise of the cytopathologist. Nowadays, this FNAC has almost replaced the diagnostic excisional biopsy in lymph nodes and breast lumps. The procedure by FNAC is cheap and cost effective. A very large cyst can be completely aspirated. So if we are doing FNAC of a cyst, so we can completely aspirate the fluid inside the cyst, and that becomes a therapeutic aspiration. So the therapeutic aspiration of the large cyst can also be performed. If the aspirate is pus-like, so if we are doing FNAC and we get only the pus, then it can be sent to the microbiology laboratory for the gram staining, culture, or AB staining, or we can also do the polymerase chain reaction or gene expertise for the tuberculosis. So these are many advantages of this FNAC. Though there are many advantages and diagnostic accuracy approaching 98% to 100%, there are some limitations to the FNAC, and that we must keep in mind, because to reduce the undue expectations from cytopathologists. So all clinicians and surgeons, they also should know the limitations of FNAC to reduce the burden on cytopathologists. It requires this special expertise and training, that is okay. Requires multiple aspirations, requiring causing discomfort to the patient. So many times single aspiration we do not get material, so we have to aspirate multiple times. So patient may feel discomfort, and so patient's cooperation is needed. If the patient is not cooperative, then we do not get adequate cellularity, and so the results, we may not get proper results. The diagnostic accuracy depends upon obtaining adequate cellularity. Just I have told that patient's cooperation is needed for the adequate cellularity, which represent the lesion. Now, though FNAC gives us idea about the benign or malignant nature of the tumor or inflammatory nature of the tumor, exact typing of tumor may not be possible. So for exact typing, the histopathology is the only choice. The differentiation between severe atypia and low-grade malignancy is not possible. It is not possible also with the histopathology also, because this is the gray zone in pathology: severe atypia and low-grade malignancy. Somebody may say it is severe atypia, somebody says it is low-grade malignancy. So this dilemma always continues. The differentiation between carcinoma in situ and invasive carcinoma is not possible, because carcinoma in situ means carcinoma within the duct, it has not crossed the basement membrane. That is the carcinoma in situ. And invasive carcinoma is the carcinoma that has invaded the capsule or basement membrane and invaded the surrounding tissue. So this is not possible to see in the cytology smears. Though FNSC has achieved high degree of diagnostic accuracy, we may miss some lesions, and there are some causes of missing lesions. This is the tumor, and this is the needle, and the needle is tangentially missing the lesion. So what we aspirate is not from the lesion we are interested in, but we aspirate the surrounding tissue, and we may get false results in this case. So because the main disadvantage is that it is the blind procedure, that's why this can happen. Now here, this is the tumor, and this is a large cyst inside the tumor, and this cyst contains cyst fluid, and this needle is inside the cyst, and what we aspirate is the fluid inside this cyst, and many cells which may be malignant, they are in the cyst wall and they remain unaspirated, so we do not get these cells for our study, and we may miss the malignancy inside the cyst wall. Now sometimes what happens, the tumor is both benign as well as malignant. Majority of the part is benign, and a small nodule or small part of the tumor at the periphery is malignant. So this is the malignant transformation of the benign tumor, we can say. The needle is inside the benign part of the tumor, and what we aspirate is the benign tumor, and the peripheral small malignant nodule may be missed. Now sometimes what happens, the tumor is completely fibrotic or sclerotic, so devoid of epithelial cells, so we do not get any cellularity inside in such tumor. So this may happen in fibroadenosis or fibrosclerotic diseases. This is the ideal, actually. This is the lump or tumor, and the needle is exactly in the middle of the tumor, and we get good and representative aspirate. So this should happen. Now in our lab, we are routinely doing FNSC of lymph nodes, breast lumps, thyroid nodules, salivary glands, and superficial soft tissue tumors. And we are getting remarkable cytohistopath correlation. Coming to some cytopathology of conditions in the lymph nodes that we are diagnosing. Following are the diseases that we can easily diagnose on FNSC. First is reactive lymphadenopathy. Now, the most common in our routine practice is the lymph node enlargement, that is lymphadenopathy. It may be the single lymph node or multiple or generalized lymphadenopathy. And the most common cause is the reactive lymphadenopathy. It may be acute reactive or the chronic reactive lymphadenopathy. The next most common cause of lymphadenopathy is the granulomatous or tubercular lymphadenitis. Then third are the lymphoreticular malignancies, or the primary malignancy of the lymph nodes. That is the non-Hodgkin's lymphoma are the most common, or the Hodgkin's disease. Then another common condition that we come across in general in our practice, routine practice, are in old patients, is the secondary deposits of epithelial malignancy. And the common is the squamous cell carcinoma or adenocarcinoma. So I'm going to show you some of the smears, cytology smears. And first is that the reactive lymphadenitis. In reactive lymphadenitis, we get polymorphic population of cells. Polymorphic means multiple types of cells. So here we get the small and large lymphocytes. These are large lymphocytes, small lymphocytes, and the lymphocytes from the germinal centers, they are called centrocytes. So we can also see some centrocytes and centroblasts. And along with the lymphocytes, we can see the neutrophils, histiocytes, and some plasma cells. So this is the polymorphic cell population in the reactive lymphadenopathies. We can also see some large histiocytes with some tingible bodies, but they are not seen here. But these are diagnostic of the reactive lymphadenopathies. This is another smear of reactive lymphadenopathies. This is the MGG stain smear. We can see the large histiocytes and lymphocytes. Now coming to the another common condition, that is tubercular lymphadenopathies. The diagnostic hallmark are the epithelioid cells or epithelioid granulomas. These are the clusters of epithelioid cells. They are large cells with elongated and chapel-like or slipper-like nuclei, characteristic features of these epithelioid cells. And along with that, we get caseation necrosis surrounding it, and we may see some multinucleated giant cells and some Langerhans type of giant cells inside it. So these are some diagnostic features of this tubercular lymphadenopathies that we see: the clusters of epithelioid cells, caseation necrosis, multinucleated giant cells or Langerhans giant cells. So this is the tubercular lymphadenopathies. Now, if we get only caseous necrotic material as aspirate, so we stain it with Gill-Nielsen stain, and we can see the acid phase bacilli. So this background is completely blue in color, and the pink colored rod, they are the acid phase bacilli. And if you see these acid phase bacilli in pus-like material, then the diagnosis becomes very easy and confirmatory. That is the tuberculosis. Now coming to some lymphoreticular malignancies, the commonest is the non-Hodgkin's type of lymphoma. Though we cannot completely diagnose or type the type of the lymphoma, we can at least give some clue as to it is the lymphoreticular malignancy. So the smears are highly cellular, so we get abundant cellularity, and all the cells are monomorphic. That means the size and shape of the cells are monomorphic. There are no histiocytes, no other cells, only lymphocytes, which may be completely large lymphocytes or which may be small lymphocytes. So we get the clue as to as this is the lymphoreticular malignancy. We are dealing with some malignancy or non-Hodgkin's type of lymphoma. But the diagnosis and typing of lymphomas is confirmed by histology and immunohistochemistry. Coming to this Hodgkin's type of lymphoma, in this also we get high cellularity. The cellularity is very high, and we get polymorphous cell population. As against non-Hodgkin's lymphoma, in Hodgkin's we get multiple types of cells. So we can see the polymorphs, we can see the eosinophils, we can see small and large lymphocytes. But the diagnostic feature is this cell, this cell. This is the Reed-Sternberg cell. This is a large cell with binucleated nuclei, two nuclei are there, and prominent nucleoli. It is said that the nuclei they show All's eye type of nuclei. These are the RS cells or Reed-Sternberg cells. This is the diagnostic hallmark of this Hodgkin's lymphoma. Now, this is a common malignancy in the lymph node in our we come across day-to-day practice. It is the secondaries of squamous cell carcinoma in the lymph node. There are sheets or groups of squamous cells with large hyperchromatic and enlarged nuclei. Sometimes squamous pearls may be seen. Now coming to some cytopathological conditions of some breast lesions, we can see some slides. This fine needle aspiration cytology has markedly reduced the need for diagnostic excisional biopsy. With proper clinical examination, radiological assistance, and getting adequate celerity, diagnostic accuracy, and its cytohistopathological correlation has reached almost 100%. In following conditions can be easily diagnosed in our lab setup. So these conditions can be divided into three major groups. First is the inflammatory lesions, then the non-inflammatory or some degenerative, and this is the neoplastic conditions. In inflammatory, is mastitis. Mastitis means the inflammation or infection of the breast. It may be acute mastitis or chronic lymphocytic mastitis, or it may be granular or tubercular mastitis. In non-inflammatory condition, we see the fibrocystic disease. This is generally common in the middle-aged women, and nowadays we are seeing the number of cases are increasing with this fibrocystic disease. In the neoplastic conditions, we get benign conditions and the malignant breast lesions. In the benign breast lesions, we get fibroadenosis and fibroadenoma. Then in the lactating women, we can also get lactational adenoma and gynecomastia in male patients. In male patients also, there are some breast nodules, so the gynecomastia we can diagnose on FNC. In malignant conditions, the ductal carcinoma is most common, though we cannot say whether it is invasive ductal carcinoma or it is a intraductal carcinoma, that is carcinoma in situ, but we can say that it is a carcinoma and it is of ductal in origin. Then we can also see diagnose the lobular carcinoma and metaplastic carcinoma. Metaplastic means the ductal epithelial cells, they are transforming into some stromal-like cells, spindle-shaped cells. These are the metaplastic carcinomas. So with our day-to-day practice, we can diagnose easily these three types of conditions: inflammatory, that is neoplastic, and fibrocystic type of disease. Now this is the smear from the acute mastitis. The pus-like aspirate is obtained, and here we can see plenty of polymorphs or pus cells inside the background, and with along with that there are many histiocytes, and these are the few benign ductal epithelial cells also there. So this is the acute mastitis or breast abscess. This is a smear from fibroadenoma. In fibroadenoma, we get varying degree of cellularity, small scanty cellularity to high cellularity, and we get these are monolayered cohesive sheets of ductal epithelial cells. These are benign cells and they appear in the sheets of cohesive monolayered sheets. These are the ductal epithelial cells in the sheets. And there are some bare nuclei. Bare nuclei means the nuclei, the cells without cytoplasm. Only we can see the nuclei with no cytoplasm. These are the benign bare nuclei. And these are some myoepithelial cells. Spindle-shaped cells are myoepithelial cells. So these are the diagnostic features of this fibroadenoma. Large cohesive sheets of cells, benign ductal epithelial cells, benign bare nuclei. We can see some stromal fragments also. Stromal cells can be also seen, and the spindle-shaped myoepithelial cells. So this is the fibroadenoma. The most common in young girls, young women. You can see this. This is a smear from tubercular mastitis. Again, as in lymph node, we can see here the clusters of epithelioid cells. These epithelioid cells, we can clearly see the elongated or chapel-shaped nuclei. These are the sleeper or chapel-shaped nuclei. These are characteristic features of these epithelioid cells. And along with that, we can see the KGCON necrosis in the background with lymphocytes, polymorphs around it. So, presence of epithelioid cells, KGCON necrosis, and you can see sometimes Langerhans type of giant cells. So they are the diagnostic features in the tubercular mastitis. Coming to this non-inflammatory type of condition, there is a fibrocystic disease becoming nowadays very common. Here we can see many cyst macrophages. So in the cyst, there are many cyst macrophages. The cyst macrophages are these cells. These are very large cells with abundant cytoplasm and pycnotic nuclei. Pycnotic means small nuclei. These are benign cells containing large cytoplasm. They are cyst macrophages. And we can see also some ductal epithelial cells. So the ductal clusters of ductal epithelial cells may show some degree of atypia. They may be completely benign or they may show some atypia. So this is fibrocystic disease with atypia. At times we may see some apocrine cells. Apocrine cells are transformed lobular cells of the mammary lobules. So this is the fibrocystic disease. Coming to this common, nowadays it is becoming very common, even in young patients we are nowadays seeing carcinoma. That is the CA breast, carcinoma breast. The origin of cells is the ductal cells, so it is ductal carcinoma. So we can see the groups or sheets of ductal epithelial cells, and the nuclei, they are very enlarged and show hyperchromiasia. There is a hyperchromatic, enlarged and irregular nuclei. So some are round, some are say pinpoint nuclei, some are elongated, and some show some angulation. So these are the features of malignant nuclei or malignant cells. Groups of epithelial cells with hyperchromatic irregular nuclei. And another typical feature is the absence of bare nuclei and myoepithelial cells. So in such a population of cells, if we do not say any benign bare nuclei and myoepithelial cells, then the diagnosis of ductal carcinoma becomes confirmed. So this is a ductal carcinoma. Now here in this slide, we can clearly differentiate benign cells versus malignant epithelial, ductal epithelial cells. Here we can see the monolayered cohesive sheets of ductal epithelial cells. These are benign cells with regular nuclei. The nuclei are round and regular. They are completely means normochromic. They are not overstained. The staining is normal. Here we can see the nuclei are enlarged. There is no cohesive force in the nuclei, in the cells. Loss of cohesion, loss of polarity, and the nuclei are irregular. This is point, nuclei enlarged, all round. So these are various variants of TPA, variant say we can say regular shape of nuclei. So the difference between benign versus and ductal epithelial. Enlarged hyperchromatic. Here nuclei are normochromic with uniform pattern, monolayered pattern. Now coming to some thyroid conditions, we routinely do thyroid epinacy. Nowadays, again, the excisional biopsy is need for excisional biopsy is reduced with the use of epinacy. Since thyroid is very vascular, pyramidal biopsy without aspiration is recommended and it's preferred. Now, following conditions can be easily diagnosed with the help of pyramidal aspiration cytology. Colloid goiter, the most common condition in our region, colloid goiter. Then various types of thyroiditis, the inflammatory conditions of thyroid. The common is the lymphocytic thyroiditis. Then granulomatous thyroiditis, Hashimoto thyroiditis, their conditions. Then the thyroid neoplasms. The thyroid neoplasms may be benign or malignant. In benign neoplasm, we get the follicular adenoma, and in malignant, we get follicular carcinoma, papillary carcinoma, or anaplastic carcinomas. We can see, I'm going to show some slides on this. This is a smear from the goiter. Colloid goiter we get background. This is colloid material. It is pink colored substance, and we get the sheets of follicular epithelial cells, honeycomb-like sheets of benign follicular epithelial cells. These are the sheets of benign follicular epithelial cells. And along with that, we may see some cyst macrophages which may or may not contain colloid material. So cyst macrophages can also be seen with this colloid goiter. which contains the brown macrophage, the colloids, and background is so this is the cyst. So coming to the or equally, this is a papillary carcinoma of thyroid.
He got disconnected. Sir, yeah, please unmute.
Hello, am I audible?
Yes, yes, sir.
Okay. Full screen. Coming to the papillary carcinoma, papillary clusters of the calcified bodies are the characteristic features of this papillary carcinoma. Some bodies are the calcified cells. They are seen in the. We may see or not see because in FNSE we get only few cells or cellularity. We may miss some of bodies sometimes, but the nuclear features are very characteristics. That could next slide. Slide one. This is papillary carcinoma, high magnification. So nuclear features are very characteristics of papillary carcinoma. Only on nuclear features we diagnose the papillary carcinoma. The nuclei are enlarged.
Your voice is cracking.
Okay.
Okay, you can switch off your camera and then continue, sir. I think that will help. That will consume less time. Just switch off your camera and you can continue the presentation.
Okay.
Just stop your camera, sir. Please, sir.
Okay. Now it is okay.
Better, sir.
The nuclei are enlarged. Okay. And you can see the ground glass appearance of this nuclei with intranuclear inclusions. These are intranuclear inclusions with prominent nucleoli. And we can see some nuclear grooves inside the nuclei. So these nuclear features are very characteristic features of this papillary carcinoma. There is nuclear crowding and overlapping and all that. Next. This is follicular carcinoma of thyroid. We get high cellularity. Characteristically, the colloid is absent. We can see very microfollicular patterns. I will show you. This is the microfollicles. Yes. Can you see these microfollicles? Yes. They are the follicular epithelial cells forming some follicle-like structure. Inside that, there is some colloid. So these are the microfollicles. They are increasing in number as we go from follicular adenoma to carcinoma. So follicular neoplasms is a broad condition in that we include follicular adenoma and follicular carcinoma. So as we go from colloid goiter to follicular adenoma and follicular carcinoma, the cellularity is increasing. In colloid goiter, cellularity is less. It is more in adenoma. It is more in carcinoma. Because and the nuclear size and OTP is also increasing from colloid goiter, adenoma, and carcinoma. The microfollicular structures, the number of microfollicular structures are increasing from adenoma to carcinoma. But the amount of colloid is decreasing. In colloid goiter, it is abundant. In adenoma, it is few or scanty colloid you see. And in follicular carcinoma, it is almost absent. That's why cytology features may be the same, but in the spectrum of disease condition, follicular neoplasm. So, next. Now coming to some soft tissue tumors that we routinely do in our practice, the most common is lipoma. Lipoma most commonly occurs at nape of the neck, shoulder, on the back or thigh. It is composed of mature lipocytes or adipose cells. They are the lipocytes, large cells with pycnotic or pinpoint nuclei with abundant vacuolated cytoplasm. They are the mature lipocytes. To conclude, pineal aspiration cytology is fully developed and established as a branch of pathology since last 3 to 4 decades. It has almost replaced the need for a diagnostic excisional biopsy in most of the superficial palpable lumps like breast lump, in lymph nodes or in thyroid nodules. It has achieved diagnostic accuracy up to 95 to 100%, and it has achieved an excellent correlation between cytology and histopathology. So cytohistopathology correlation is remarkable with the advancement of this cytology. I hope you all find this lecture very informative, and this technique of epinacy will be beneficial to diagnose the tumors in your day-to-day practice. I am thankful to the president of IMA KHAMGAON, Mende Madam, and the whole team of KGCON-2022 for giving me this opportunity to represent this wonderful topic on this digital platform, that is the webinar 22. So thank you, everybody.
Thank you, Dr. Bhopre sir, for your amazing insight on this topic. Questions, if any, and concluding remark by Dr. Brahmananda Tale sir. Tale sir.
Thank you, Sanjay sir, for enlightening us with our day-to-day practice topic in cytology. And it is a very important topic. We encounter in everyday practice lymph node, breast, pap smear or cervical biopsy, cervical FNAC and thyroid FNACs. Have you ever encountered dual pathology in FNAC study smear?
Dual pathology?
Yes.
What is dual?
On FNAC.
Dual means?
Two pathologies.
Yes. Definitely. We can see a tubercular lymph node, and in some that we can see some lymphomas and tuberculosis in one lymph node. So dual pathology can be seen. So that for that multiple aspirations is needed. As I have told that some benign tumor. In benign tumor, there may be some malignant part in that tumor. So that is also dual pathology. So we have to aspirate at multiple sites so as to completely cover the entire lump, so that we should not miss anything from the tumor. So this type of things can happen. Hello?
Pathological correlation is always there.
So pathological correlation is.
And inflammatory changes are always there present in there are above inflammatory changes and below there are malignancies many times we encounter.
I always tell patient to first take some antibiotic treatment and then we will do FNAC. So when patient comes to me, I recommend first antibiotic trial or antibiotic treatment to reduce first inflammation around say proper, if there is some pathology, and around that if there is inflammation. So we may be missing it because we might get some inflammatory aspirate first and we miss the proper pathology. So always it is recommended to have some antibiotics first and then do FNAC.
Yes, sir. Thank you, sir. Thank you.
Thank you, sir.
Thank you, sir. We welcome our last but not the least lecturer, Dr. Narendra Bhagwat sir, to present his topic, Newer Advances in Neurosurgery. To chair this session, we welcome Dr. Gaurav Goenka and Dr. Aniket Mende. Introduction of speaker by Dr. Aniket Mende. Aniket.
Hello and welcome.
So there is echo, Dr. Aniket. There are two devices, I believe.
Hello. I'm here to welcome Dr.
Sir, you will have to disconnect one.
Welcome everyone. I am here to introduce Dr. Narendra Bhagwat sir. He is a working consultant at Vatsal Hospital, consultant endo neuro and spine surgeon from 2016 to till date. Consultant neurosurgeon and spine surgeon at Ozone Hospital, Apollo. Consultant neurosurgeon and spine surgeon at Silver City Hospital, KHAMGAON. Senior resident of neurosurgery, UCMS and GTB Hospital, Delhi from 2012 to 2016. Senior resident, Gangaram Hospital, liver transplant and GI surgery since 2011 to 2012. His skills are endoscopic spine surgery, complex brain tumors, navigation guided brain and spine surgeries, neurotrauma. He is also a teaching facility in endoscopic spine surgery. Thank you. I heartily welcome.
Sir, you can speak.
Yeah. Is my screen visible?
Your screen is visible, sir.
Yeah. Very good evening to one and all. Respected chairpersons, all dear delegates. Hearty and a warm welcome from Vatsal Hospital and Research Center. We are nearly a 40-year-old institute with the second generation into practice. And we had come with an aim that we would be always updating ourselves and putting the best in the service of the mankind. So I took this topic as recent advances in neurosurgery and what we are practicing since the last half a decade. The navigation system, the advent of the navigation system completely changed and revolutionized neurosurgery, again making small tumors, the brain biopsy available with the help of navigation and super added with crush cytology or the squash cytology, along with the newer MRI sequences, has made things much easier and has decreased the morbidity and mortality in the hands of neurosurgeons like us. This is the navigation system we bought in 2017, and we feel very proud to say that we are the first private single-owned hospital to have this as the first center in the central Vidarbha and central India. There are somewhere around 7 navigation systems in Maharashtra today, and 3 more to be established or installed in the few months to come. What navigation system has helped us is they have made our approach more minimally invasive. The older dictum was the bolder, the more bigger the scar, the more bolder or more better the surgeon is. Over the last decade, this dictum has changed to make us more opt, more minimally invasive. So navigation system has helped us to become minimally invasive. It has boosted our surgical confidence like anything, which has helped us to decrease the morbidity and improve the patient's outcome in even tumors like glioma. Navigation system has helped us and has improved the visualization of the anatomy and help us to avoid critical brain structures, thereby preserving important brain functions. And that has helped eventually to improve the surgical outcomes even in complex surgeries. Navigation system has helped us to decrease the surgical errors which were encountered because those are in the human tendency to make an error. and therefore they have reduced the operating, hospitalization, and the recovery time. Team help us, or what is the principle? Basically, we collect the data of DICOM images where even less than 1 mm cuts are being taken, and we form a 3D image. That 3D image is completely available to us during the intraoperative session, so we can check ourselves and we can use the computer aided technologies so that we can move in the confined areas of the brain, the skull and the vertebral column, and we can have a live track of our movement in the brain millimeter by millimeter, thereby increasing our accuracy. So how nervous system has helped us, I would like to elaborate with an example. Recently, we encountered a 66-year-old gentleman who was free of addictions, had no comorbidities, had presented with cough and progressive right-sided numbness and weakness in right upper limb and lower limb. He was initially evaluated in Aurangabad. So first CT chest showed a tiny nodular opacity in the apical segment of the left upper lobe. They said it to be non-specific or query inflammatory etiology. The other labs were essentially normal. The other contributory evidences, what we could gather were the CT chest, it gave us a non-specific nodule from where they took a biopsy and bronchoscopy was done and BL was negative. The bronchial lavage was negative. The CT guided FLC of the left upper lobe yielded nothing. CT abdomen was done and tumor markers, we could not come to any conclusion. The patient had also at the same time started developing progressive weakness of the right upper limb and lower limb. So they started looking into the brain and they found a lesion in the brain concomitant with the lung. So as the patient was available or was in Aurangabad, PET scan was done. But a PET scan showed an ambiguous result because the FDG uptake was increased in both the entities, but there was no concomitant lesion seen in the rib, which was showing high uptake. So they thought that this could be a tuberculosis or this could be malignancy. Now this patient, they came to us, and when we did because CT is not a proper aid for this time, so we got their MRI done, and MRI showed us a lesion in the left frontoparietal lesion, and this lesion had massive edema in coordination to the lesion. So according to the lesion, the edema was around 7 to 8 times fold. So this could be seen in tuberculosis, and this can even be seen in malignancy. A contrast was done, and the contrast showed inhomogeneously enhancing cystic solid component. This is more in favor of malignancy, but even it is shared by tuberculoma. So now with this dilemma where we are not able to establish a diagnosis and the patient is deteriorating, we decided further to move ahead, and now there came the role of a brain biopsy. So what we decided was we took the planning. Now how do you take a brain biopsy? For example, my location in this room, if I'm static, is very much fixed in x-axis, y-axis and z-axis of a room. Similarly, the lesion in the brain, if it does not undergoes any change in edema or any change in the CSF dynamics, is supposedly said to be still. So on the x, y and z coordinate, we planned the axis, and this is how we first fix it. Secondly, after fixing, we have a real-time tag. We can see that we are moving inside the brain and we are able to track the position step by step till the moment we reach our destination. And once we reach our destination, we lock it, and similarly on the same cut, we cut, we uncut, we create a suction, and then we remove the tissue. And this tissue is very well visualized here. We have taken 2 biopsies from 2 different sites, and then now I would like to tell you what the newer advent is. It's crust cytology or the square cytology. Frozen section is not available so easily in our town, so crust cytology has completely revolutionized. We got this report of the tumor being glioblastoma multiformis in just 7 minutes after the tissue was removed. Now, what difference did it make? The first thing that we got in diagnosis that yes, we are dealing with a malignancy and not tuberculosis. Secondly, we knew that this is the entity which is primarily arising from the brain, that is glioblastoma multiformis stage 4. So the very much localization and of the PET scan not being able to localize or not being able to take or demonstrate the CT guided or CT scan FNAC coming negative for lung was proven by this thing. Now, the very moment we knew that this is GBM, my restrictions and my further treatment was defined, and we decided to go for just a decompressive keratomy and making the patient go for radiotherapy. So this made 2 things. One, we were able to construct an excision tumor and therefore further increasing the morbidity of the patient, and this was the daycare procedure. Now, what does image guided surgery help us? It helps us to delineate the vital structure within the brain. It helps us to plan the excision, and it ultimately helps us to check out whether we have done our job completely or not. This was what I encountered. I was operating a patient with an osteolytic region. Sidal sinus was nearby, so navigation system helped me to delineate where sinus was. The line with the blue mark shows me that this is the localization of the sinus, which I could very well understand before operating. And with this help, I could completely do an excision of the tumor. We sent it for square cytology, and we received mark and we received anisonucleosis with osteolytic lesion of the scalp. There were variable size of thyroid follicles containing colloid. So our diagnosis of secondaries of follicle carcinoma of thyroid was confirmed. Now, what do we incur with this navigation system? Because this helps us in planning and precise execution. One can nicely see that I am able to completely move without operating and localize myself on the brain, skull, where my tumor is. That helps me in defining the incision. Secondly, it helps me in defining the keratomy, which I would have done unnecessarily a bigger one. Now, this helped me to have a very defined keratomy, and I knew where my tumor was. The whitey structure, which is we can see at 2 o'clock position, that is the tumor, and it did not hurted any vital structures in the brain. So with this knowledge, we went inside and we could remove the tumor bit by bit, slowly. One can very nicely see that we were in the tumor and we were not harming any vital structures in the brain. Now one can very nicely see that the complete tumor So we knew that we have completely removed the tumor, and this big tumor was completely excised without having any neurological deficit. The patient went home the 3rd day. And one can very nicely see the pulsations after closure. So our job was complete. Now this is something what I encountered. I never thought that I would be dealing with an intraventricular space occupying lesion, at least within the first 10 years of my life. But the navigation system made it possible, and one can nicely see that it is not possible to enter this structure without creating an incision in the brain. But now how this navigation system helped me, I would like to elaborate. This navigation already defined where the tumor was. So I did a craniotomy, size was only 3/2 inches. So after doing a craniotomy, I knew where my localization was, and one can very nicely see the superior parietal lobule and inferior parietal lobule. So between the two gyri, I went, the approach is called as a transsulcal approach. One can very nicely see here that where the blue mark is ending and the yellow mark is starting, we were at that position, and had we slightly gone medially, we would have injured the splenium or the corpus callosum, posterior corpus callosum, and patient would have landed in deficit. These were the fear we had before entering without having a proper knowledge. Now, the moment we knew that we were at the right position, we entered inside, and even with that small craniotomy, we could remove the complete tumor. The complete excision was done, and see the size of the tumor, the size of the craniotomy is hardly 3/2 inches. And the histopath revealed intraventricular meningioma. The patient went home on the 5th day home, which was never thought to be done with this neurosurgery with an open technique. Now, the advent of crush cytology, that is intraoperative diagnosis, has helped us many times. I would like to elaborate with examples. This was a 12-year-old boy whom I was operating, and immediately I got a report from my pathologist. I would like to thank Dr. Vaitsar madam, because she has been doing it since last 5 years, and I really appreciate her because she eventually took that, and she took that burden of giving intraoperative diagnosis within 7 to 10 minutes. The moment I knew that I am dealing with eosinophilic adenoma, my incision and excision was completely planned. I removed the complete tumor, and the baby is pain-free and tumor-free over the last 4 years. The moment this is a very good example, I was operating a tumor which was near a brain stem, which was around a size of 3/4 centimeter, sorry, 3/4 inches. Absolutely, the patient was from KHAMGAON. So the moment we got that this is grade 3 astrocytoma, we stopped and we did not further went for surgery, but we went for radiotherapy, and the patient survived for nearly 2.5 years. Had we gone inside and we had done surgery, we are pretty sure that we would have added some neutrophils to the patient, and the patient would have not survived for nearly 2.5 years. This is the third example where we got the example of astrocytoma, which is of a mixed grade 2 and 3. So we decided for an extensive surgery, and the patient's life was survived, added more for the benefit by radiotherapy. Oligodendroglioma, the result, the very moment we got this, we were more aggressive because we knew that chemotherapy is available, and the overall survival of this patient is very high. We have got nearly a 4-year survival of this patient till date. This is again a second slide which shows us that histopath, also the cytology yielded glioblastoma. We got a very much warning that yes, we have to be sure that we are not going to be more aggressive. Yes, this tumor, glioblastoma multiformis, recently we knew that my teacher's teacher was diagnosed with this entity, and unfortunately he expired 1.5 months back. He had given a video before his death that it is very unfortunate for me to die by this disease, and I know that things are not going to be pretty sure for me. He discovered this when he was operating. His left hand humbled, had tremors. He knew that something was not right. He went and had his MRI. The very moment he had his MRI, one of his colleague who was his student, he took her biopsy, and the biopsy yielded glioblastoma multiformis. That moment he said that I don't want to go for surgery. Kindly give me radiotherapy, and whatever life I have, I would do it with peace, and I would like to leave this world with peace. These were the wordings of our teacher's teacher. We have a very high salute for him, and we have learned many things from him. The biopsy was an advent from people like those people. We have encountered secondaries of Echinocytes while doing an excisional biopsy. We knew what we have to do further because we were not able to track the primary. And after that, we went for a thorough search and we could localize a small lesion in the GIT. This was a patient who was of diagnosed case of CA esophagus, was operated somewhere around 6 months, and there was only SDH in the patient. SDH stands for subdural hematoma. But whenever I was operating, I was not comfortable with the dura. So I took a biopsy from a dura. And the very moment we could localize that, yes, the dura was studded with metastasis. So we gave radiotherapy to the patient. Unfortunately, the patient died, but then we could afford him something. We even had the choriocarcinoma metastasis in brain. These are all the slides which we have done in Akola, and all slides are from Dr. Vaitsar madam. We even encountered non-Hodgkin's lymphoma in the brain, for which then we offered them the treatment. Monoclonal antibodies were given, and the patient is still pain-free and disease-free. We have all kinds of meningioma. We have encountered Somatus meningioma, ependymoma, intraventricular meningioma, even CP angle tumor and intradural tumor of schwannoma, meningiomas of different types. Yeah, this is one thing where navigation have made big difference in pituitary adenoma. While doing drilling, we are very much sure that we are away from the carotid. We are very much sure that behind us is the sella, and we are very much sure that we are just beneath the optic chiasma, and we can visualize the tumor even before drilling the bone. This is what new thing they have given us. And it is like you know where you are going to go, you know where you are going to land, and you know that you are going to do your job very securely. We deal with pituitary space occupying lesions, so there are differential diagnosis. The very moment we know it's pituitary adenoma, we are more aggressive. We knew that this is craniopharyngioma, so we knew we have to be less aggressive. We could do maximum decompression and offer them radiotherapy thereafter. Even we have encountered pituitary metastasis, which is a very rare entity. We could have encountered that in Apollo. So this is what navigation has helped us for brain. Now, secondly, we added neurospine endoscopy and navigation in spine over the last 3.5 years. We have been practicing endoscopy discectomy. We are even doing percutaneous spine fusion, and the use of ultrasonography in the cases of intradural tumors have revolutionized. The use of USG has helped us to localize that yes, this is the extent of the tumor. This has helped us to know that yes, our job has been completely done. And when we have some difficulty in orienting ourselves, whether we are dealing with a cord or something like a cord, the USG has helped us. We can very nicely see that these are the photographs taken from the camera beneath the microscope. We have opened the cord. The cord is opened, and one can very nicely see the whitish structure. With the help of sonography, we knew the extent, the upper pole, the lower pole. This was epidermoid. And after removing the complete tumor, one can very nicely see the cords, the nerves in the spinal cord. So sonography helps us in knowing that yes, that we have removed completely the tumor, and this is the complete after the repair, the tumor we have seen. This was epidermoid tumor. Now, in the patients of syrinx, it is very difficult to know where we are going to take an incision. Syrinx is a dilated cord. We don't know where to take an incision. With the help of sonography, we took the incision, and now one can very nicely see the pulsatile cord. We can very nicely see the pulsations of the cord and the syrinx fluid being drained out completely. So this is what incision over the cord that has, and the patient went home without any neurodeficit. We even had done hereditary spine. In the spine, it was very difficult. It was a redo case. So sonography helped us in localizing, and we could. One can very nicely see that there are the hereditary cysts present, and these cysts were removed. This was the orientation of the cysts in the spine, and the histopathology yielded membrane with the spine. Now, spine endoscopy. We are doing endoscopy spine routinely. The first step is, what we do is we localize the place. We put a needle. The needle is placed inside the fragment where we want the desired location. We pass the guide wire, and over the guide wire, we pass the cannula. The cannula, when it reaches the annulus, that is the posterior 1/3 of the disc, we tap it, and after inserting inside the disc, we know that we are inside the disc, and we pass the scope over the trocar. And then with the help of the working instruments, we can remove the disc. One can very nicely see after removing the disc, the flopping dura. One can take the help of the right-sided figure where above is the epidural space, the traversing route. The 3 o'clock is the L4 superior end plate, and the L5 is the 9 o'clock is the lower inferior end plate. and the disk space is completely vacant. The patient goes home the very next day, and this is done under local anesthesia. One can see very nicely the fragment removed, and the patient walks immediately after surgery. Even we are doing now spine endofusion. This is the recent trend what we are doing. We are going intradiscally and we are reducing the listhesis. And one can very nicely see there are hardly any scars. We were not even able to localize the scars after 3.5 to 4 weeks. So what spine endoscopy has helped us? Spine endoscopy has helped us. One, it has become a daycare procedure. Secondly, the blood loss is hardly in ml. It is less than 10 ml. Cosmetically, it is very much accepted. One cannot find the scar. The pain post-operatively is very much reduced. There are very much less chances of infection. There is no muscle cutting. Only we split the muscles. Recovery is very quick. Less rehabilitation. Patient hardly remains in the hospital for less than a day. Even we have sent the patients in less than 4 to 6 hours at a time. Now the tough nuts. My wife, Dr. Namrata, has in the morning talked about this case. What has happened is we had a 60-year-old gentleman who presented to us with a right-sided pain. He was unable to brush his teeth and face while he could not wash his face in the water. He had pain in paroxysms. It was severe, feeling like a current would last for a minute. This was when he was diagnosed to have trigeminal neuralgia in 2013, and he was started on carbamazepine. Unfortunately, he had a rash. So he went to Mumbai, and at that time, only RFA was done in Mumbai by a functional neurosurgeon. Dr. Doshi sir had done his RFA of the V3rd division. It was on 7th July of 13 that this procedure was done. Later, this patient presented to us again with the same pain. So I evaluated with him for the MRI and did radiofrequency ablation for the trigeminal 3rd division. But unfortunately, this patient came back to me after 3 months with pain in anterior 1/3 of the ear. Now I was much more confused because was I dealing with a relapse, or some of the fibers were not completely radiofrequency or they were not completely ablated. So we decided to do a redo. We went in again, but unfortunately we could not localize the center. That means that the procedure was completely done in the first setting. So now the only diagnosis that was left was whether we are dealing with a V3 auriculotemporal syndrome, because auriculotemporal has a innervation. So we thought of giving an auriculotemporal block. We gave him an auriculotemporal block, but we could not go for RFA because the patient's RFA would have led to secretomotor fiber of parotid, would have ended up in Fraze syndrome. We had no other clue, so we took his CT scan, and to our fortunate, we found elongated styloid process. Now, elongated styloid process is labeled as Eagle syndrome. Now, if you can see very nicely, it is elongated on both the sides, but the patient had pain on right side. So we took help of Dr. Namrata, and she gave a diagnostic glossopharyngeal nerve block on the right side, and his pain had relieved. So now we very well knew that we are dealing with the glossopharyngeal neuralgia. There are very few patients documented in the literature where the patient has concomitant trigeminal neuralgia and glossopharyngeal neuralgia. Once after diagnosis was confirmed, we decided to opt for surgery with the help of our ENT and neurosurgeon. We did tonsillectomy, and on the lateral border of tonsil, there is this styloid process. One can very nicely see stylohyoid ligament. And we could very nicely, with the help of endoscopy and under endoscope, the styloid process was removed. So this is how we could tackle this difficult nut. And the role of endoscopy, navigation, the very moment they have advented into our field, they have made the job much easier. They have made it more simpler, and all those complex tumors which we thought we could never do, we were able to do it in a place like Akola. So I really am thankful to God that we were able to use the modalities to the best of the things. I thank the organizing team, Dr. Mende Madam, Dr. Ajankar Sir, the organizing dynamic secretaries, Dr. Rathi Sir and Dr. Mende Sir, for giving us an opportunity to present this recent advances. Thank you.
Thank you, Bhagwat sir, for your wonderful updates. Now, questions, if any, and concluding remark by Dr. Gaurav Goenka.
Thank you, sir. Sir, first of all, definitely endoscopy, navigation, they have made surgeon's life very easy. And first of all, congratulations to you for having first brain navigation system in all of the Vidarbha Vatsalya Hospital. I thank from on the basis of IMA. Any question from audience?
No, sir.
Thank you.
Thank you. Thank you, sir.
Thank you, sir. Thank you. Thank you.
Hand over to MOC.
Thank you all. We hereby declare the end of today's session. See you tomorrow morning for round 2. Thank you, all of you. Have a good day.